Today we have gathered here for the body contouring video workshop, which is accredited by the Iaaps, and we have our dignitaries, seniors, and esteemed speakers. On this occasion, I will like to invite the President of Apraso, Dr. L.K. Mishra, to speak a few words and kickstart the video workshop. Thank you.
Good morning, respected Dr. Sandeep Sharma. He is the consultant of plastic cosmetic surgery, Vadodara. He was past president of Indian Association of Aesthetic Plastic Surgeon, Iaaps, 2021 to 22, which was organized in Goa, which is really a memorable. Those who have attended this conference, it was a really fantastic, memorable event, which I have also attended this program. Now, he is currently the chairman of International Outreach Committee of the Iaaps, with mandate to improve the profile of the Indian aesthetics plastic surgeon around the world. He is now the current visiting professor of cosmetic surgery for the Association of Plastic Surgeons of India. He is a graduate from Baroda Medical College and further trained in London, UK and Melbourne, Australia, doing an advanced aesthetic surgery under the Professor Graham Southwick. He also worked with the research unit of Professor G. Ian Taylor at the Royal Melbourne Hospital, being the lead research in the angiogens of the hand project. He travelled extensively nationally and internationally as invited faculty. It is a matter to pride that the last year he was the co-chairman of National Conference of the German Association of Aesthetic Plastic Surgeons held in Berlin in May 2023. He also led the Indian delegates to the American Aesthetic Surgery Society annual meeting held in the Vancouver in May this year. A joint meeting with the British Association of Plastic Surgeons was planned in September is planned for 2025, September, in London. So I welcome to our association, to Apraso, and to the land of Lord Jagannath, to Odisha. Sir, please come to this dais, and Dr. Jayant will hand over a bouquet for the memento for these reasons. Second, the stalwarts in the cosmetic surgery in our India, Dr. Medha Bhabe, she will be coming soon. She is just now arriving in the airport, and she will join here within 1 hour in this program. By that time, the third, the stalwarts, I don't want to describe and I don't want to tell also, he is so popular in the aesthetic surgery of India, Dr. Rajat Gupta. His contribution is immense, and he headed more than 500 members during these 4 to 5 years for this association of Iaaps. His contribution was really immense. Dr. Rajat Gupta, he is MBBS, MS, General Surgery and DNB Plastic Surgery from Maulana Azad Medical College. He is the National Gold Medalist. The fellowship he did from Spain and also from Sant Paul of Spain. He is the National Secretary, Indian Association of Aesthetic Plastic Surgeon. He is the Director and Cosmetic Plastic Surgeon at Excel Hospital, CK Birla Hospital, Skinova Clinics, Rojwak Luxury Hospitals. And he is the accreditation trainer for the national companies like Allerga, Thermal, Bbsr, Microair, and Emode Aesthetics. I request Dr. Rajat Gupta to come to the dais, and I request Dr. Sanjay Giri to have a memento for this bouquet to this Dr. Rajat Gupta for this organization. Second, just to few words of our association for the faculties. We have organized means this association started at the in the year 2011 under the guidance of our founder president, Professor Dr. Sir, and the past president, sir, and we all get together and we have initiated this program 2021. Our association also registered in 2011. Now we regularly conducting our bi-monthly meeting and we regularly conducting this seminar programs, these workshops 2013. Arun Chaudhary sir is the founder president and Dr. Ramesh sir, the past presidents. Their contributions was extremely immense and they have started this program, this our association from 2013 onwards. Now we are going regularly this program and Dr. Joyant also conducting this program since last 2 years. Hope this program will continue in future also. We also encourage this young generations to do more academies in our programs. Our unity is our strength. Long life Apraso and also Iaaps. Thank you very much. And I request the faculties, Sandeep Sharma sir, Dr. Rajat for the lamp lightning and founder president Dr. Arun sir and Ramesh sir to come to the for the lamp lighting program.
शुभं कुरुत्वा सम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः ओ दीपब्रह्मरूपस्त्वं ज्योतिषां प्रभुरव्ययः
I request Dr. Rajesh to start this program, this academic program on body contouring procedures. Thank you.
So the first topic for the morning will be how to treat grade 3 and grade 4 gynecomastia. Fourth one, how I decide. Okay, sorry. The first topic will be how I decide size of the breast implant. The speaker will be Dr. Rajat Gupta. Sir, please.
So first of all, many thanks to my senior and my very dear friend, Dr. Jayan Dash, Dr. Chaudhary sir, Dr. Sanjay Giri, Dr. Mishra sir, for having us here for this Iaaps accredited workshop. When we were conceptualizing this workshop, we decided that let's cover breasts as well along with the body contouring because that is one aspect which usually makes a huge impact on overall body shape, proportions, and he also thought it needs to be more discussed. The other request, Kuldeep. Okay, so we want this a very interactive kind of workshop. It's not that we give a just one-way lecture. I'm sure all of you would have done breast implant surgery or have seen breast implant surgery. So can I have mic pass around in the crowd? I don't want them to sleep either. So how do you decide size of breast implant? How do you decide size of breast implant? ऐसे बोल ले.
Yeah. Uh, as per the patient requirement, the size of the breast implant, and the sizer is there. We give the patient the sizer. If the patient feels that which size is good for her, then accordingly we can decide.
So basically what Dr. Kuldeep says, involve the patient in deciding the size of implant. This is very important. But what he has forgot to mention is what is the base width of the breast. The sizes may be very big. She may say, I like this size, but whether that size is suitable for that breast or not. So we will go in depth in this topic today. So can I have my slides, please? Can I have my slides, please? Yeah. So now breast implant surgery is a tricky surgery. There are certain issues in this. It's a challenging operation to perform to get consistent result. It's much, much more than making a pocket and putting in a balloon, okay? Because in this digital age, if the patient does not get what she wants, unhappy patient can have a severe impact on your cost, reputation, and practice. So basically, we want to achieve a consistent result as well as predict the result both in our eyes as well as patient eyes, so that we achieve that. So, of course, sizing is the most important to achieve such a result. So there are different parameters on how we decide the size. The volume, you can ask about the cup size of the patient, okay, so if I ask you, if someone has a B cup and she wants a D cup, what volume of implant will you use? Anybody in the crowd? So कुलदीप मैं तेरे से बार-बार इसलिए पूछना पड़ सकता है क्योंकि मेरे को तेरे नाम मालूम है. Anyone, please. Someone is B cup and they want to go to D cup. What size of implant? So basically, this is just to jolt you out that we topic. It is important if we are not able to answer this. We also need to see what is the distance between the IMF and the NAC and whether the breasts are symmetric or asymmetric and whether you need to do a different size of implants on each side to achieve that symmetry. What we want a smooth, natural looking result like these. So this is a subfacial augmentation. This is a dual plane augmentation. Now, when do you do a dual plane? When do you do a subfacial? Anybody in the crowd? I'll have to pick you up then. Ma'am, you, come. Yes, you're turning back, come. Okay, so she'll be the right person, okay. So how do you decide subfacial and dual plane? Sure. So, yeah, so basically, will that impact in your deciding the size of implant? Yeah, so this has to be taken care of as well in the mind. So some of the results basically that how you achieve the result. So basically, I divide the procedure into two parts, pre-op evaluation and the technique of surgery. We'll talk about pre-op evaluation here. I see this surgery as something in which I define the glove and construct the hand. Now when I say define the glove, the patient's own anatomy defines the glove, and I have to imagine and construct a hand to fit snugly into that glove. The hand cannot be big, hand cannot be small. that has to have the right size of implant to fit into that glove and to be able to predict that result. That's the whole game. So how do you define the glove? So you see the nipple position and you discuss with the patient. If the nipples are going sideways, they still may keep going sideways. This is important to discuss with the patient. If they want to medialize the nipple, then you will have to lateralize the implant. So all these needs to be discussed with the patient. This is part of defining the glove. What is the intermammary distance? If the intermammary distance is wide, basically breast implant surgery cannot change the footprint of the breast. It will still remain wide. If you want to create a narrow cleavage, then you will have to go for a hybrid breast augmentation and we put implant with fat, which my subsequent speaker, Dr. Medha Madam, will speak. If the NSC diameter is big, it will still remain big unless you do something about it. So this is again a part of defining the glove. Now note that this patient had a tuberous breast deformity. The inferior pole was hardly developed. And of course, NSC diameter was big. She opted for improving the tuberous deformity, of course, which we did. We also narrowed her cleavage, but we did not do anything to the NSC diameter. So this also needs to be. And of course, the IMF distance and the base diameter, which everybody knows that we need to do. Now, how do you select the implant once you have defined the glove? Of course, the dimensions like base diameter, projection, the volume, fill material, we all know fill material, silicone, the shape and the surface, all the criteria. But we'll talk about base diameter, projection, and volume. So there are 3 parameters. When we get a chart from the company, you will see that it will have 3 parameters. 1, the base diameter, 2nd is the projection, and 3rd is the volume. How do you decide all 3? Anyone, how do you decide all 3? You want to take this, doctor? So you have to decide base diameter, you have to decide volume, you have to decide projection. How will you decide that? Just with sizers, you will not get to know all these things. Okay. So basically, you do not decide all these 3. You decide only 2 of these because 3rd get automatically chosen. Now, if the base diameter is 12.5, just to give you an idea, if the base diameter of the patient is 12.5 and the patient chooses volume 300 cc, so there is only one, that is the medium profile. So you can't have base diameter and volume when you choose. The 3rd parameter gets automatically chosen by the charts. So you have to decide 2 parameters. I hope I'm able to explain. If you see the opposite, if the patient chooses 300 cc first, and that there are 300 cc's in the chart, and you measure it's 12.5 cc, again you come to the same thing. So whether you ask the patient to choose and you calculate base diameter first and then the second, or the opposite, you come to the same point. So that's an issue. We need to measure the base diameter and we need to decide the volume. The profile gets automatically chosen. Now, problem is that the measurements are not absolute. There have been recent studies which says that if you measure base diameter several times of the same patient, depending upon how you keep your caliper, there can be a difference of around 0.5 centimeters. And if you add 0.5 centimeter in each side, can go up to 1 centimeter. This makes a confusion because if your base measurement is not correct, you open a Pandora's box and there are so many implants you can choose. The second thing, if your base diameter is 12, you can still go for putting a smaller base diameter implant. There's nobody stopping you put an 11 centimeter base diameter implant with a breast of 12 centimeter, right? You cannot go big, but you can choose small. So that adds to the Pandora's box because there are so many implants which now come in that glove. So what I personally like is asking the patient to select the volume first and then look at the base diameter as a secondary parameter. How do you decide volume? Because everybody in our country, the patients who come to us are fixated with the volume. So you can show them previous patient photos, how they were similar to one patient and what different size implants can bend and how it looked like. You can use external sizers. But what I like to do is computer simulation. So in our practice standard protocol is we go through external sizers, show them so that they get an idea of what size of implant, what volume implant they're looking at. How do you measure base diameter? We do measure base diameter. Base diameter is breast width minus the skin fold thickness. We all know this. You also measure the skin stretch and keep that in your mind. Now, why this is important? Because if the skin stretchability is more than 2 centimeters, either you can do this measurement of NSE or IMF by stretching the skin or just by pulling the NSE. If the skin elasticity is more than 2 centimeters, that patient can easily accommodate high profile implant. If it is less than 2 centimeters, you will struggle to put a very high profile implant. So keep that in mind. Don't discuss with this patient, keep that all these points in your mind and write it on a piece of paper when you are deciding an implant. And how do you predict once you do that? So we do this 3D simulation. So there is a special software in which we take images of the patient and so audio is not working. So then we put different sizes of implants and show to the patient on the 3D image. Yeah, now it's come. So remember, patient has already chosen the external sizes, and then she's also deciding on computer simulation. So you involve the patient into the decision making as well as her partner, whether they want a bigger or smaller. You can also show them whether the breast has asymmetries. This helps the patient to be involved in the decision making so that the patient says, yes, I chose 280 cc, and not the doctor chose 280 cc. And at the same time, during this is happening, you can fix the base diameter in the software so that it does not show any implant which has a wider base diameter. You can also show different sizes together, one size big, one side big, smaller. You can also show, depending upon subfacial or dual plane as we talked about. You can also show how the breast will look like when the patient animates, when she runs around, how it looks when she wears the clothes. So all this is possible through this software. So now what I'm doing is putting different sizes of implants so she can actually see. So what basically we are doing is, we have fixated our patient on the decision of volume, cleverly fixing the base diameter also along with it. So you can show the impact. I can't fast forward this. And the software also has different choices of exact implant brand, whether you choose Motiva, Sebin, Polytech, Silimed, whatever. All these implant brands and their exact catalog is there, so you can actually show them what exact model implant you are going to put in it. So, and then you can make them wear different kinds of clothes to show them how it's going to look like so that they get a real perspective. So once they have fixated with the volume, you can show how it will look like when they walk around, when they lie down, the breast will fall. All that can be shown. So, and we ask them to wear a 3D glasses, and they see them live on the immersion kind of feeling. So she can go down and look and also look at the mirror. Okay. So once you hit the volume and fix the base diameter, your chosen implant is there in front of you. So you have fixed the base diameter, you have asked the patient to decide the volume, the answer is in front of you, what kind of implant. So basically what it does is, this trick does is, you have involved the patient into decision making of the size of implant, and not only the volume implant, also the exact implant what going to use. So, and you are able to predict several videos like this in which we have shown that the 3D simulated result actually matches. We have shown this patient that she had a slight breast sagging, it will keep sagging. So basically it helps us defining the glove. We construct a hand for that glove involving the patient in the decision making to get a predictable and consistent result, giving us happier patients. Understand, happier patients is the most important keyword. Sometimes you may not have a great result, but having a happy patient is more important than having a great result in aesthetic practice. So if you can manage that, so this trick of measuring the volume and sizing implant is important in getting a happy patient. Thank you.
Okay, after the very dynamic presentation by Dr. About the breast implants, the second topic is by Dr. Sandeep Sharma, breast reduction surgery, markings to execution.
Good morning, everybody. I'd like to thank Dr. Jain Dash for organizing this dashing conference, and I'm happy to be invited here. My first visit to Odisha here, and nice to see familiar faces. Nice to meet Dr. Vibhuti Nayak again, and introduction to all my colleagues here, and my namaskar to Dr. Balyar Singh, sir. Namaste. Hi, I'm Dr. Amrish, how are you? Namaste was to the senior, sir. So, yeah. Ready? So, while this is being set up, I just want to have a profile of who are here so far. How many PGs are there? The 8 of you are PGs, right? There? Okay. And the others are all, how many are in the first 5 years of practice? And 5 to 10 years of practice? Okay, yeah. And how many do breast reduction at least once a month? Once in 6 months? Right, okay. So I have an idea as to at what I should pace it to, yeah. So I'll be talking about reduction mammoplasty, marking to execution. So what we want to is to achieve this. How do we go about doing this? So it may be a large resection, which is the usual case in our cases, or it may be a very small resection, or it can be a moderate resection. So it's important to have a clear plan for each of these cases. So as we before we start our marking, we've got to know what is the fundamental concept in breast reduction. So we've got to look at the breast in three segments. The cover, which is the skin envelope, the content, which is the glandular and fatty tissue, and the keystone area, which is the nipple areolar complex. So we have to be looking at addressing each of these three differently, and that decides the technique which we will use. So all the techniques address this. So we have to have a resection pattern, we have to have a parenchymal resection pattern, and we've got to have a pedicle design that we decide. So for the cover, it may be the access point on the skin, it may be periareolar only. If it's a very small resection, it may be vertical. If it's a bigger resection, or if it's a very large resection, which is a common thing in our Indian scenario, it would be an inverted T resection. Alternatively, there may be a compromise where we have a vertical with a short horizontal scar. So, and the pedicle may be any of these. My preferred ones are the medial pedicle and the superior pedicle, the inferior, the supramedial, and the central mound. These are my preferred pedicles. So, how do you mark it? You might mark it by a Weiss pattern, which I'll show on the video. And also there's short scar techniques, which were popularized by Lessus and then Madeleine Lizor, and subsequently made very popular by Paul Findlay. The evolution of techniques, again, the idea is to shorten the scars, because the scars on the breast are not really something very desirable by patients. But as you eliminate the scars, you want to also reduce the risk of bottoming out. So there is a steep learning curve to breast reduction, and that's why we have fewer people doing breast reduction. Okay, so this is how we go about it. The first thing we do is patient assessment. Now, this is the patient that we have. The first thing you see is psychological, as to what is the patient's expectation of the outcome, what should be the size, and what should be the shape. So once we are clear that the patient understands the outcome to be expected, we start with the physical examination, where you see the upper breast border, the upper breast fullness, the lateral breast contours, and the level of the inframammary fold. And also very important at this stage to determine the symmetry or the asymmetry between the two breasts. And that should be noted down specifically. Now, coming to marking, you mark the midline, the mid-mammary line, the upper breast border, and the inframammary fold. Why the emphasis on the upper breast border is that because every woman's side frame is different for the chest. So the breast sits at the level around, or the nipple is around 8 to 10 centimeters below the upper breast border. Because a patient will be very tall, so markings from the clavicle may not be the right thing. So there we are. So the new nipple position is decided based upon the upper breast border, the mid-humeral line, and the level of the IMF or the inframammary fold. And then we mark the medial and lateral pillars, which decides the amount of resection that's going to be done. Right. Oh, sorry, I'm actually going back. And then we decide the areolar opening, which is a horizontal oval. Yeah, so having shown these things, I have a chart in which I measure all these distances so that I have a clear idea in terms of geometry as to how much resection I'm going to be doing. And then I infiltrate. I'm showing you these points so that it will be easier for you to follow it on the video. And then I infiltrate with xylocaine adrenaline and avoid the pedicle and some parts of the incision margin. After the infiltration, I do the scoring. And then I deepithelize the pedicle. In this case, I've marked the supromedial pedicle, so I deepithelize that, and then I do the parenchymal resection. I do it as a C-shaped thing around the pedicle which we have designed. And then I weigh the resection on one side to be sure that I match it up to the excision on the other side. That's where the importance of the symmetry comes into play. If we know that one breast is bigger than the other, so accordingly we should be resecting more on the side which is bigger. So that's sort of how, the deepithelization followed by the raising of the pedicle, and once we have decided the volume required, we resect the amount of tissue we would want to. And that's the same being done on the other side. So that's the pedicle design. And then we close the pillars, and this may be closed vertically if it's a vertical pedicle, a vertical pattern of resection, or it can be closed in a T-section. So here I would do only 2 layers of closure. One is the deep dermis, and then the skin in a subcuticular fashion. So that's a vertical closure, and this is an inverted T closure. Yeah, so then I put a dressing on. I put a dynaplast which is elasticated, so it has some degree of stretch, but still holds the breast pretty much in position. I leave the dressing there for 5 to 7 days, and once the patient comes back for the first dressing on the 5th or 7th day, get the patient to wear the new size brazier. I now have to. I'll go on the post-op later. Let me show you the. Can I get my thing on the screen? हाँ? वीडियो है? वीडियो दिखाना? हाँ? वो एक स्लाइड पे embedded था, नहीं प्ले हुआ, इसलिए मैंने ये वीडियो ले लिया. Yeah, the audio is not working on this. So this is a 32-year-old lady with okay. That's the upper breast border being marked. And so that's 10 centimeters from the upper breast border. You mark the point of the nipple, and then you mark the areola. So the areolar opening is marked as a horizontal oval. and this is marking the wedge. So you hold the breast in position and twist it, keeping the nipple in the center, nipple point, and from the edge of the areola, mark down the vertical limb, a 5 centimeter, that's the point, 5 centimeters down. So that will be the vertical of the breast reduction, the vertical scar. And that's marking the supromedial pedicle. So from the edge of the skin, it's approximately 12 centimeters, I think. And that's marking on the other side. And the base of the pedicle is around 8 centimeters. And so I've marked out both the the vertical scar only, as well as if I were to do an inverted T. And that is marking the. So we're infiltrating the parenchyma. So I take a spinal needle and I inject. And that's sort of first, now I'm scoring all around. So that's the pedicle score, and now I'm de-epithelializing the pedicle, as you can see. And now I'm resecting. I make sure that first I raise the skin flaps. So that's the lateral skin flap being raised. And then I go under, and that's I'm separating the breast tissue from just over the pectoral fascia. So there you can see the white pectoral fascia there. The aim is not to get into the muscle, and that has a lot of bearing on the post-operative pain if you do not touch the muscle at all. And then next the inferior incision is deepened. Go on again to the pectoral fascia, or actually keep a layer of tissue over the pectoral fascia. So I've pretty much raised the full breast medially as a pedicle. So now that's the medial side being, and then finally I separate the excision margin from the excision specimen from the pedicle. In here you've got to be very careful that you keep your resection vertical. You do not want to undermine it. So that's the specimen resected, and that's the supromedial pedicle that you have. That's what is sitting in. So you have a fair idea about the three-dimensionality of the resection. Then you weight. In this case, it was around a bit under 800 grams. So again, all the flaps are like a wedge, so thin at the margin, and thicker as you go. And then key sutures are taken. In the interest of time, sometimes you can take staples, so you can staple everything together, and then you can keep replacing that with absorbable. I use monocryl 30. So these are subdermal sutures. So when you're doing the second breast, you want to keep an eye on the first so that you have symmetry. So here I'm describing why it's important to, how would you decide the point of the vertical margin going down, because it has to be symmetrical to the opposite side. So that's, so if you would handle the tissues gently, if you especially handle the subdermis and dermis gently, you do get very good scars. And to me, the shape is more important than just a short scar. So I would rather have a nicely shaped breast with no dog ears than have only a vertical scar but have dog ears, and with just, because no patients in our scenario want to come back even for a small revision or correction. So you got to make sure that you got only one chance, and that one chance is all you get to get a good result. So there, so that's the patient on the 5th day, and now this is the. So you're putting on a sports bra, which is a total contact bra, which gives us support 24/7.
The presentation is by Dr. Rajat Gupta, auto-augmentation mastopexy.
So, auto-augmentation mastopexy. As the name suggests, this is a procedure in which we are not using any external product, whether it's implant or even fat. We are actually just remodifying and remodeling the existing breast tissue which has sagged to make a nice shape of the breast. This is auto-augmentation mastopexy. Not reducing any size, just lifting the breast up. So the aim is lifting up the sagging breast, lifting up the nipple-areolar complex, of course, and ensuring that the patient has a nice upper pole fullness as she would have if this patient would have undergone a breast implant surgery. And of course, getting a beautiful cleavage is essential part in modern breast aesthetic surgery. We want a result like this. So one of our results, you see the breast is lifted up, she has a nice upper pole fullness and a nice cleavage. If you just see the patient on the right, you would think that this patient has had an implant. But no, this is not implant, this is auto-augmentation mastopexy. So you want a result like this even if a woman is wearing a clothes these days without any supportive bra or any support, the result of the breast shape should look like this. Nice upper pole fullness, nice cleavage. Another before and after. So we get a lot of patients send pictures like this. You want a nice result, a natural looking result without sagging of breasts, so that they can wear clothes without supportive bra. So how do you do this procedure? So basically we start with marking. I'm showing you marking in a big elaborate breast, although she had a reduction, but then we will also show you in a sagging breast only without reduction. This is basically what we call as a two-flap technique. So you mark the new NAC position, which is opposite to the IMF. I use a scale to mark a 16 centimeter circumference of the new areola. So the scale is 15 centimeter, slight surface before and after, it makes it almost 16. So you mark and then open up of 5 centimeters. So this opening up depends upon how much sagging you have, how much lift you need to be resected. And then medialize and lateralize the breast and join the dots at the breast meridian. Now, join these lateral and medial pillars around 3 to 4 centimeters above the IMF, because remember in this surgery we will also be raising the IMF. Now, once you have marked the skin excision, what I'm doing is, this is a superior pole, not superior medial, this is a superior pole. This is marking freehand NAC. So this is superior pole and this is the inferior pole, inferior flap. So there are two flap technique. All the dotted green ones will be deepithelialized. So flap will take the NAC. The second flap, which I'm marking, again will be deepithelialized, and this tissue will be remodeled to get an upper pole fullness. So you'll be making 2 flaps. So this is the which I'll show you in the surgery. Flap 1 and flap 2. So this is 2 flap concept. Flap 1 takes the NAC, the flap 2 takes the breast mount to the upper pole. So this is how the patient looks like. She's falling apart on the table when she's lying down. You depithelize the skin. So you flap, just removing the skin as an FTG. So basically, once you're depithelized, and you can see the line which divides my flap into two. I'm marking the 12, 3, 6 at the NAC complex, which helps me get suture later on. And between flap 1 and 2, you go perpendicularly to the pectoral fascia. No undermining. This is very important, as Dr. Sandeep also explained during his technique. No undermining of the flaps. Just go perpendicularly and make the flaps 1 and 2. So you see, I'm going perpendicularly till the pectoral fascia. And only once I see the pectoral fascia, I will start raising the flaps. So you see, once I've reached the pectoral fascia, I will the superior pole up to the second intercostal. This is I'm making flap now. आपका माइक भी चल बंद रहा है. So this is raising the inferior flap and then freeing the flap from the lateral skin, inferior skin, as well as the medial skin. So basically, this is the amount of tissue you would have excised had you been doing a breast reduction. So you make a flap out of it and use it to auto augment. I'll show you. So this is raising the flap laterally and inferiorly. I keep the skin thickness of around half a centimeter and take all the tissue in my flap. So this is my inferior flap, which is now freed from all the sides. Then I'm dissecting the superior pedicle, which remember has the NAC, and making the pocket up to the second intercostal space. So you see, I'm dissecting above the pectoral fascia and going up, as well as medially. Not laterally, medially, making a pocket in which I can suture my inferior flap. So the inferior flaps get sutured, and then you close the lateral and the medial pillars. So I use permanent suture. This shows Ethibond. I've moved to now nylon number 1, and I sutured the dermis of the inferior flap with the pectoral fascia opposite the second intercostal space. So basically, I have mobilized all this tissue and taken it in the upper pole. Suture with permanent sutures so that it gets fixed. There are some surgeons who say absorbable is also fine, but I don't want my tissue to fall and bottom out, so I use permanent sutures. And there is ample evidence which says permanent sutures in the breast does not make a difference. So the flap is sutured. So I use 3 to 4 sutures to suture this flap nicely. Now, earlier, Dr. Ruthgraf described, and I also used to do, is before suturing the flap, I would make a pectoralis muscle sling and take this flap beneath the sling. So this is also a technique which you can do if you are really worried about bottoming out. So once you have made a sling of pectoralis muscle, basically this is where I'm closing the pectoralis muscle after I made the sling. This sling is of around 1.5 to 2 centimeter wide and around 10 centimeter long, and then you put the flap beneath the sling. It is said to prevent bottoming out further. And then you close the lateral and medial pillars as you would do normally. So basically what you have done is you have taken the flap above, made a flap out of the tissue you would have excised in breast reduction, taken it above on the upper pole. The NAC moves as the superior pedicle, and then you close as you would close. I take interrupted sutures 12, 6, 9, 3, and then in between as well, and then use a subcuticular monocryl to close the nipple iliac complex. Remove the dog ear, whatever you have. You can see even on the the upper mount, the cleavage. So this is how you begin. This is the final result. Good lifting of the breast. Showing you some results. You can see the upper pole fullness, the cleavage, and how much breast lift you can achieve with this technique. This is auto-augmentation mastopexy for you. You can see the result in 3 dimension, how nice the upper pole fullness in the cleavage. It looks like the patient has an implant. That is the kind of fullness you can achieve. So, now these are some results. So, another result. Thank you. Dr. Jayant, shall I continue with that? Where is Dr. Jayant? Shall I continue? So Dr. Medha Bhave has still not landed. Her flight got delayed probably. So Dr. Jayant has asked me to cover hybrid breast augmentation as well for you. Oh, okay. So I will take the liberty of covering this topic as well. Yeah, please, Kuldeep. मैंने नहीं पूछा तो तू पूछेगा. हाँ, ठीक है. हाँ, बोल कुलदीप.
Sir, how do you choose the patients for auto-augmentation mastopexy?
So, if the patient says that I want a breast lift and no reduction, if the patient says that she really wants a nice upper pole fullness, you will have patients say, Doc, I want a lift and I don't want an increase in size, but I found that implant kind of look. If the patient says that she wants a very narrow cleavage, then these are the candidates for auto-augmentation mastopexy. Yeah.
Did you face any difficulty of having flap necrosis? Because you are pulling through that tunnel and this is another adipofascial flap. How robust is the vascularity?
So, moving to hybrid breast augmentation. So, I want all your attention, please. So, what do women want when they come to us for breast augmentation surgery? They want results like these, right? So, it is not just big breasts. It is a shapely breast with a nice cleavage. This is very important. They want a breast shape like this, that even without a bra, it falls naturally, has a teardrop, and has a nice cleavage. What do men want? This is important, right? Breast augmentation is a procedure for women, but also men would want the breast to look nice. So what do men want? So there was a survey done by Ask Men kind of magazine, and they said that even the men consider the shape of the breast more important. How it looks natural, how the cleavage is. That's very important when we are talking about breast augmentation surgery. I'll show you 3 results, and I want all of you to tell me which breast looks nice to you. These all are my patients, all had 275cc implants, so very similar. This is breast 1, breast 2, okay? Please look carefully. breast 3. Which one? I'll make it easier for you. Case 1, case 2, case 3. All those who think it's case 1, please raise your hands. 1, 2, 3, okay. 4, 5, okay. All those who think it's case 2, okay. Mostly men, some women. Case 3, none. So what is the difference? Why do you think that a lot of people have thought that case 2 looks nice? Because it looks natural. Now, of course, none of you have felt the patient. But it looks that it feels natural. Right? You go back to this. It looks natural, and it looks that it would feel natural. Now, even with the 2D image, this is important, that nobody has felt it, but it feels that it will feel natural. So, breast implant surgery, in my previous talk, as I said, cannot change the footprint of the breast. But you can by doing a hybrid breast augmentation. So you put an implant in the breast to narrow the cleavage and give a nice smooth curve in the upper pole. You can put fat, which so that most of the edges of the implant are covered by fat. It gives a natural slope rather than a steep slope, and it gives a natural look and feel to the breast. So this is how you mark. Standard breast augmentation markings. You mark the midline, you mark the IMF. I make usually an incision of around 3 to 3.5 centimeters for incision. So the first point I mark from the median edge of the nipple. My incision will be 1/3 medial to this and 2/3 lateral to this. So my 3.5, around 1.5 is medial to that point which I marked, and 2/3 lateral. And then, depending upon the implant base diameter, using a Werner caliper, I mark the edges of dissection, the upper, the lateral, and the medial. Now, make sure, this is important, I've seen people making mistakes, that the medial edge of both sides dissected is similar. You don't want one breast implant to go more medial than the other. And then, the medial and the superior pole, if you want, can be marked like this, in which my fat will be transferred. Okay? So, subfacial technique, I'll show you. In dual plane, it's very easy. People don't fear because the implant is beneath the muscle and you put an implant, you put the fat. I'll show you in subfacial also, it's easy if you are in the right plane. So making an incision, I use a monopolar cautery to open the incision, dissect again perpendicularly till the pectoral fascia, and then start undermining. Headlight always helps in this surgery. It's a big boon. Do a prospective hemostasis. Make sure there is no bleeding. It reduces the chances of capsular contracture. So all dissection is done via monopolar cautery. So your assistant's steady hands to retract the breast is very important, or you can also retract with your left hand. And if you can see, what I've done is extension of my cautery tip. It's a long cautery tip so that I can dissect with the cautery going superiorly and laterally very easily. So once we have done that, you can make sure that it's a good hemostasis. This is a lighted retractor. This retractor has a light in it. Then using a triple antibiotic wash to wash the cavity. Then I'm suturing the inferior skin scarpa's fascia to the pectoral fascia so that the implant does not bottom out. Important step which many people forget during the breast implant surgery. Washing the implant, opening the implant, transferring the implant into the funnel. We always use a no-touch technique. Kuldeep, how did you decide the implant size? We decided in the first talk, right? So same size, okay. So this implant is then now transferred to the breast without any touch. So when you say touch, not only your glove touch, but more importantly, when that implant touches with the patient's skin, is something which we should be wary of, because that is the part which said that has a lot of commensals and can get touch. What you also, I want you to notice, is coverage of nipple with nipple shields. This is important because this step is shown to prevent capsular contracture. And then putting an implant, it just takes 10 seconds and the implant is gone. And then closing it in layers. So I use monocryl to close. So once we have done that, then we move to fat grafting. Scar is hardly visible, we know that, so I'll not show dual plane. Now coming to hybrid, so once we have put the implant, if you can see, there is a reasonable gap between the breast. And we put fat grafting, we put fat in the medial pole in subcutaneous plane. So basically, just to show you that the footprint of the breast cannot change by implant, but you can medialize the breast by putting the fat. I'm sorry, the software in this, I cannot forward my videos, so that's the limitation. So this is how another patient, you can see how wide the breast is, and we'll start transferring the fat. So you make a small needle prick with an 18 gauge needle, and with 1.2 mm curved cannula, I go in and put in the fat in the medial pole in the mark. Now remember, you're going in the subcutaneous plane, that is beneath the skin and above the breast tissue. This is where you are putting the fat. Your implant is beneath the breast tissue, so you are safe. So you don't need to worry about, just need to be careful about. So curved cannula helps us in achieving and giving a uniform. So you see, one side I have transferred the fat, and how that side slope looks like, and opposite side is still left. So you can see it gives you a nice change in shape and narrows the cleavage. And then we'll go in and do the opposite side as well. You can also use it to cover the upper pole of the breast, so that even when the skin lifts from the clavicle to the breast, it's not a steep lift, it's a gentle curve. And this is how the result will look like on table. Instead of a U-shaped cleavage, it will become a V-shaped cleavage. So this is hybrid breast augmentation, gives a natural looking result. I'll show you some of our result, and you'll see how we have medialized the breast and narrowed the cleavage. Another patient, another patient, another patient, another patient. You see how natural it looks, how it looks that it would feel natural as well. Patient, another patient. This is the same patient which I showed you earlier in different profile views. Another tuberous breast correction. You know, another advantage is you take out fat. So although she was not fat, but you have also helped her contour her tummy. And you see, many women will not talk about their breast surgeries. But when their tummy gets contoured, they do talk about it. So you get an added advantage. You see, even this thin patient, we could give her a nice contoured tummy. Instead of flat tummy, she has gotten out an athletic tummy. So this is her tummy shape. So even the flattest of patient would give you enough fat and give you an opportunity, so that when they go to gym or do some on beach, their tummy shape looks good, and then they talk about your work to their friends. Another patient, thank you.
I'm just leading up to the panel discussion. So we discussed about the operative technique. And so post-operatively, I usually do not put drains. I spend some time making sure that it is dry, and then I suture. And the patient usually goes home the same day. And as I said, he come back for follow-up on the 5th day, and where I fit them into the new size brazier. and they can return to work in around 1 or 2 weeks, or sorry, return routine work, home work in 1 or 2 weeks, and return to work in 2 or 3 weeks' time. So some tips are, as I said, leave some fascia, leave some fat under the skin, do not take too many sutures. The more sutures you take, more you're going to affect the blood circulation. The idea is to keep everything together and let the healing take place naturally. So again, these are sort of no tension closure, no drains, no deep sutures, very few dermal sutures. Okay, so now in summary, for small to moderate reductions, I do a vertical scar technique. For moderate to large reductions, I do an inverted T scar. And as to the pedicle, for small reductions, I do a superior pedicle, because I feel that the superior pedicle, everything what you leave back is on the top, so you have a good upper pole fullness naturally. For moderate to large, I do a supromedial, because then you can get a good cleavage as well. So if there's going to be some volume, it might as well be on the top and on the medial side rather than, so resect on that. And for gigantomastia, I prefer to use the inferior pedicle, because I find that that is the most robust flap of all of them. So you can really have a narrow pedicle of around 10 centimeters and a very long pedicle of even like 20, 25 centimeters and still get a good survival. I haven't had to use a free nipple graft at all. Just plan it well and you can do things with the pedicle, choice of pedicles. Okay, so now the last thing is, the tips I say is always critically analyze your results. In looking at the few number of cases that you do, so basically you people have to be giving good results by doing very little. So you have to be very, very, think it out and not, and have a good plan every time you do the procedure. So again, you should be critical, find out what you didn't do right, so that the next time you can correct it, and never overpromise, right? And never promise that it's going to look like a youthful breast. It is not. Okay, and the last thing, do not compromise on the cosmesis. So even if it means giving a bigger scar, do it, but have a well-shaped breast. And do remember that breast reduction is one of the surgeries with the highest complication rate. Almost, if you add minor and major complications, 50% patients have some complication or the other. So you really have to be very, very a fine surgeon to be able to give a good result. And don't hesitate to seek expert or help, especially with an organized, with an experienced colleague. So breast is a symbol of femininity, so it is onus is on us not to mess it up. So never to take breast reduction surgery lightly. Okay. Yeah. So now coming to the panel discussion was on what different techniques do we have and what one do you prefer? So if you could start with you, sir, first. What is your preferred technique of breast reduction? And if you have, I'll point out what points to ensure. Yeah, so these are the points which you talk about. Which in your case is the popular one? So if you could tell me so we can...
First, let me compliment you. The video that you showed, the result you showed was excellent. The shape of the breast.
Mic this.
Yeah, let me compliment the case that you showed. The result was excellent. Absolutely hemispherical breast with exact nipple areola complex, the ideal way to do reduction. Breast reduction, even though I am a panelist, I am not a very regular surgeon doing breast reduction. Maybe I do about 5 or 6 a year, maybe 8 or so. Sure. My most common technique over last few years is supromedial. I have experience with superior pedicle, inferior pedicle, even free nipple areola graft, but right now I get more predictable results with the supromedial technique.
Yeah, and what are the typical indications you get for your breast reduction cases?
Yeah, indications.
Can you hear me? Can you hear me?
Many patients, but the breast size is less, they are not happy with the size. That's one indication. But in addition, there are many who have back backache, and backache is another common problem that they have, and they are not happy with the size. These are the two most common indications that I have got over the years.
Right. In the Western countries, if an orthopedic surgeon certifies that the backache is because of breast size, they can get mediclaim from it as well. So that's sort of important for you to know, because if somebody else is paying, people are willing to get surgery done in our country. So we should know that as an association, you guys can try to see that we can.
Is it available in our country now?
It's up to the insurance companies, so we have to be able to convince them. Yeah. Anything else you want to add, madam?
In indications, nowadays that the girls are wearing jeans and tops which are tight fitting, so the girls are not very comfortable, and also the excess size causes the movement of the breast, so they are not very comfortable. So even it's not must that very big size girls only come. Even the moderate size girls, breast size girls, they also come for the reductions now.
Yeah, true. It's more got to do with proportion. So the breast may not be per se very big, but if the girl is slim, then that also is a burden on her, and the clothes then don't match. So they tend to want to get that done. So yeah, it's a question of actually increasing awareness in society that this this is something which can be done, and it makes a big difference in their quality of life by getting this reduction done. Yeah. And sir, Dr. Sanjay, anything to add?
In our government setup, we are also getting these macromastia cases only, these large size breasts, whatever are told. And we usually prefer the supramendial technique. But the young patients which usually like to go to the private scenarios, we got like 2-3, but we do not know what should be told to them. But still then, we prefer only supramendial technique. The another thing, sir, you have written about the contraindications.
Right.
So in large breasts, and whatever the contraindications, just usually follow it up. Sir, what you prefer, I would ask.
See, for me, the contraindication is patient psychology, patient's understanding of the procedure, what she is signing up for, what she will get. They may not end up being happy with the size. If you are an occasional surgeon and the shape may not be absolutely perfect, which is understandable, and then they should not create a problem that you have messed up with my breast, because there's no going back with the breast. And subsequently, I've known of girls or ladies then becoming very kind of socially awkward, and then they blame everything on the surgeon. So that is something which we should be very aware of, that what size we are going to give them. There may be some difference in shape, and there can be some complications. When we come to the complication panel, there can be very, very bad complications as well. So it is important to explain to them that all this is possible. So to me, if a patient does not understand that, we should not be embarking on doing this. And the other contraindication obviously is if there is skin infection. Many times it is missed because we don't examine an OPD, especially busy OPD, and then in the OT, the nurse will have prepped everything with a betadine, so you don't see that there was infection. So that's sort of important, that that to me is a contraindication. Other than that, there is really no contraindication. The size and shape is not a contraindication.
So I have a question. Very common question that the parents ask is, what will be the effect of reduction on the breastfeeding later on, because unmarried girls are coming and all. What is your take on it?
Yeah, see, when you counsel for breast reduction, there are a few things which you have to always mention, even if they don't ask. And that is one of the questions which should always be told before. Number one thing is that the size of the breast. Gigantomastia, even naturally without surgery, many of them do not breastfeed. 30 to 50% is documented in literature that gigantomastia people cannot breastfeed. So they could be well in that category. So that has to be explained to the person, that especially if it is an nulliparous woman, that you may not breastfeed anyway. So then don't blame the reduction. Number one. Number two is also depends upon the technique you do, because we do keep some ducts or a full system of lactiferous duct intact. There is a high possibility of them being able to breastfeed. But still, to be on the safer side, you only tend to say that only 30 to 50% can breastfeed, others may not. So that's sort of, we're basically safeguarding ourselves, because most people will still go ahead with the surgery, because nulliparous woman going in for surgery is basically because of some physical discomfort which is causing the problem. Yeah. So that is one thing. The second thing is what you talk about, the scar. You know, that there are going to be these scars on the breast, and they should be understanding about the fact that this is going to happen, right? Yeah.
Another thing is some patients, they want reduction, but they don't want scar. So what is your experience with liposuction in such patients?
As I keep, many of my colleagues don't agree, but I still feel that scar is a reality if you want to have a good shaped breast. And we are going to be operating on people under 50, and today even 50 is the new 30 in that sense. Women at age of 50 are also extremely fit, and they have a lifestyle of what used to be in the 30s in the past. So what I'm trying to say is that all of them want good shaped breasts. So a good handling, you can give decent scars. I'm not saying the scars will totally fade away, but you can give decent scars. So you should never promise a good breast reduction without them accepting a scar. Because if you empty the bag of the breast with liposuction and do not do the tightening, she's going to be good in a bra, but the minute she takes off the bra, she's going to feel like an old woman. So anybody, is not going to like that under the age of 50. So that's my take.
So as you said, 50 is new 30. So what is the experience with the circumarular mastopexy if we do the, is it possible? Because then there will be no scar also.
See, circumarular mastopexy is actually looks very good on theory. Number one, you cannot do a big reduction with circumarular mastopexy. Like you are doing 200 to 400 grams, which is nothing as far as our context is concerned. And secondly, even in that, because you are doing a round, circulage suture and everything, still the areola tends to spread. So you get a very poor scar periareolar, so which is also not acceptable. So I don't think that scar is a worry when you are counseling a patient for a breast reduction. So you have to get their mind and thought process away from scar and into the cosmesis in the outcome. So my take is, first tell them, how are you feeling now? How good are you now? So let's talk about today. And then you say, are you going to be better off or no? I can assure you that you're going to be better off by 80% at least. So do you want to discuss the 80% or you want to talk about the 10 or 20%? So if they can get that across, that is fine, because if they're going to discuss scar, it is a fruitless discussion.
Another thing Dr. Rajat Sama also said about happy patients.
Right.
Actually, it's very difficult to know which patients will be happy, which patients will be unhappy. But there are some patients, I have some patients who had reimplantation, failed reimplantations, they have come back with gifts.
Yeah.
And there are patients who have had excellent results but little deranged function, and they're extremely complaining and unhappy. So it's not actually the result which determines happiness. I think it's the psychological state of the mind which determines the happiness. And if we don't understand that, in all the aesthetic cases, we can be in real trouble.
True. I think I'll forward that link to you. I had given an interview on Economic Times. And after my interview, they had, my quote they put was that we are surgeons of the mind. Basically, because whatever we do, ultimately make the patient feel happy. So whether the patient and then I'm happy or not, that dictates our outcomes. Our outcomes are happiness. And yes, you're right. There are two things. One is you have to see what kind of patient that is. Is it inherently, that unhappy, complaining kind of person, or is the reality is a problem which is keeping them unhappy? So those, and where do we fit in our attitude and approach to the patient? So keeping the patient on site makes a big difference.
Yeah, some patients you are during the initial consultation, this is a problematic patient you can avoid, but some patients, they're very, very cool at the time of discussion, and only after you have finished the surgery, this is not correct, this is what I didn't want. They are the problematic ones.
True. Yeah.
And then about the software, like in augmentation, you have beautiful software, this is the implant, this is the foot size, this is the result that you can get. In reduction, do you have such softwares?
See, again, I think ultimately plastic surgery is a lot about artistry. And we have to have developed, a keen eye as to what we are capable of, both in terms of artistry and our ability. So when you are doing occasional surgeries, you cannot be investing in softwares and things. So that discussion, you got to decide if you're early in your career or if you've got less cases, you cannot invest in that procedure. So you got to trust your judgment and your technique to be able to give a good outcome. That's how I would see it. But in breast reduction, I don't think there is a software.
No, there are patients who come and demand. Maybe they might have gone to Delhi and consulted Dr. Gupta and they have seen the software. They will ask you what will be the look. Then you can say that.
So then you should tell them that Dr. Gupta's dressings I do over here. So go and get it done over there.
There are patients who
Yeah,
demand
there are
actually, they want
patients
to
there.
see.
But the thing is, sir, many of these patients are anyway they're not going to get converted to surgery. As I said, you got to dictate the conversation and the consultation. Like as the ma'am was saying, if you start talking about scars, that person will never get the breast reduction done. But if you talk about outcomes, they may. So many people will come to me and they will ask you, आपके पास वेजर है? मैं आपको वेजर चाहिए कि आउटकम चाहिए? वेजर चाहिए तो मैं आप भाड़े पे दे देंगे आपको, आप कर लेना जो करना है. So that patient is never going to get convinced. But somebody who says I want a good outcome, that is the person to talk to.
Sir, here I have a question.
This software also does breast reduction and breast lift. Although I don't like it, because as sir said, breast reduction and lift is much more artistry, and that cannot be captured by any software. So for breast reduction, breast lift, even Dr. Gupta in Delhi does not do 3D simulation.
Yeah, that's what I was about to ask, that we show to the patient that this will be the result in breast reduction, but if we do not get it, it's a double-edged sword, I feel so. That
Madam, it's about confidence. Don't worry. See, the thing is, your body language should be confident. I'll do what is best for you. Because no two scars also can be assured, same way. So my typical thing is just say, okay, we are three of us. If I had to take stitches on all three, the scar will be different. I can't, my effort will be same. That is all I can say. My effort is 100%.
Body language and confidence is dependent on how many cases you have done. That's also, if you have done 1 or 2 cases, however you talk, the patient will be able to pick up.
Sir, when I say confidence, means your confidence in your ability, not that bravado kind of fake confidence. I always say, to fool somebody else, first you have to fool yourself. So you want to convince somebody you are very good, first you have to convince yourself you are very good. And that conviction should not be, you have to be honest with yourself. So depending on that, so you lay it out to the people. See, we've all done our first cases, right? I have never hidden to a patient, and there are people who will come and say, Doctor Sahab, humko aapke paas hi karane ka hai. Humko pata hai aap naye ho, and we are happy with that. And there's some people who say, oh, naye ho, I don't want to see you only. I'll come to you after 10 years. So everybody has their own choices. So there is somebody for each of us, so not to worry. So, yeah. Any questions from the youngsters? Because then we have to wind up this session. We are running very late. Yes, sir.
While doing this cosmetic part, should we do the counseling for future breast cancer incidents? How much in the long-term follow-up? Because suppose the lactation will not be there, what will be the incident? Should we counsel them about it? Because gradually the breast cancer incidence is very high.
I got your point. I always will send my breast reduction resection specimen for histopathology. Always. No. So once we have done a histopathology, so that patient is actually way better than even a mammogram, because they've had a histopathology proof that there is no sort of pre-malignant condition either. So in that sense, this patient is better off than compared to general population.
Sir, one question, sir, regarding breast. One literature recently I have gone through. This literature, this breast enlargement is mostly due to this estrogen's sensitivity. So he has, in this literature he has given clomiphene citrate for 6 months. Followed by, he has noticed that 50% of the breast was reduced by this clomiphene citrate. Then he was doing this breast reductions. And the results are excellent after this clomiphene citrate. I am asking about you, what is your suggestion, what is your view regarding this clomiphene citrate followed by breast reductions? Medical treatment followed by surgical resections.
Okay.
Have you any ideas regarding clomiphene citrate? Most of the young unmarried ladies, they want for medical treatment rather than the surgical treatment due to this oversize. So clomiphene citrate for 6 months followed by reduction. Any suggestions and any view?
No, I have no personal opinion on this, but I tend to, whenever I have an issue, I tend to consult. There are a couple of good endocrinologists in my city who I talk to.
Sure.
So, but I take your point. I will check up on that and revert to you.
Thank you, sir.
Yeah.
Dr. Sharma, it was a brainstorming with all the stalwarts of cosmetic surgery. In fact, you are welcome to the land of Jagannath and can visit Jagannath during the Bauda Jatra on Monday.
Yeah.
Anyway, if you stay here. I have a very practical question which I have faced in cosmetic surgery. One patient, two sisters came down from Mumbai to Bhubaneswar and Cuttack, and they went to 10 plastic surgeons in Orissa, and they have taken a FAQ for 10 questions and asked 10 people. And end of the day, all the surgeons, plastic surgeons who have their exposures, they wanted to do it. And everybody, they are marking also, these two sisters. And ultimately, I don't know what they saw. They landed with me and I operated the patient. And they went back to Mumbai. In such situations, every surgeon has given a different type of opinions in
Right.
cosmetic surgery.
Right.
So how to handle such type of patients?
Sir, I have over the years, as I
I
have,
think Vibhuti also knows about that patient also very much.
No, so my take is that everybody has their own style, everybody has their own approach to life, to patients, to work, and that shows through when you talk. And it is a comfort zone with a patient develops with a surgeon, and especially people who think, who take second opinions. They've got many angles which they want to decide on. So, जो चीज़ set होती है, that's what they tend to do. It's like going and betting on a horse. You go to the race horse, there are 10 good thoroughbreds. Which one do you put money on? Ultimately, if you got only, put one ticket, you put only on one. So how do you decide? So I don't think we should read too much into, why a person did not come back to me. It's a question of us giving our best. And I also find that we should not be slaves of patients. We should be respectful and we should be nice. But many doctors now tend to see, अच्छा वो मेरे पास नहीं आया, that means I was too harsh. I should be even softer. That softer is actually losing your personality, which is not a good thing. You should have a certain ego, not a bad ego, but an ego enough to give you a strength of character.
But that is happening because we do not have uniformity in deciding a patient's operation.
So, so medical is sort of art and science. There is no sort. It's not like computer that you change one chip and it is done. So the best expert also can get complications. That means that there is something beyond that. So there is, and that's why we should always listen to youngsters also. They may come up with newer, better ideas.
Yeah,
Anyway, thank
this Professor Chaudhary's question, I am aware of that patient. That patient had done multiple consultations. I'll give you two examples. That patient was talking about different techniques. So was fixed upon a particular technique. So I don't know what you talk about that. She wanted silicone implant. So I gave her all the combinations and permutations and told what the advantages and disadvantages are. I don't know what Professor Chaudhary told, what others said. He got operated by them. But at the same time, I had another patient where the patient had a scar and the patient came to me and she had seen many other surgeons. Somebody had said 90% improvement, somebody had said 100% improvement. So I had said you will get about 70% improvement. The patient got operated by me. So both angles are possible. So it depends on patient, what patient gets convinced. What is your sincerity in which you are convincing
So
the
it's
patient?
sincerity and it's also culture. I, like in Gujarat, as you know, it's a business community over there. So everything has to be translated into numbers because accounts is finance. So patient will always come to me is, कितना improvement होएगा? आप कितना result दोगे? And they want it in taka. Taka means percentage, right? So when you say अच्छा हो जाएगा, but आप तो कोई guarantee देते नहीं हो. The other doctor gave me 90% guarantee. You are not giving me any guarantee. So now then that comes on to you. What is your thing that you want to also get into? चलो कुछ बोल के खत्म करो कि नहीं, I hold कि भाई, medical science cannot be translated into taka, so I'm going to say, भाई, so I always,
sometimes it might work to your advantage, sometimes to your disadvantage.
Exactly, true. So there's...
Dr. Lakshmi, about your question, just a
Any,
minute.
So
any
last question.
closing question?
Sir.
What is the incidence of recurrence after reduction?
Incidence of recurrence after reduction?
Yeah.
See, the recurrence reduction, you kind of define it in two ways. Number one is a reduction when you have, first one, you have not done a big enough reduction. Right? It is a E cup or F cup and you have made it a double D. So it is still big. So that patient may come back later, now I want, even lesser. So then they'll usually go to a second surgeon. So it's a redo, but the first one was not adequate. And the second question, it could be recurrence as in, okay, it became a C and then it increased again to be something. That usually depends on anybody putting on weight. There's going to be proportionate increase in the breast size.
Yeah. I have come across few patients, those who have hormonal problems, and other group is having taking the antipsychotic drugs.
Right.
They are, even though they are slim, but the breast size has increased enormously.
I have had antipsychotic, but they have put on weight overall. I have not had person putting on only breast. Because I had an abdominoplasty patient who put on weight, and then the abdomen was flat because the lower abdomen is removed. That's where the majority bulk is. And so she was like a 2.5 dimension, not a 3 dimension. Which very funny looking lady.
Yeah, here Dr. Lakshmi brought out that interesting effect of clomiphene. That paper that you mentioned about, does it have any age specificity, like within 20 years of age, they are more responsive to this, or is it in 40s or 50s, it still responds? No, if we can get 50% improvement with the medication, then it makes things much easier, and about the recurrence, that also can be taken care of.
Yeah. Okay, then I'll revert to you. I'll check up on that and do it. Yeah. Sure. Okay, so thank you very much. And Dr. Medha, welcome. I've been holding stage for you to come, so aajao.
Thank you all the panelists for a very nice discussion. Now I will request Dr. L.K. Mishra, President Apraso, to speak few words about our esteemed speaker.
Thank you very much, Sandeep sir, Dr. Rajat. It was a really fantastic breast reduction program, first session of our program. Now I request Madam, Dr. Medha Baba Madam to the dais. Dr. Jayant, please come and hand over a bouquet to Madam. Madam, Dr. Medha Madam is now the Vice President of our association in Iaaps, and he is now presently the Director, Laser Cosmesis Thane, Director, Param Hospital and ICU Thane. He was APSI Visiting Professor in Cosmetic Surgery in 2019, Excellent Award FCI 2022, the past Secretary and Executive Iaaps, original work, Drainless Abdominal Plasty and Axillary Breast. And the many literatures, presentations in the national and international books. He is the past paperless CME Fat in the Future of 2013. His area of interest was body contouring and aesthetic administration technology. I invite to this program, to the association Apraso, Madam, please.
Good afternoon, everybody, and apologies on behalf of the heavy rain and Indigo for the delay in flight. I am really sorry to have held you up. I can see a very nice get-together of young people and all my old friends, Dr. Giri, Dr. Bibhuti, Dr. Chaudhary sir, and of course Dr. Dash and Dr. Mishra. So nice to see you here again. thank you Iaaps and Dr. Dash for the opportunity to visit and interact with you. So this is my clinic and this is my operation theater, because I think I am talking here for the first time, so I should just tell. So male chest is as important as female chest, especially in 21st century. This is my own patient of gynecomastia, not a model, although he has got into modeling. It is very important because of the psychological and hormonal implications that gynecomastia has come to have, and the incidence has risen very drastically, especially after COVID. This is how the patient on the cover page came to me. It was done with simple power assisted liposuction and removal of the gland. And within a year, he started building body because he gained confidence and he has now entered modeling. That was a 6 years post-operative result. So gynecomastia is a male breast enlargement, and the term was coined by Galen in 5th century, although it was given to fatty enlargement of the male breast. A glandular enlargement was known to them, but they called gynecomastia as a fatty enlargement. We all know the types of gynecomastia: glandular, fatty and mixed. But there is something called as pseudogynecomastia. Now this patient already had a gynecomastia removal done 5 to 7 years back, after which he gained weight. Instead of building body, unfortunately he gained weight. And then he developed this fatty enlargement of the breast, and this is what we call a pseudogynecomastia. Personally, I don't believe in the term, because patient comes for a female-like enlargement of my breast and I want a flat chest. So I find the term to be very superfluous. This patient had mostly fat, hardly any gland. But we have to note that these enlargements do not come down even after patients lose weight. I will show you examples. The etiology of gynecomastia: we know that gynecomastia manifests in perinatal, pubertal and andropausal periods. The perinatal one is because of maternal hormones, and that has to be ignored. Many times the parents keep on, especially the grandparents, they advise expressing the milk, which should not be done because it stimulates further milk secretion from the baby's breast and the gynecomastia may persist. The common causes are idiopathic, hormonal, syndromic and drug induced. These are very important because nowadays clinical examination is actually part of investigation. Such unilateral gynecomastias, they make you wonder whether we really understand the hormonal causes completely or not. The same hormone is circulating in the blood, but there is a unilateral enlargement of breast. And surprisingly, after COVID, the incidence of unilateral gynecomastia in my practice has increased. And what I want to say at this point is, we don't understand the receptor density, the receptor sensitivity to the hormone and hormone receptor interaction. So that is why doing the hormonal levels in gynecomastia might not contribute anything towards the diagnosis. So only in specific case, there are several papers published that say that a measurement of hormonal levels is not useful, and it is because of this reason. This is another queer example. This patient had gained weight and developed a huge gynecomastia. This is because of peripheral conversion of testosterone into estradiol in the fat. That is especially around the peripelvic region. After losing weight also, the projection of the breast has not moved even 1 centimeter. And you can see a good result with radio frequency. All the 3 technologies were used to avoid skin resection in this patient. This is important slide to note. These are the drugs which lead to gynecomastia, and you can note that simple commonly used drugs like ketoconazole, anti-tubercular drugs, and tricyclic antidepressants, they can cause gynecomastia. So can marijuana and heroin. So taking history about all these things is very, very important. Tricyclic antidepressants have to be stopped. You have to wait till the anti-tubercular treatment is over to treat any gynecomastia. This is a list, actually these two are the lists I have compiled for my chapter in Dr. Anup Dhir's book on practice of liposuction in that chapter. And these are the common causes of hormonal imbalance. So just to say that examination of testes is very important to rule out atrophy or tumor. So in general examination, apart from examination of the chest, we have to take height, weight. Posture of the patient is very important to counsel the parents. They always slouch. Secondary sexual characters have to be noted. Areas of fat deposits, because many patients have gynecoid body habitus and they have lot of peripelvic fat deposition. Many patients have gained weight rapidly and lost rapidly, so they have developed stretch marks, reducing the quality and elasticity of the skin. Keloid tendency as a surgeon we have to see, and other pointers to obesity have to be checked. When we examine the patient, we have to divide gynecomastia in 4 components. Skin, look for excess elasticity and stretch marks. Nipple areolar complex for size, position and projection. Many times because of development of the breast, it may have turned medially or excessively laterally, and it has to be placed properly. In male chest, the nipples are placed little more laterally than females. Gland, we have to see the composition so that we decide what technology we use, whether there is a ptosis. We have to also check the footprint of the breast and rule out any pathology. A tender gynecomastia might be a developing gynecomastia. We have to wait for 1 year for the tenderness to settle so that the inflammation gets converted into fibrosis, and then is the right time to operate. Inframammary folds, lateral highlights and infraclavicular area have to be checked, and this is all for the patients who are seeking contouring, and I'll talk about it more in detail later. This is my gynecomastia chart. These are the measurements. This is the list of investigations if you want to take. Nowadays I have added vitamin D and B12 because 90% patients are deficient in these two things, and lack of these vitamins causes edema, and that is not good for our surgery. So I correct that and then only take the patients for surgery. As I already explained, hormone levels have to be done only in specific cases. They may not be contributory, and if required, especially nowadays children are coming with gynecomastia. So in such patients, it is safer to take opinion from an endocrinologist. Although I have also seen that they will always advise tamoxifen and pass 1 year, and the patient has extended year of agony before he gets a surgical treatment. Counseling the parents is the most important step in our consultation. Parents are always reluctant. They feel it is unnecessary expense or a tantrum of the child. He is not focusing on studies, he doesn't go out and play. And they are also logically worried about surgery on their child. So we have to sensitize them for the agony of the child, especially pointing to the lack of focus, and tell them that this is because of the problem he has and probably the peer teasing that is occurring. We have to assure them of a safe surgery at a good center, and another worry is that whether the child gets operated, he will have to go for it again. So we have to tell them that we are removing the gland as well. So it is very unlikely to recur unless the child gains weight. So this is my patient. The gynecomastia chart is filled up, and the areas in blue are the areas where you want to create negative areas or depression, so that there is some contouring of the chest. And these are the areas, if you are comfortable with fat grafting in the muscle, to show a good contour, you have to do fat grafting. I am not doing fat grafting as of now. So these are the various views of our patient. Can I have volume up, please? Volume. This video has a volume. Sorry. Huh. So this is marking of the gynecomastia patient. अरे, why is it? आगे क्यों जा रहा है वो? Yeah. This is marking of a gynecomastia patient. I am marking the midline. The patient is cannot standing straight. Can you hear at the back? Can you hear at the back? Process and the mid-clavicular points and the breast meridian. Yes, in gynecomastia also you should mark the breast meridian. Now, as you can see here, the patient is throwing pecs in action, and that allows me to mark the pectoralis border. It is very important because everything lateral to the pectoralis border has to be removed. And now I am marking the inferior pole of the breast. And here I am pushing the breast out to mark the footprint of the breast and the medial border of the breast on either side. I am marking it tentatively with a dotted line, and that is the line along which I am going to feather my operation. Now here lateral to the pectoralis, I am marking strongly because I want to remove every possible tissue that is lateral to the pectoralis, so that the pectoral can be defined when the patient starts exercising. Now the patient has raised his arms and I have marked a small... So this axillary approach I have started using recently. In the early period I used to use parasternal incisions for liposuction and periareolar for gland removal. Some time in between I used to use lateral, but now I am using this axillary ports. So this is a video of surgery. The patient is kept with arms raised. As you can see here, infiltration is done with power assisted infiltration pump. So that helps basically hydrodissection, making tunnels, everything is finished in infiltration itself. This is after infiltration. And after waiting for about 8 to 10 minutes, I use liposaver, that is the brand of ultrasound lipolysis I am using, to lyse the fibrotic tissue and also to liquefy the fat. The lateral rolls also have to be treated. So this dissipates heat when ultrasound treatment is being given, and that also helps contracting the septae. The radio frequency also helps contracting the septae. So this will probably obviate the need for doing too much of contouring because it retracts the skin nicely. The problem of radio frequency is that it coagulates the fat and makes it hard to remove. That is why Bbsr is done and fat is liquefied first. Suction has to be done tunnel wise because I see many times a fan shaped suction is advised. That actually breaks the septae and predisposes formation of seroma. Now this is creating the infraclavicular hollow. A thorough liposuction is done in infraclavicular zone to really thin the skin out. So you can see the gland is still there. This is the lateral liposuction. What I have not shown here is the cross chest liposuction. That is done when I put a port in the areola skin junction. The liposuction is done along the lateral pectoral border thoroughly. You can see the gland. Despite ultrasound lipolysis, it has not completely dissolved. So this is the gland that needs to be removed. Periareolar incision is my preferred approach. Even from lateral incision, I was not able to get the entire gland. So I used to invariably land in removing it through periareolar approach. It is very important to be careful to leave the subcutaneous layer intact. If you cut off the subcutaneous fat thinking it is breast fat, it is going to leave indentation. Initially, I leave more tissue under the nipple which can be trimmed as per our needs. So a large mass usually can be taken out, especially from younger patients, whereas older patients who have got gynecomastia because of weight gain, this tissue is likely to be slightly less. So suprafacial gland removal is done. This is how the infra-NAC fat and tissue is trimmed off. And here, as I showed, the fat is being pulled. Subcutaneous fat gets pulled when you are trimming the area under the nipple. So hemostasis has to be checked, and you have to fix the nipple to the underlying pectoralis muscle with interrupted sutures in the first layer. And on the other side, the dissection is repeated many times. The amount of tissue that is taken out from either side is different. And subcuticular sutures. And as soon as the patient is out of anesthesia, I like to give a padded dressing and garment. We don't put garment on table because under anesthesia, it becomes difficult for the patient to breathe. So you can see a nice contour with all the highlights and the specimens. So this is the patient on 10th day after surgery, hardly any bruising, good skin contraction already, and it will contract better. Even the nipple is slightly edematous, but it is well contracted. So this is the post-op care. I think everybody knows about it. Most important thing is talk to the patient in the first consultation and find out his activities. Most of these boys are riding bikes, driving and lifting weights. They are itching to go to the gym. And it is very important to put this condition that they are not allowed to put load on the shoulder. Otherwise, in second or third post-operative week, they will come with either a hematoma or seroma. Exercises have to be started after 6 weeks. So some of my results, this is 28 months post-operatively. Usually I like to show long-term results. So this was done through lateral approach, a small scar is seen. Now this is a patient who was putting a dynaplast in attempt to reduce his breast and conceal it under the shirt. He refused to undergo bilateral gynecomastia surgery. On right side there is a small glandular enlargement. So you can see the result, especially in the lateral view. You see the difference between the not operated side and the operated side. And this has to be told to the patient beforehand that if they want to go unilateral gynecomastia, they should expect a difference. The other side may grow later. So here is a patient who again had unilateral, but he opted for bilateral surgery, and you can see good result on either side. This is a patient, really an example. He developed gynecomastia around 18-20. He became depressed and he was put on antipsychotics for 20 years. He got married, he did his job, but at the back of mind he was depressed, and the antipsychotics added to the gynecomastia. So when the patient came to me, probably he had not informed the psychiatrist about the gynecomastia at all. So I connected with the psychiatrist, had this stopped for 6 months, and then went ahead with the surgery. He developed seroma 3 times, which sometimes these complications can happen. We should be able to manage. Some amount of hyperpigmentation because of energy-based device. As opposed to that, this is a patient with massive weight loss. He also had all the 3 techniques used on him. But because he had undergone weight loss, his skin is less stretchable, not elastic. So you can see that laterally the skin is still lax despite so much of treatment. So this also has to be forewarned. Usually massive weight loss patients do not have elastic skin. So you have to decide whether patient wants a perfect chest or a scar. This is another patient, young patient, 16-year-old, insisted on gynecomastia surgery before 10th standard examination, in which he did finally very, very well. Once he was operated, he never came back for follow-up, but he sent me this photo after 10 months. He had gone into bodybuilding, very confident and very bright individual. So these are transformative surgeries. So some more results. Some results in the pre-energy based area. Machu Picchu is still going strong even if it was built 1000 years ago. So our regular people who do not have access to EBDs, they still need not feel bad. The results can be good, only you have to choose the patients properly. So these are the results before energy. So what the take home message is, you have to assess the skin. If it is lax, stretch marks, or there is excess, try to use skin tightening with RF, laser and UL. If the gland is big and fibrous, try to break it down with UL. And for contour, you can consider fat grafting. So sometimes you wonder whether you did anything for your gynecomastia patient or not. This is a post-op, 2 years post-operative. But he pleased me by throwing his pecs into action and told me, "Madam, you have done a good job. I have developed my pectoralis." So peaks look beautiful because of valleys. Thank you.
Thank you, madam. The next topic is how to treat grade 3 and grade 4 gynecomastia. Dr. Sandeep Sharma.
Yeah, we'll quickly move on to the next. This is discussing grade 3 and grade 4 gynecomastia. Now, when we talk about grade 3 and 4, obviously we need to know what is that. There are 2 classifications which are popular. One is the Simon et al. Classification, which basically grades is at grade 1, 2, 2A, 2B and 3. So again, that's basically talks about enlargement between mild, moderate, and large, and the skin excess in the 1 and 2A. There's no skin excess. Basic enlargement is as the skin is stretched, and if there's excess, it's 2B or C or 3. And the other one is the Rorick et al. Classification, which goes by 1, 2, 3, and 4. And again, 1 is minimal hypertrophy, 2 is moderate hypertrophy, 3 is severe hypertrophy with grade 1 ptosis, and 4 is severe hypertrophy with the grade 2 or grade 3 ptosis. So yeah, but for practical purposes, we see 3 forms. Whether it's when we see it clinically, we see whether it's glandular, whether it's fatty glandular, or only fatty gynecomastia. Usually in the later age groups, you have more of fatty glandular because patients are obese. And the second thing is whether we see is how much of ptosis is there. So this is a schematic diagram of a female breast, a male breast, and what a gynecomastia would be. And our treatment options are, this is mainly simplified it for our postgraduates here. It's either subcutaneous mastectomy, as was demonstrated by Dr. Mehta just now, and here's a schematic diagram on this. Just to show you an example, this is a young boy of 18, and that's the excision done, and you take a semilunar pellular scar, and that's sort of the outcome which you have. Again, the same subcutaneous mastectomy as done in a grade 4 breast. That's sort of 350 grams per side with again a fine heel scar. But yes, in this cases, the skin does not shrink as much, and you do end up with certain deformities. The other options are liposuction, or a combination of liposuction followed by whatever is residual. You do a excision of that residual portion. So this is only liposuction. Again, this is again only liposuction, 2 weeks post-op. You can see the change in posture. You see he is hunching forward with the chest flat. Now he's standing straight. Again, this is pre-op, you see, and you can see the 6-month post-op. Now, what we are talking about, grade 3 and grade 4, or 2B and 3, that's sort of 6 weeks. This is only with liposuction. Different views of the same patient. I hope this video plays. अपने आप प्ले करेगा कि अलग से करना पड़ेगा? Thank you. Okay, there you see concentric markings for. In this case, I did the abdomen and flanks as well, sort of, or the lower torso. Just wanted to show you that sort of doing it, without putting a scar on there. Grade 3 and grade 4 per se, there's always going to be some degree of skin laxity, and you do not get a perfect result as you would want it to be, and you may require to do a secondary procedure if unless the patient is going to accept some degree of skin laxity. Or here you can see that there was it has healed, but it does get stuck down to the. Yeah, so this is a grade 3. Here I've sort of done it on the left breast. You can see the emptiness of the pocket, and I'm about to do the right side. You can see that's sort of the fullness of the right side. The cross markings is the transition zone where you would want to do liposuction but a bit less. And this is how much you want to empty it so that it can shrink properly. And this is after having done both sides now. So again, now the right is also emptied. So this is how you check that you've done a complete job. If there's a little bit of residue under the nipple, you might want to resect that out with a semilunar scar. So that's the patient at 3 weeks. So a lot depends upon the age of the patient and the nutrition status as well, the quality of healing that a person you would get. So yeah, now going on to older patients, also with this, you do not go for total resection. You would want to leave some behind because the abdomen is also a bit bulgy. So if you have only the chest is flat and the abdomen is bulgy, it looks a bit of a mismatch. So you should plan to do your gynecomastia accordingly. Again, this is this is only 10 days post-op. You can see the degree of shrinkage. And I do not use any power devices. This is only with the classic method of liposuction, and you get good results. There you can see this is day 10, and it's obvious that after massage and a bit more compression, he's going to get a good result. It's again day 10. This is one excision with lax skin, which is Dr. Rajat's case. So there is a scar, but it is, you can see that the chest is flat. That's what the desired requirement was. So planning the scar is very important. So these are the instruments which I use for liposuction. And on the right, there is this cannula which has got serrated opening, and the serration is only on one side, as you can see. This instrument has been designed by Dr. Mukund Jagannathan, at Sion Hospital, Mumbai. And that does come in very handy when you got very resistant or fibrotic fat, which is difficult to get to. The only thing is you got to make sure that the serration should always be facing away from the skin. Never have them facing towards the skin, because the abrading effect can actually cause devascularization. So basically, where do you use whenever there's marked redundancy of skin? Either redo liposuction. So how do you advise people with grade 3 and grade 4 when there is a little bit of laxity left or you've not got a complete result? Either we redo the liposuction after anytime after 9 months. You should not hurry into doing it again, or get them to agree to do a skin excision. Alternatively, if it is if it is a very huge one, you might need to do a free nipple graft to get cosmesis. Well, there is a list of complications which can happen with the major gynecomastias. Again, acute bleeding is a possibility. You got to take patient back to OT. Hematomas, small ones will resolve, small seromas will resolve, bigger ones may need to be aspirated. Again, nipple loss is a very rare thing for a gynecomastia. But yes, unsatisfactory result is a big issue, and especially with grade 3, grade 4, that's why counseling is very important. And it should not be because of inadequate removal. There can be some asymmetry because we are dealing with a difficult case. Contour irregularities can happen, so you got to convince them that you may require a second session, but do not overzealously excise. And I find as time goes by, I'm doing less and less of open. I'm doing more using the liposuction cannulas only, because I'm not getting, because of this, I'm not getting the divots and the saucer kind of defects following gynecomastia surgery. Yeah, thank you.
Thank you, sir. So now having a panel discussion, gynecomastia, different approaches. So may I request the panelists to be present on the dais. Dr. Jayan Das, moderator, Dr. Medha Bhave, Dr. Sandeep Sharma, and Dr. Rajat Gupta.
So we have all the stalwarts on the dais, Dr. Sandeep Sharma, Dr. Medha Bhabe, Dr. Rajat Gupta. So I hope it would be a nice discussion on gynecomastia, which is a very common surgery in aesthetic practice. We all do gynecomastia with the different techniques, with different approaches. And I'll start the panel discussion, first of all, with to Dr. Medha Bhabe. Madam, still it is considered as a psychosocial stigma. It is more of an embarrassment than a disease. And what is your take on it?
Definitely there is a psychosocial stigma, and not only that, getting operated is also considered stigmatic. But I do feel that it is very, very natural for any boy to feel embarrassed, and they definitely deserve a surgery. And we have to work towards allaying patients' anxiety. Another important point what I have realized is this is era of overnutrition. So we have to sensitize the patients, parents, or the society against overfeeding their children, because you can actually see 9 or 10-year-old child who is obese being fed chocolates, cokes and everything, and the gynecomastia starts developing, and then it consolidates by age of 12 to 13, which further pushes the child away from bodily exercises. So Iaaps, we can take awareness, drive for this.
Right, madam. So it's obesity, and you must agree with me, most of the time, the cause is idiopathic. There is no specific reason, there is no hormonal abnormalities. So do you think the increased number of surgery is because of the social media? People are more obsessed about their body image. Do you think that?
I frankly don't think so. In fact, it is very healthy to have a healthy body. When you jump, whatever moves separately is dragging you down. So that
Right.
is unhealthy. That has to be eliminated. That is my take on it.
Nice, nice, madam. So, the next question is to Dr. Rajat Gupta. What is the minimum age? So there is a controversy whether we'll operate a case of gynecomastia at the age of 12 years or not. So what is the minimum age, and what is your take on it?
So in my clinical practice, I usually ask my patients to wait for 17, 18 years. Actually, it's more than the age, it's about having secondary sexual characters. So if the patient has secondary sexual characters like mustache, beard, chest hair, you don't see any hormonal imbalance being there, you can do the surgery. Usually it happens around 17, 18 years of age. So that's why we say age. Having said that, I have operated 2 of my patients even at the age of 13, 14 years. And both of them had severe psychological issues, suicide attempts, not going to schools at all. They had big, like grade 3, grade 4. And the kids in that age, adolescence age, the other boys would touch their breasts, press them, they would embarrassed. So their parents came to us, and I told them that this is the scene. The patient may have some breast development. Again, we can do the surgery. And they understood that. We did the surgery. The child started going back to school. Is fine. You know, he still had some loose skin, but if it doesn't show in the shirt, the kids in the school don't tease him. So that was it. But as a dictum, not before the secondary sexual characters have come.
Yes. So if the child is bullied in the school, child is depressed, child is not focusing on the study, so we may take the child for the surgery.
But telling them that this can grow again, and
Right.
they may need to go on a secondary procedure.
Right.
So if they understand, only then. Otherwise, wait for secondary sexual characters, unless they are. Most of them are not that depressed. They are
Because,
concerned, but they are not that depressed that they are suicidal and all. So you can counsel them and ask them to come back after a couple of years when everything settles down.
Right.
Yeah,
Sir,
one more point I would always also see is that the demand also should come from the child.
Right.
that their understanding of the procedure, what they're getting into. If the child does not want it, don't do it.
Yes, yes. Even theoretically, it has been written. So, if it subsides during the adolescent period, after 1 year or 2 years without any medications, so no surgery is required. So, it may subside with the time, but the peer
Usually
pressure
will not subside. They are happy to live with it. That's what it is.
Right, right. Another thing, there is a lots of advertisement used to be before awake gynecomastia surgery. Okay, so it was being publicized, it was being advertised. So, Dr. Sandeep Sharma, what is your take on awake liposuction and gynecomastia surgery and gynecomastia surgery under general anesthesia?
When you say awake, can you define what
So
you mean
it
by
is
that?
under local anesthesia.
Under local only?
Local anesthesia only.
local tuberculosis.
Patient is awake, local anesthesia.
See, I have, majority of them I do it under local sedation, but I don't do it only under local.
Right.
Because thing is, when you want to do an adequate liposuction, you are going to scrape the muscle.
Right.
And it can sometimes be painful, and sometimes one big jerk of a cannula rubbing against the pectoral muscle can be so painful that the patient sometimes may panic and say, "Ab band kar do, meko karana hi
Yes,
nahi hai."
it may happen. You will not finish the job.
Yes,
It will,
correct.
the result will be incomplete.
And then you are more worried about the patient than about doing an adequate job.
Exactly.
So,
exactly.
I would never.
Once upon time, it was being advertised a lot. Awake liposuction. Patient is awake. Patient is talking. But you still prefer under sedation
Yeah.
and under general anesthesia also.
General anesthesia also is a possibility. But
Is it your
most-
daycare or you discharge on the
always,
same day?
Always daycare.
Always daycare.
Always
No need of stay in the night.
No need of stay in
Only around 12 hours to 14 hours.
Correct,
In
correct. And I
hospital.
now I don't put drains. I'm sure you also don't put in drains.
Hardly.
Yeah.
Only-
So nobody
only-
puts.
only
Yeah,
grade 4.
drainless since 15 years.
Yeah,
now.
she's drainless.
Yeah.
Brainless, huh?
Right, right. So again, the next question to Dr. Medha. You completely depends upon on liposuction only, or you combine liposuction with subcutaneous mastectomy, or sometimes you have come across some patients where you have done only subcutaneous mastectomy.
So subcutaneous mastectomy only never, because there is invariably some amount of fat, and the beauty of liposuction is you can feather it. In the very old times, I think when Sir was young, he might have seen that dish-shaped deformity, which I had written in my thesis, but I never saw it. So that has been eliminated because of liposuction. So liposuction is essential component, but I would say 90% of the time or 95% of the times there is some amount of gland there which has to be excised as well. So it is mostly a combination only. Very rarely I have done without a gland removal, and sometimes patients insist that they don't want incision. So one patient I said, okay, I will do only with liposuction, but he came back after 6 months with that small button of gland which I had to do free of charge.
So, madam, do you rely on suction-assisted liposuction, power-assisted liposuction, laser-assisted liposuction? Madam, or you combine everything?
I have come from suction-assisted to all the three in last 28 years. And as I showed at the end of the talk, earlier results without energy-based devices were very good. But what energy-based devices have done is they have improved the results and avoided the need of skin resection in larger gynecomastias. That is what I have realized. And even the amount of gland that you remove after using ultrasound lipolysis, actually it lyses fibrous tissue as well, is much smaller. In older times, I used to have very large glands and I used to really struggle to reach the periphery. But now with liposaver, it is possible to remove a very small gland.
Yes. So in all patients, you combine liposuction, the power-assisted liposuction, then you also combine some ultrasound assisted devices.
Yes.
And then you do
Radio
frequency also.
Especially in larger patients.
All the three things
Yes.
you combine.
Yes.
So
Because now I have the gadgets.
suppose in some cases you have done power assisted liposuction, then you have done you have done the Bbsr ultrasound liposuction, then power assisted liposuction. Have you ever tried radio frequency later during follow up?
Yes, I have tried it only once or twice, and that too in liposuction patients. When you do radio frequency in the end, what happens is subdermal fat is eliminated, and that results in wrinkling. So I avoid doing radio frequency after my liposuction.
And you do radio frequency on the table only?
Yes, basically the
never
main
in follow-up.
advantage of radio frequency is that it contracts the septate. So I don't like to use it for dermal tightening. For that, if at all I have to use any device, I would use MNRF. Microneedled radio frequency to tighten the skin horizontally, but not for subdermal tightening with internal radio frequency.
Good, thank you. So next question to Dr. Rajat. What is your take on port side? There are various approaches through axilla, lateral chest, trans nipple, trans areola, cross chest. So there are so many approaches.
So in grade 1, 2 and 3, I usually do only lateral chest, which is actually not just lateral chest, not axilla, in between, beyond the anterior axillary line, so that that scar is not visible when the patient is standing bare chested. And I break the gland and mostly remove the gland through that same incision. So that is my preferred port site. I don't use cross chest or trans nipple ever.
Sir, you have ever tried cross chest?
I typically do two things. Number one, I always make sure that both my incisions on each side are not symmetrical. Yeah, right. So I'll never put it at the same point. Because I'm a right-handed person by preference, though I try to be ambidextrous, on the left side I will always have it, around sort of just below the axilla, where the lateral contour of the breast is there. And on the right side, I would tend to put it either midline or a bit lateral to the midline in the inframammary, just below that. Because ultimately, I do not do power assisted or that. So my cannula size is very small. I usually use the 3 millimeter cannula. So my incision is going to be 4 millimeter. And because there's bruising around, I never tend to suture it also. So it heals very nicely. There's going to be, in our kind of patients, there's going to be a darkish pigmentation in that area eventually, which sometimes goes away after a year. Many times it does not go away. So that is pretty much okay. So I don't think I have an issue with the scar.
So some people, they have described liposuction through nipple.
Correct.
Yeah, so
I find it, I have seen that, I find that I might, and I tend to, over time, I'm less and less, I'm trying to even do the nipple ke niche ka the part, that nubbling which is left, I try to even avoid removing that. Let the nipple be a bit protuberant is okay, but not to try and incise it. For two reasons, because I believe that to get symmetry from a grade 3 or grade 4, the nipple has to shrink to the same position on both sides. Otherwise, you'll get an asymmetry not in volume but in looks.
Right.
So I find the massage is very important. So any incision means your massage is put off by 2-3 weeks.
It will reduce the fibrosis.
Yeah, so to induce that and get it settled down, I find that I do not want to put any incisions, so I keep it away. That is my way of
The other thing why I don't prefer trans nipple is, we all know when we do liposuction, there is some abrasive injury around this incision. So trans nipple will of course have it. So that area will have slightly more scarring. So that's my personal thought. Second, we have done a lot of areolar, or even, inverted nipple surgeries. And whenever you go near the nipple or areolar complex, there will be chances of having loss of sensation around the nipple as well. So that's my another reason why I will not like to
nerve damage is more.
Did you see?
I find difficulty for movement through the nipple, so there is less movement, movement is restricted for the liposuction. Madam, what is your?
I just wanted to make a comment about cross-chest liposuction. It is not an approach. Through any port, when you go to the other side, you are able to debulk the medial part of the gland. That is cross-chest. So it is not a separate approach. In any of these approaches, you should always do a cross-chest liposuction to redrape the skin nicely and especially to smooth out the medial borders which may remain prominent.
I tend to avoid crossing the midline if possible. That's a personal...
Crossing the midline.
Yeah, I don't like to cross.
So even the sternum skin above the sternum is very thin subcutaneous fat.
Yeah, if I need, I'll take another incision on that same side, but I try not to cross the midline.
There are some patients who have reasonable fat over the sternum also. For them, you can go there. Otherwise, if it's not there and it's actually very distinct, and you feel it in grade 1, grade 2, it will re-dripping, then you may not need it.
Yeah, if this contiguity was rather than saying, then it is...
Exactly why I did not show in my video. Because it was a small gynecomastia, so I did not need the cross.
And sometimes you will feel resistance also while do cross chest liposuction.
You
over the
saw
sternum.
one more approach I showed on my grade 3. From the inguinal region,
Right,
I did
from the abdomen. From the abdomen.
Yeah. So you can get a very good.
See, the other advantage of doing lateral chest incision is many times you would do abdominal contouring as well, and lateral chest incision is very safe if you are doing upper abdomen.
Exactly.
Especially in thinner patients, if you do from going below to up, the upper abdomen, there are chances of risk going beneath the ribs and all.
So in most of the patient, you prefer lateral chest.
Yeah, I do. The other thing is in grade 3, grade 4 gynecomastias, you also go beyond the chest and do the slight upper abdomen. It helps in redraping the skin very nicely. So lateral chest incision also helps you go safely in that region so that you break the IMF and the skin redraping is better.
Yes. So next thing is to Dr. Sandeep Sharma. After you have finished liposuction, so what is your approach for gland removal through the same port, pull-through technique, or transnipple approach, or through areola?
Well, when I used to do it, I would take a periareolar, small incision depending on the amount I need to remove. But as I said, more and more I'm trying to avoid doing the gland removal at the same time. I'll spend more time, change my cannula, use the Jagannathan cannula, whatever, to try and get it out all through my liposuction only. Because I find that whenever I try to go in, however much you planned, you tend to do a bit of over resection, and that part tends to stick down and not settle down as well as it would if I were to do a liposuction. And I find over resection is worse than under resection.
Now the transnipple approach has become very popular.
Correct. I somehow it doesn't appeal to me.
Yes, yes.
I don't like splitting
what
the
happens sometimes the patient requests you don't do liposuction, don't do anything, just remove the gland through transnipple approach. So anybody?
I would tend to say no. मेरे को ये नहीं आता है.
I do almost.
Liposuction is the core entity.
Liposuction with gland removal from
core
the lateral port. Right. With the technologies which ma'am said, with ultrasonic and radio frequency, what they does it, they break the fibrous septae as well, which are bound the tight gland, hard gland with the fat. So even the gland portions become slightly loose and not that tight. And you can remove it through that. The other advantage is, since you have not opened the skin, what I feel, since you have not opened the skin, when you are doing liposuction and gland removal, the skin is redraped. So you can see whether the skin is going in or not. Is it too much removal or not, as you said. But if you have given a periareolar approach, lifted the skin, and suddenly when you remove the tissue, you feel, oh, this has gone in. So that thing does not happen if you are able to remove the gland through the lateral port. However, it's a trickier thing. Not all patients can go through it, especially patients who have gland due to steroid abuse, going to gym, very hard glands. It's difficult to break in some, and then you might have to do a periareolar approach.
Madam, you never do transnipple?
I usually always do periareolar.
Periareolar.
Yes.
Periareolar.
I prefer that because I feel I have enough control and I can also place the nipple where I want. Sometimes, nipple may have turned medially or laterally. Then I can control the nipple position by fixing the nipple to the pectoral.
So next thing to Dr. Medha, madam, regarding when in grade 3, while dealing with the grade 3 gynecomastia with large areola, sometimes like female areola. So do you prefer that de-epithelialization of NAC part, NAC reduction, skin excision?
Yes, sometimes it may be required. What I have noticed is that after the energy-based devices have come, somehow even if I don't go over the nipple with radio frequency, it shrinks. So you might have noticed that pre-EBD era, most of the nipples were a bit large. And when I do using the energy-based devices, the nipple shrinks on its own.
Madam, when the areola is large, like female.
So it depends on whether patient wants it reduced or not. First I discuss it with him, and then if required I do. Actually I wanted to share one very nice technique by Dr. Bimla Rajan in Delhi. I will show the patient, I think during lunchtime, because it is on my phone. Unfortunately, her beautiful technique done for almost 250 cases of gynecomastia was not published in IJPS, saying that it looks like bipedical horizontal technique for breast reduction. But it is a very nice technique in which she de-epithelializes periareolar skin and then just cuts the superior and inferior borders, goes underneath, removes everything that has to be removed, and then just sutures the skin around the areola. Right. So that is a very, if the skin is really in excess, that is a wonderful technique.
Sir?
Yeah, I mean, when you talk about, the areola size, never do it, consider doing it. I would never consider doing it at the first stage itself, because after the suction and the whatever technique you use, there's at least a 50% reduction in the size of the areola. So that's when you make a judgment call. And most of the time it's not required.
Right. So how I think is that you see the skin quality of the patient. If the skin is thick, they're less than 40 years old usually, that skin actually shrinks very nicely. But sometimes people who go to gym and who have lost a lot of weight, their skin is so loose that skin, whether you use EBD or weight, it does not shrink. In fact, what it does, it gets crumpled.
Right.
And if you see those patients after several foldings, infoldings, crimpling, and it is very difficult to then correct that. So in such cases, you may decide to do that skin excision in the first stage only. But if it's a normal looking skin, young age, that skin actually shrinks very well. So you have to decide depending upon the patient's skin quality as well.
So next to Dr. Rajat Gupta. So regarding the drain.
So I showed you two cases. Dr. Sandeep showed my two cases, grade 4 gynecomastia, like a female breast. So that is an FTM surgery, almost like a female to male surgery in which you have to do inferior pedicle, take an NAC up, you have a scar. Or in some cases like grade 3B, which has a lot of dead space, and I've decided not to remove the skin. We have wait for 6 months for the skin to shrink. And whenever I think that there is a dead space, I might put a drain for 1 day only.
1 day only.
And that's not just to remove any fluid collection. It is basically, it's a negative suction drain. And when suction negative, it helps skin redraping and sticking to the muscle. Only that is the indication. In my practice, very few patients. As a general dictum, I don't think we need drain.
Sir? So even if you are removing gland tissues or tissue resection is more, you don't put drain?
No, I mean, see, in the past when I was doing resections, I was putting drains. But then, because a lot of it is blind, so you cannot guarantee hemostasis perfectly many times because, you're kind of thinning out the skin, going down till the inframammary fold and all. So was putting a drain, but as I said, now I've stopped opening up. So there's no question of drain.
As I said, I am drainless. Now, I have written the principles very clearly in my paper. So they are absolutely valid and I think they have stood the test of time.
I've always thought that someday I will say to Medha ma'am, never say never.
No, in fact, I recently put drain in one of the abdominoplasty patients. So it is never,
Never say never.
Yeah.
So you have to choose on the table what is appropriate for the
Some
patient.
patients are oozy.
We can't be adamant.
You never
As a basic policy, you don't, but sometimes you may need to, yeah.
Right. And the pressure garment and massage, both are very important things after post care. So what is, sir, what is your, you give the pressure on the table immediately after the surgery or on fast dressing?
I use Dynaplast.
Dynaplast, right.
So because for reasons that I want my nipples, both sides, to sit in the place I want them to. So I will only strap and I will put Dynaplast there. The Dynaplast will stay on for 7 days.
7 days?
Yeah.
You do the fast dressing after 7 days?
First dressing after 7 days.
They can't take bath.
Allergy नहीं होती?
हाँ?
Allergy.
नहीं वही बता रहा हूँ देखो. See, I counsel them that this is the best dressing. So if you don't sweat, you are fine.
But it sometimes causes excoriation.
They don't sweat in
They come back, if there's a problem, they come back any day after 3rd day. 3 days to minimum they will keep. They can come, but I have many people who come back at 7 days and they are fine. And at that stage, I see if there's no rash, everything is fine, which at least 50% are fine. And if they're agreeable, I put it for another 5-7 days. And they'll come, have a shower at my center only, and then I'll sort of put oil and all that, take care, do some skin care for an hour or so, and then put it back. Because I find if you can put good pressure for 2 weeks, you are done.
What you will do, sir, if there will be soakage? Sometimes you are not putting the drain, so there is soakage and soiling of the Dynaplast.
I haven't had a problem with
soakage.
No. I think there's such a big cavity, even if there's a little bit, it will be distributed, not to come out from that little port. So that is one thing. And secondly, after that, then I do not put a garment. I get them to get that sternal belt. And I get them to wear the sternal belt up in the wrong way side so that the Velcro is at the back. So they require somebody to, so they should open their chest, wear the belt, and it will have a bit of an issue around the axilla. Sometimes can slide down. They've got to keep kind of putting it up kind of thing, and it works very well for me. Because I found that many times garments also, even a customized garment, they just are uncomfortable. They don't wear it also. And then they tend to take it off. So
Rajat, you prefer a customized garment or derma wear ready-to-made garment, and when you advise the patient to wear pressure garment?
So always customized garment, but I make them wear on the evening of surgery before the discharge. So they are covered with Dynaplast,
right.
But I remove the Dynaplast before they go back home, see the result once again, show them the result in the mirror. They also feel happy. And then if you want to re-drape the skin, tell them to lift the skin up and wear the garment. Make sure the garment is customized. Sometimes we have also had garments which have some foam pads inside. There's a pocket inside the garment made so that it gives additional pressure on the chest. So adequate pressure is applied. And my patients can then also take bath the next day.
Madam, many people, they advise pressure garment on the table. Immediately after the surgery,
I
they
am
put pressure.
strictly against that.
Right.
That is because the patient is just coming out of general anesthesia, and when you put pressure garment, they are not going to be able to breathe properly. So I put garment on any patient only after they are shifted to the room and they are breathing. I don't use any sticking for my gynecomastia patients, except maybe steri-strips for the over the suture line. And for 4 days they are not allowed to remove the garment. And from the reason for that is for first 48 hours the capillary permeability increases. It is internal burns. So after 48 hours the capillaries start regaining their tone and they start absorbing the fluid. So 2 more days to give to the capillaries to work. Then remove the garment, have a bath every day and wear the garment. That's my protocol.
So your patients have 4 days no bath?
Yeah, because they have bath for 7 days with Beta scrub or Edit soap.
But for first 4 days no bath?
No bath.
So 7 days no bath, 4 days no bath?
No, first 7.
And your second day? Second.
Yeah, but I don't have any sticking plasters.
Yeah.
At all.
So do you prescribe them deodorants as well?
They are not required because for 7 days they have had antiseptic bath before. So कीटाणुओं का नाश हुआ होता है. तो वापस आने को 4 दिन से ज़्यादा लगते हैं.
So it was a
And
nice.
boys are always happy not to have bath. They are aligned with me.
So it was a nice discussion. So final concluding remark, madam.
So the incidence of gynecomastia is increasing and all of us have to gain proficiency in safe gynecomastia surgery because there are many quacks, as you know, who do the chop surgeries, put videos on YouTube. So it is very important to give time to the child, boy and the parents and explain everything in deep details about what is expected, what precautions they are supposed to take, and also take this opportunity to counsel them for obesity. And I think as Iaaps proud members, it is our duty to deliver top-class gynecomastia results to the patients. What remains to be explored is pectoralis fat grafting.
We'll talk about it.
Yes. So Rajat, what is your conclusion?
So as ma'am said, rightly, so we feel that each gynecomastia should be done by a qualified plastic surgeon only. But at the same time, it is our responsibility that each qualified plastic surgeon should be trained to do that adequately and properly. So it is our responsibility to be trained in each technique, adopt the technique. As you've seen, all three of us would have slightly different opinion. And that's what plastic surgery is all about, having different opinions and artistry. But each one of us can get good results. So learn the techniques, make your protocols and follow them. Make sure that all patients get good results and ensure that all patients get gynecomastia surgery done from a plastic surgeon only.
Ultimately, result matters. Sir, what is your final?
I feel that gynecomastia problem is not necessarily to be clubbed like a lifestyle problem. It is a disease, so to say. There are a few people who, I think many of them take up to not looking out at themselves because of the gynecomastia rather than, gynecomastia as a cause, especially in the teens. So all medical colleges also should be encouraging, people to come up and they should have a list where they should be doing more gynecomastia surgery. All the trainees should have learned good gynecomastia surgery in their training itself. It's not really a cosmetic surgery. That's how I see it.
Problem is many people take it very lightly.
Exactly.
कि gynecomastia तो है, but to give a good result in gynecomastia is not easy as well.
Yes.
It affects the life of the person.
So it's a 360-degree result, so chest contour, the masculine chest. So that is our aim.
It affects the life of the boy. So yeah.
Sir, thanks a lot for your all the inputs.
Jayant,
So any questions? Sir, question.
Question to three of the panelists. Out of three, the instruments we are using for gynecomastia liposuction, as far as outcome is concerned, which one is good? Like mechanical and Bbsr and power assisted?
I think at least ultrasound liposuction should be done, followed by ultrasound lipolysis. Actually, ultrasound, after that you have to do some kind of liposuction. So some amount of heating is required. That is what I feel, to shrink the tissues.
Shrink the tissue.
Correct. So if you have to have bare minimum, then one ultrasound and one simple liposuction will also do.
And Dr. Sandeep?
Yeah, I take it very differently. I think ultrasound is required only for redo if there's too much of fibrosis. But otherwise, just a mechanical or a classic liposuction is good enough. And you do get shrinkage. There is an odd patient where you will not get. But that odd patient also happens to have problems with the energy devices also. So all in all balance, there is not, I don't see the scope for using that.
Okay, Roger?
If I think I have to buy the first stool, I would buy a power assisted.
Power assisted.
Because it will help you achieve much more smoother, adequate work, faster, making yourself less tired. You see, end of procedure most commonly, whether we agree or not publicly, is when we are tired. हो गया, ठीक हो गया. So power assisted helps you do that. You will not agree, I know, because, okay, so we can agree to disagree. And the second should be ultrasonic. Although when we're talking about gynecomastia, as ma'am said, ultrasonic adds distinct advantage in gynecomastia because of heat and the skin shrinkage. But first tool I think should be power assisted. We'll talk more about technologies in my talk. We have a talk coming up.
And second question is what workup you undertake pre-operatively to roll out secondary and syndromic gynecomastia?
It's, yeah. I have discussed
it's
in
already
details.
answered in the talk.
In fact, it is very important. There is a paper from Kerala. I think it will soon be published in IJPS. My basic contention is that the hormone levels that we measure, they are the levels that are seen in the society. If you see, the range is very wide. So we don't have any studies about receptor density, sensitivity and hormone receptor interaction. So if I have a low hormone level, it may still be too much for me. So till that comes up, there is hardly any advantage of hormonal testing unless you find something like Klinefelter syndrome. There is something syndromic pointer is there. It is a waste of money for the patient.
My question to everybody, actually anybody using the power assisted liposuction, micro air, how do you decide the cannula? Which cannula is good for gynecomastia only? It is a tripod helix or Mercedes, or how do you decide?
So I usually started with 4 mm Mercedes cannula, which was my workhorse. Slowly and slowly I moved to basket cannula, and I use 4 mm basket cannulas a lot, both during infiltration and suctioning. Only thing is, it's a very aggressive cannula. You should not be static at one place, and it can cause contour deformities. So you need to be, otherwise Mercedes is
otherwise the actually company, the micro air company, there means recommending the tripod helix is for gynecomastia. But I am finding Mercedes is also good. Means
it is good.
See, Mercedes will work in periphery better because there is not much of fibrous tissue. Whereas in the central part, the basket will work better because it will take away the cores.
Only thing is, with basket you need to be careful.
Yes,
because it is very aggressive.
careful.
Suddenly you will have a contour deformity.
Especially under the nipple areola, because you can go really deep and...
And my second question is, how do you decide the infiltration, whether it has to be a superweight technique or tumescent, how much you have to infiltrate for a grade 3 or grade 4, means how do you decide according to the grade of the gynecomastia?
So I usually infiltrate till I feel the turgor, and I feel it is good enough. Usually when I see how much suction we have done, it's usually 1:1, so it is tumescent. And I think it's good enough, and especially because we do it under either sedation or general anesthesia. Only in patients who are doing it probably awake, without sedation, you might have to do more because of analgesia effect of lignocaine. Otherwise, I think this is good enough.
If the
So
gynecomastia...
1:1 is actually wet technique, which is what I always recommend. Tumescent is 1:4. That
Yes,
is too much. It causes tissue edema. So basically, Rajat is right.
It is weight technique, not superweight or tumescent.
Superweight is 3 times, yeah.
Right. And if the you are means clinically you are judging it as a more glandular tissue, do you recommend much little much more tumescent fluid? Because many times.
Yes. The second thing what you can do, if you're not infiltrating with power assisted, once you have infiltrated enough, before suctioning, take normal cannula, aggressive cannula, and go inside, make movements and break the gland so that the infiltration will become smoother and the area is amenable to suctioning easily.
Thank you. Thank you.
Thank you. Thank you. This concludes the session. Assis, you would like to ask something? One question.
My question is, gynecomastia is a psychosocial problem. So we reduce the bulk by treating the disease. But what problem we see that the size, shape and position of the nipple areola complex. How we can manage this for a best nipple areola complex after the surgery?
See, ideally the position of nipple is mid-humeral length, right? Mid-humeral point. Drop a line or fourth inguinal space, or from humerus to elbow, the midpoint should be the nipple. For grade 1, 2 and small 3, right? It usually shrinks back to that position. For grade 3, which has excess skin, you might do a periareolar lift or wait for the EBDs or time to happen for 6 months and then see. For grade 4 and especially female breasts, which results are shown, you will have to do a nipple areolar lift to get that shape, at position. Otherwise, you can't do it.
So, sir, last question, sir.
Nice discourse, brainstorming, panel discussion, anchor being Jayant Das, sorry. My question is, in fact, in the secondary, when the complication to arise about the nipple height, and also if there is a little depression of one side, how do you handle in such cases?
Correct.
And if the heights are
not in the... You can release that and then you can make a substation and make a platform again to get that.
So you can get a normal result after that?
Near normal, depending upon how much of wrinkling, what Rajat was talking about you have.
One of my teacher always used to say, when you're doing gynecomastia, first of all, keep 20-30 ml of fat handy with you on table, so that at the end of surgery, if you feel depression, you correct it immediately at that time.
Yes.
So he would always do that.
Lipofilling.
Two sides should be done by two surgeons or one surgeon?
It depends upon whether the two surgeons work so much together that they are almost like one surgeon.
Like
Otherwise,
like cricket, you mean to say?
Otherwise, ideally, in any surgery, should be done by one surgeon.
Yeah.
Thank you.
Thank you. Thank you, sir. Thank you, sir. So this concludes the session. Let's have a short lunch break. Then again, we'll resume the session after 20 minutes.
So welcome back to the post-lunch session. I hope everybody had a good lunch. So the first topic for the post-lunch is setting up aesthetic surgery practice. Presented by Dr. Sandeep Sharma.
Hello, hello. Hello. Can you hear me? Mic chal raha hai? Mic is on, na? आवाज आ रहा है? Yeah. Now we start with our post-lunch session. This setting up an aesthetic surgery practice, this is mainly for the youngsters here. So, can you guys come here? Get your chairs here and come, na? Then we can talk. Aajo. Yahan se you can hear. ठीक है. Okay, then I'll look this side only. Yeah. So now, what are the things? How do you go about deciding when you want to set up your practice? I mean, you can. It's a generic word that it's aesthetic surgery. It could be, anything plus minus as far as surgery is concerned. Oh. क्यों blank हो गया? बड़ा सा blank हो गई इसके अंदर screen. हाँ, आ गया. Okay, so I have got my own aesthetic surgery practice, and in December this year, in a few months, it will be 15 years in that premises, and it sort of gives me satisfaction to see that I'm maintaining it very well, which means the teamwork is doing well. So, अभी क्या है? Oh, I think I'm pressing. Yeah, so when you have your own setup, you have people visiting you, and that gives you more reassurance of what you're doing is good or not. So now, the important thing is that when you're doing cosmetic surgery, you have to have good quality. And because you're dealing with what we perceive as normal people, you cannot afford complications. So basically, if you do it in your own setup or on one setup only, you can improve your quality of work. You will end up having less complications, and you will have less stress per case because the team will be the same, the environment will be the same. So you can concentrate on improving your results rather than worrying about so many other things when you are going to a different setup all the time. So you do not grow as much as a person. You help other setups grow, but you do not grow as fast or as much as you can with the effort you're putting in, right? So now, yeah, so when you're setting up the practice, that you got to be sure and certain what you want to do. Some things are going wrong out here. My slides are splitting up. Okay, yeah. We continue. Sorry about that. Thank you, Rajat, for getting this right. Okay, so when we look at setting up practice, basically there are two kinds of people who are there. One group which is sure and certain of what they want, and the others who are unsure and undecided, are hesitant to kind of take up the next step about going into practice, right? So there are basically two scenarios. You got to see what timing in your career you want to take a decision. So whether you want to get into practice early on, mid-career, or later. So these things should play in your mind, and that you have to kind of take a call. And based on that, you make further decisions. The second is place of practice. Whether you're going to be practicing in a metro city, tier 1 city, tier 2 city like Bhubaneswar, or tier 3 city, because that will decide what kind of patients you're going to get and what kind of skills you need to have. No point in having skills which are not going to service the patients which you're going to get or you're not going to get. So basically, you have to have a plan. And the reason I'm telling, I want to talk to the people in the first year, earlier years of the practice or in training, is so that you learn to think that you got to make a plan. So again, and you got to make a plan, and then you got to stick to the plan, because anything to fructify, just like your MCH, you got to stick. Only then you get a degree at the end of 3 years. So 3 to 5 years is what you plan for. So decisions when you make, when you decide to go into practice, is what team you're going to have, right? And whether it's going to be ownership or corporate, right? Whether it's going to be solo or it's going to be in a group practice. Whether you're going to have it like a family practice or you want to make a group with your colleagues to do it. Whether you're going to enter a multi-speciality practice or whether you're going to be only plastic surgeons practicing together. So these things have to be decided. And also, whether you're going to be doing in plastic, whether you're going to do general plastic or you're going to go into a niche like only micro, only aesthetic, or only facial surgery, those kind of things, you got to take decisions. The second decision is again what kind of services you're going to give, aesthetic only or aesthetic and reconstructive. Now, well, if it's going to be both, then you got to have preferably separate premises, especially if you're in a tier 1 or a metro city. And but I personally feel that at least in the first 10 years of practice, you should not give up reconstructive surgery unless you're in a metro city where dynamics can be a bit different. So because relative to aesthetic surgery, reconstructive surgery, you are more trained for, you're liable to give better results, and compared to both incomes, you make easier money in reconstructive surgery. So whatever people might say, whatever other specialties might say, you should stick to reconstructive surgery as well. Third decision is location. So it's very important that you got to have a location which is visible. You may have to spend a little bit more initially for a good location, but it is very important to have a visible location. Again, you have to see access, and that also makes a difference. The next is budgeting. How do you decide how much you're going to be spending on doing that? So budgeting is of two types. The money you put in and the time you put in. Because money is going to increase with time, while time is going to reduce as you go along in life, right? So basically, money you got to deploy it and have a plan how you got to do it. And same thing, with time you got to keep working in such a way that it keeps freeing up your time as you go along. So the more senior you get, the more time you should have at hand. The younger you are, the more busy you should be doing all the hard work. So that's kind of the way you kind of budget your money and time. Right? The next is finance. So it's for the setup, either you need to take a loan or you can use your own family funds. If it's a loan, you got to take it from the bank, and if you're taking it from the bank, you got to know so many things about the rate, the terms of the loan, the type of account you got to open, whether you open. So all those things are important to understand. If you don't know it, you got to have somebody who will explain to you. You got to understand about cash flow, and these are not very difficult things, because you got to understand that people who were in your school who were much below your grades, below your IQ level, they are doing all that. So why can't you do it? So don't have a sort of a thought block that you can't do it. You should be able to kind of handle your own money, right? After all, you work hard for it, you should be able to handle it. And also the savings and investments, those things also are important to do. So the next is management. So the bigger your vision, more professional one should be. So as they say, money attracts money. So have a big vision, have a big plan early on, so that you can chase that, and you will not sort of have fear of taking risks, as well as putting in more hard work. So, well, I personally, I'm not from a business family, so I didn't know what too much to do about it. After a while, when I thought I was struggling, I did a short course at the Indian School of Business, and there I sort of learned a bit more about healthcare management. And because there were gurus there, they gave us lots of good ideas how to kind of handle yourself. Basically, handling business is more about handling yourself, and handling yourself is about how you handle your time. Because if you've got more time, obviously you can do more work. So it's all about efficiency. So I'm sorry, all these things have just shifted out, because, all this says is the team that you're supposed to have when you set up your practice. So what works for your practice, people who are here, who are senior and in well-established, they will know that loyal staff is very important. Trained staff is very important, because with trained staff, then it will free up your time and mind, so you can apply it to newer ideas, either relaxation or getting ahead. And also that you have to be available. A doctor has to be available. He cannot be online. He cannot, do remote work. So you have to be there. And also, you've got to, like there was a question they were asking about, how do you convince a patient? So you have to learn that art of connecting with patients. I'll tell you more about how you also do that. So, and it's an art. It's some people have it, some people don't. And when you look back at your school friends, you'll find many of them are much more successful than a doctor. It's just because they have the art of communicating, they have the art of connecting with people. So people very easily put faith in them, put money in them, to get their stuff done. So now all that is what works. What doesn't work is false marketing and over marketing. It may feel good initially, especially for the youngsters. I know of people who have come into practice, they've immediately signed up with a social media company, paid 1 lakh rupees, 2 lakh rupees, because they promised them, oh, we'll do so much of bombarding that you'll have a rush of people waiting for you, and nothing happened. So then you are now, not only you are behind, you are actually way behind, because you're also minus 2 lakh rupees. So those things you've got to be careful about. Again, and then a big thing when you go into practice is, how do you charge? How much do you charge? So you've got to make your own list. You've got to understand what your services are worth, where you're practicing, who are you serving, and accordingly you have to have your own charge list, which if you're good, if you're upgrading yourself by attending workshops, conferences, training programs, you should be also revising your charges upwardly 5 5% at least each year, because that's what it took you to get where you are. Again, you should always be meeting a chartered accountant to know at least twice a year, to know where you are, where you are going, where to cut costs, where was a bad judgment, so that you can, from bad judgments, you make good judgments, so that, you kind of keep reinventing yourself and meet things in a planned way. So ultimately, you're all doing all this for success. What are your success parameters? That's how you kind of plan backwards. Is materialistic, that is how much money do you have, how empowered you're feeling, and what recognition you got in the city or town where you're practicing. The other thing is satisfaction, that how satisfied you are with having achieved the goals which you wanted to, and whether you've got some dreams and you've got a bucket list, and how many of them are you achieving in the time as you go on. And ultimately, you got to lead a balanced life, and to me, this is the key word for all doctors, because we work very hard in the 20s. We do not balance ourselves, because that's what we are told, that, do all the hard work, you got a life to enjoy. It really doesn't work that way. You got to also kind of keep doing the right things at the age-appropriate times. You just do not want to leave everything for the later part of life. So here, this is sort of a book which I would recommend. This is a book called Harvard Business Review, and it has got 100 articles which have been very meaningful for management over the years. And as you can see, I don't know if you read it, there's one article which says managing oneself. That's very important. If you're calm and composed, you can also look after people. Yeah, lead with authenticity. How to be an authentic person, how to be you yourself, and convey yourself to people, to society, to patients, to family, and and be the leader. And time management, very important. 9 things you should do differently. How do you there's a science in persuasion. So how do you persuade people around you to be with you, so that you can lead, and why, and also very importantly, why you should have 2 careers, as in you should always have 2 sources of income. Usually in our context, it is investments. So yes, enjoy life, as you work hard and be successful. Thank you.
Thank you very much, sir, for your wonderful girls session. There are lot of eye-opener things also, what you said. So next, our panel discussion, challenges faced in aesthetic surgery. I would request Dr. Sandeep Sharma, sir, to be the moderator, Dr. Medha Bhabe, ma'am, Dr. Jayan Das, sir, Dr. Akshay Raut, sir, Dr. Bansidhar, sir, and Dr. Rajat Gupta, sir, to take up the stage. So this is now panel discussion, these challenges faced in aesthetic surgery.
Hello.
Yeah, though this is called a panel discussion, it's basically we have a set of panelists here, and we have people from different interests, hello? Yeah. So it's going to be an interactive session. So this is more the idea of the way we had the discussion in the previous panel, that you ask questions, and there are sort of 5 of us answer questions in their own ways. Basically, this is the thing of challenges you face in aesthetic surgery, practice which affects our life and which affects our big decision making. We discussed a lot about procedures and how procedures can help make our life easier, can get us ahead. Also, this is based upon decisions which are going to help us lead a better life. So, I'll start off by asking the panelists, the first question is, what is the biggest challenge in your practice? Meda, starting off, which is for the youngsters, the next level, and now maintaining yourself.
Hello. So when I started practice, that was in 1996, there was hardly much concept of aesthetic surgery in the society itself. It was actually limited to Bollywood celebrities and Dr. Narendra Pandya and Dawar in Mumbai. But my teacher, Dr. Swaran Arora, was visionary. She gave me thesis on liposuction and we did 25 cases. And I still remember my examiner really chiding me, saying that you cannot do gynecomastia with liposuction. So now I really feel that the examiner should come here and see. So it was really a great challenge to align the concept of aesthetic surgery. But for me, it went comparatively easy because my husband is a very renowned and very good physician. And because of him, there was a basic medical trust in us as a couple. So he also took 2 years to refer patients to me. He also saw how I was working. And once I started, then I didn't look back. And slowly, the entire society around me rose up to that idea about abdominoplasties, liposuction, slowly breast implants. And then the society itself advanced. Now I am again in a phase of little bit of challenge. I do have my own hospital with a very good OT and I have lot of equipment. I love technology, and I like to put it in the right perspective. So I have, but now the social media has evolved so much that there are a lot of semi-plastic surgeons, non-plastic surgeons recommending, making a huge propaganda. And for a person who's used to mouth-to-mouth publicity, it becomes a little difficult to stay put in this era of social media. I find it a little hard.
Okay, Rajat, to you decided to take up cosmetic surgery in a metro city, right? So, and you did not have anybody to follow. So, what was your challenge when you first started?
So, at this start, I always wanted to become an aesthetic surgeon. So, but when I came into practice, I used to do freelancing as well, trauma, and AV fistulas, micro. But after 6 months, I stopped doing it. And at that time, I did not have enough work for aesthetic. But I decided that from tomorrow, I'll not do it. And it also because it's a story. I did a microvascular for which I was paid 3,500 rupees, and I was like, shuck it, I'll not do it from tomorrow. So, anyway, so the challenge was to make your name. One of the hospital where I used to go, the general surgeon there, the head, his advice I still remember. It is very difficult to make a name in a metro. There are a lot of plastic surgeons. I would feel probably in a tier 2, tier 3 city it is easier. They will have their own thing.
Everybody.
Yeah, exactly.
Yeah.
So yeah, nothing comes easy. But there is a lot of struggle as of now in Delhi also. There are senior plastic surgeons, like 15, 20 years senior to me as well. Enough practice, but still doing, say, gynecomastia 25, 30,000. So there is a challenge from non-semi plastic surgeons, but there's a challenge even from our own colleagues that even after so much experience, so much amount of work, downplaying and what I say is charging so less, then undercutting, then who will come to a newbie, right? So it is a struggle at that time when you think of that. Then you start entering into thought process, should I enter into referral practice, commission-based practice or not? So that was, I was very clear, we'll never do it. So the point which I'm trying to make is we decided that we will be most expensive. We cannot be cheapest. There will be someone who is cheaper than us, both surgically, financially, as well as behaviorally. So we cannot be cheaper. Let's be the most expensive.
Those are good words for you.
So
right?
from that day, now it is funny. Till date, every 6 months, 1 year, when we raise our pricing, we get more patients. So there is a subset of patients who would want the most expensive one as well. But it
people
comes
who want the Rolex watches, right?
So
to us it is Rolex mein kya alag time.
But it comes with its own rider. Your service has to be of that level. Your hospital, your infrastructure, your results, small things which you would want it to be absolutely finished. Even, when I made up my center, I went to buy very good cutlery as well. So all those things have to be ingrained in you as a person to help achieve that and create that ambience as well as the surgical results. So that was a challenge initially. I clearly remember those days that I should be doing at least 2 surgery a week, and I'm the happiest. Like 8 surgeries a month, I'm the boss. And then the challenges change, because then when your team becomes bigger, then your challenge is it should be 2 surgeries a day. So that kind of thing starts cropping in your mind to be consistent. And now the next challenge is कि ऐसे results आते रहें, कुछ गड़बड़ ना हो जाए. मतलब you should not get complacent.
To be successful, you also have
yes. So then how to remain consistent is another challenge. So initially that was the challenge.
Dr. Jain?
Yes, my biggest challenge was to cross the barrier. Rajat crossed the barrier after 6 months. Rajat is...
First thing, when you...
Yes.
No, not aesthetic practice.
Then I practice. That's what I am telling. I came to Odisha in 2011 from Delhi. Rajat is 5 years junior to me. So there is an orthodox thinking. So don't take aesthetic surgery first. You do everything, then after 10 years, take aesthetic surgery. So my piece of advice to all youngsters, if you like it, you start it as early as possible, because other specialties are encroaching, and you have studied a lot, MBBS 6 years, then PG surgery 3 years, then super specialization 3 years, so 12 years study. After 12 years study, so you are fit enough, you are capable enough to start aesthetic practice. Yes, initially patient numbers will be low, but if you are determined, decisive, consistent, then you will win. And don't go for advertisement initially. Start doing good work, and advertisement will supplement your good work. It's not a substitute.
Very true.
Absolutely.
Yeah. Thank you.
Very valid points. That when you want to take on any practice, in this case we are talking about aesthetic practice, earlier rather than later is better. But then as with any journey, if you're not prepared for the journey, you cannot undertake a good journey. So that's why Iaaps says also for the last 3 years or 4 years, we have been putting out so many programs of teaching, upgrading, so that people who graduate can immediately, through short multiple courses, have the confidence to deliver certain decent results, right? So that's a good thought. Thanks.
I will share my experience in a city like Bhubaneswar, which is a 2-tier city. I disagree with Rajat also. In metro city, there are lots of patients. That is the ocean. And our city is like it's a pond only. So few patients without awareness, and people whisper about he or she is undergoing cosmetic surgery. That is a social taboo also at that time. So after passing out, means from PGI, then from Dr. Bangu, I joined with Dr. Jena there in Osini Hospital. Whatever I exposed maximum cases with Bangu, then with Dr. Jena, I learned that how to connect with people, how to talk in a business sense, and what will be the outcome, and what you will talk to that patient that he will be impressed. That thing I learned from Dr. Subraj Jena. Then I started solo practice in Bhubaneswar. I opened a small clinic. Most of the time what happened, no patients, but my boss, Dr. Gautam Biswas, told me that whatever the situation, you sit there, and after some time patient will start coming. And what I did, I choose and pick up a few celebrity patients. I did liposuction in 5,000 rupees. I did breast reduction in 20,000 rupees. And those group of patients, they started bringing patients to me. And that time social media was not there. I give an article in Times of India, in Delhi local here, create awareness in Rotary Club, in Lions Club, Surgical Club. Everywhere I went there, I present my case. I push to sell my product. So once they see the result, then patient will bring the patients. That is the self-advertisement. So, and other thing, one most important thing, don't tell lie, don't give over expectations. Two things has to be, because if you tell lie, initially I was telling lie. And I also trapped in between. One patient I did a derma abrasion. I charged 12,000 rupees. I told 100% will go. But he was a journalist. He published in paper that doctor has cheated me, so return my money. So from that only I learned, whatever result you are able to give, tell the patient that this is the result, and they will be quite happy that they will come to you and do the surgery. If that is not your patient, he will not come to you. Many shopping patients are there, they will not come to you. So don't leave them, but give quality, and skill is the ultimate which will stand you in the society. That is my practice.
Very nice and endearing words, and they came. Yeah, very nice and endearing words, and they came from his heart. And this is really true. Authenticity is very important, not only for work, but also to define you as a person. So you kind of fall in love with yourself, and that's when you can sort of deliver even better. So yeah, thank you very much.
Hello. I joined in Bhubaneswar in 2014 end, November. I was trained in R&R hospital with, actually from the beginning, some good exposure was there in aesthetic and cosmetics from R&R. Then I worked there in Gangaram for 1 year. Then I came and joined here with a mind that from the beginning only I will start doing aesthetic surgery practice. I started also, but here the problem is the requirement of people for aesthetic is less. Number of patients are less. The payment means for, they are not that good in, means they don't want to pay much in cosmetics and aesthetics. That is another problem. So you have to start your practice in a very compromised state. That is another issue. And also simultaneously for nowadays there is very hue and cry advertisement about the different kind of gadgets. Means same thing can be done with a derma abrasion, but you must be having a laser, you must be having a many different gadgets. So if the paying capacity of the patient is not good, so it will be difficult to keep all the gadgets in your clinic. So that is a challenge what still I am facing.
See, everybody faces that, but I feel the payment part is very subjective. I feel that's where probably my lack of business background did not help me for a long time. It is the way you get them. See, I have people who will go and bargain with my staff outside when it comes to consultation payment, and then same people will be having a meal worth 3,000 rupees.
Yes.
How did they suddenly, so what is affordability?
Yeah.
Yes.
Affordability is just the willingness to spend. So, and the willingness to spend is based upon what you create.
Yes.
If we are playing on the back foot, then ball is always going to come up only to us.
And I am also attached to a corporate hospital. So there, let's say, if you are going for a gynecomastia surgery, the cost is around 1 lakh rupees. But if you are having a own setup, it can be managed in 40,000, 50,000.
But that is because we start deciding to manage it.
Yes.
See, the message from Rajat and Dr. Medha is the same thing, that you don't want to go down a stream.
Yes.
You want to make your own path, especially when you're saying that there's no path. Then you have to make your own path. And if you're making a downhill path, then you will not see the peaks. So So that is very important for you youngsters. If you want to undertake practice, and I don't mean only aesthetic surgery practice, any private practice, you've got to empower yourself with business skills. And that business skills is not only about, those are the points I made, all about finance to persuasion to communication to setting up what is your value. That has to be done. And your body language tells. You can make out when you go to a shop also, you can make out which shopkeeper is willing to bargain and which shopkeeper not look at you. The minute you try to tell them, "Ke thoda kam kar do," they'll just move away. Right?
I found it comfortable to go with both the things, means reconstructive and aesthetic simultaneously. Yeah. That's what I am doing right now.
The other challenge when I thought was important at that time was to learn aesthetic surgery. When we are residents, we used to see Hoyo's results, right? And we wanted to create Hoyo's results. How to learn that? We did not see in our department anybody doing much liposuction. Where to go? Who to go to? And if I can dare say, if during your residency you ask your boss, I want to learn aesthetic surgery, you are so looked down upon that you are the worst person in the world. You would want to dig up your grave and bury yourself dead alive. That is the kind of look your bosses used to give at that time. I don't know now. I have heard things have changed. Yes. So to learn, and then I tried to connect with Dr. Hoyo's team. They asked for 15 lakhs. How will I get 15 lakhs of money? Right. So it is difficult to learn also those things, where to go. And in last few years, 5-6 years, Iaaps has taken that agenda and we are doing so many workshops, training, even the conferences levels have increased, so things have changed. But training also yourself to go those results is actually a challenge. And especially when you are talking about social media marketing, if your results are not good and you do social media marketing, it's a double-edged sword. You're gone. You're gone.
Yeah. True. It is like a tripod. Right. So as Doctor was saying that he went to Dr. Bangu, right? So Dr. Bangu is a very good teacher. He's a very good clinician and technician, and he is actually trained a lot of people or introduced a lot of people to good quality aesthetic surgery. So, but then coming back, he didn't have the business acumen. I don't know him in that sense, but I still presume that you have to have that acumen to develop. So I think it is all of that together which makes the the dish. It's not only just one pure ingredient that sabji hai to ban jayegi. You need to have all the masalas and everything to be able to get something which is palatable and people are willing to pay for that thing. So those are the things which you need to know. We'll take a halt out here because we don't want to have a very long discussion. We are behind schedule. We want to have any questions. You people have any doubts, especially the youngsters, I would want them to ask first, and then the seniors can ask a few questions. Anything you have any queries about your training, lack of training, future fears? Sorry?
So,
Iaaps. Iaaps vision, Dr. Sanjay, has been quite progressive in the sense of that we want more people to become members. Ideally, every plastic surgeon of India should be a member of Iaaps. That is our vision.
Yeah, in fact, with that view, Iaaps has worked on aesthetic surgery insurance, and we handed over all that work to APSI so that everybody gets insured as cosmetic surgeon and then at least become Iaaps member.
See, I'll just tell you a few things. They are conducting courses regularly. We're almost having a CME every 3 months, a substantial CME. Or even more actually we are having. So that is one thing. We're having workshops. And there are, operative workshops also. Both live operative workshops also are there. There are fellowships which have been encouraged and started so that people can go, and we are keeping a monitoring eye on who's doing what. Obviously not everything up to mark, but then they've got a lot of people who are, a lot of time they're giving to kind of make sure that happens.
So may I say something? Now I am talking as Vice President of Iaaps. We are planning to make a faculty bank. We recognize the fact that there are not too many aesthetic teachers in government colleges for obvious reasons. It is not wrong if they cannot do much aesthetic surgery. So we want to make a list of people who have done considerable work in private practice, have some published articles, original concepts, and we will have them go to various institutes. Like when I got Bbsr visiting professorship, I went to Assam and Bbsr and performed abdominoplasties. So something on that basis, we will spend our own money, come to your institute and demonstrate cases. That is what is my plan.
The other thing is Iaaps fellowships also started, sir. A lot of medical colleges have now ingrained compulsory rotation at different aesthetic surgery centers. So at my center, we get from KMC Manipal, Safdarjung, CMC Vellore, and even TMH Mumbai. I hope from AIMS Bhubaneswar also you send your residents to other rotation centers.
Invite us to do aesthetic
yes.
surgeries at AIMS. We will come.
Mike, please, sir, Mike.
Even if you see in NMC course also, in plastic surgery MCH, whatever is there, till now it is not, this criteria is not being fulfilled by many of the institutes. So we have to be a little bit of stick onto these things. That
Sanjay,
I
sir, it is there is a vision.
Responsibility also.
See, Sanjay, there is a
Plastic
vision
surgery
behind doing that. I'll just, because that started a few years ago. The vision is, number one, more and more procedures are done by unqualified people. We make such a lot of effort and hullabaloo about proper training, and then we get somebody totally untrained doing majority of the cases. So we are trained and doing nothing, while they are untrained and doing everything, which is a sad situation. So, do you know that the Dental Council approved that hair transplant is a dental procedure? So with one stroke, they became official people who could do hair transplant. Same way, so what we have done is we've included this list, and so that this is put up so that this becomes our domain. So first is have an ownership. So that is what we've done. Next is comes to how to train. Now the second thing is we started this group of aesthetic teachers, right? That is so that so that people, all heads of department become sensitized that this is our subject. You may not know the surgery, but at least you should be able to examine a person on that. See, ultimately a teacher doesn't need to be able to be an expert on everything, especially in plastic surgery. So even if you can examine a student, and for that what Rajat is saying, that people go to institutes and learn whatever basic is required. So if you've got the basics of aesthetic surgery right, it's good enough. Because most people in general surgery would not have done majority of the big surgeries even after 3 years of general surgery, right? So that's okay.
So also, when I was secretary, under guidance of Milind Wagh, Dr. Milind Wagh, we have prepared aesthetic surgery curriculum, and it is really level-wise very structured curriculum, and we are requesting all the teachers in medical colleges to forward that to be included in MCH plastic surgery curriculum as a part of it, so that when there is a uniform curriculum everywhere, then we automatically are pronounced as qualified to do that surgery. Then comes the training.
That's what's going to raise the level of education in the country, right?
I have a question, sir. I have been a medical college teacher for last 3 decades. In fact, in our course, there was no aesthetic surgery as a part of it. But the recent past, I think 6 years back, the Medical Council, then NMC has approved that these are the procedure has to be mandatorily done by all MCH students at different levels, first year, third years. So I went as an external and also inspector to BJ Medical College. They were not getting their recognitions for MCH. The reason being, they are not doing any cosmetic surgery. So I was an inspector, I asked, why don't you do liposuction, rhinoplasty and breast augmentation? These are procedures, you can do it. And you know who are the faculties there. You are the secretary of APS. And So they told, sir, the admission came down to me. How is it you are talking cosmetic surgery to be done by plastic surgeons in plastic surgery? Because you are going much back, 18th century. We are in 21st century, 22nd century. These are basic things to be learned by a MCA student. And if at that level, this is compulsory by the NMC, why not we undertake that? So that is the problem that most of the institutions in India were giving the MCH or DRLP courses. They are not practically involving students for going for this.
Sir, I think that is a pipe dream for the moment. I think as what Rajat is saying, they should be sent for short fellowships to get exposed to good college rather than set out.
I think the mindset has changed, and the number of cosmetic surgery patients they have increased also, and all medical college, irrespective of whether government or private, they should be proactive in teaching aesthetic surgery to MC students. Because after
in SOA.
Yes, sir. Yes, sir. They have a good exposure. And sir, we are the first person to have the power-assisted liposuction.
Because of the ultimatum that came later.
Not ultimate. In some also. Okay. So it is the mindset. Mindset should change.
Change in the sense, while teaching and training them hard. But commerce part we do not know much.
True.
And that is actually hampering the young students nowadays.
I think that is what
that commerce part, even I don't know how to handle with.
I think plastic surgery has too many subjects under itself. If you talk about urology, whatever you are trained in your MCH, you go and do that. But paradoxically, majority of the teaching institutions teach less than 5% of the aesthetic surgery. 95% of the, just like Dr. Rajat Gupta, who was trained in microsurgery, he was doing T-flap, he was doing Bbsr, he had to let go all that training, hard work he has done in his MCS to take up a subject which he was not trained for. So I think a time has come where MCS, aesthetic surgery, if it's not coming now, in another decade, I am sure MCH aesthetic surgery is going to come.
I don't think though I've let it go. Okay, I don't think I've let it go. Micro probably gives me my surgical hand. Micro probably gives me the surgical finish and the confidence. Also.
Yeah, fine. But if for 3 years you toiled to do a finger implantation and now you are not doing it, it's a waste.
No, so it's not a waste. That's a waste that I read Krebs cycle also, sir.
That skill has gone into...
I think you should have all the knowledge in your armamentarium. And it depends upon your setup, your use, whatever you will use it, you use it successfully.
No, fine. Suppose you want to do aesthetic surgery, why not get the entire 3 years pure aesthetic training? You do breast reduction, breast reductions, augmentation, you completely get trained for it and then go for it.
Then you'll be a technician throughout life. You're only doing 2 things, like the cardiac. I never wanted to be a cardiac surgeon.
The flavor of plastic surgery is to innovate. There is a basic set of principles based on which you customize a solution. It might be micro, it might be for a trauma patient, or it can be aesthetic.
Yeah, let me tell you, I do all spectrum of plastic surgery and I do it in good numbers, but my feeling is always we are talking about this because this is inadequate in all the institutes.
I feel we should not divide it into 2 at all.
I personally feel that when we do everything, the most difficult thing which we forget to do is, after doing everything, we should realize that these are the 4 or 5 surgeries I will do and stop doing others. That is the most difficult thing.
Yeah.
I'm struggling. One of my mentor actually told me 2 years back to stop doing breast surgeries now. I said, I love making breasts. I can't stop it. He's after my life till date. You now only do body contouring, stop doing breasts. Let Priya do the breasts. So, the problem is this. When you leave certain things, we are not ready to leave. You know, you have to now, after learning everything, you have to then start focusing on few things. You know, as in abroad, there are some people who will just do noses. There are some people who will just do facelifts. Because our inherent insecurities and love for all surgeries, both of these, we are not ready to leave a lot of things That's why we are not excelling in few things.
And we should have guts to refer to a right aesthetic surgeon or right microsurgeon or call, if required, each other.
Even in a city like Delhi, as of now, there are only 4 or 5 only pure aesthetic surgeons. There are a lot of aesthetic surgeons, but if they get a free flap, they'll do a free flap. If they get a cleft lip, they'll do a cleft lip. Only 4 or 5 people are there who will not touch it. They say, we don't do it. I know who can do it. You go to them. Unless we develop that, then that person will also send the breast augmentation or tummy tuck to me, because they know that he's good at that. As a society, we all should start realizing that we have to then start having a tunnel that this is what I'm doing and I'll not do the rest.
Pretty much like jack of all, master of none.
I didn't want to say that.
That becomes jack of jugaad.
Sir, I have
the
a
last question to you.
Sir, I have a question.
Sir, one. Yes.
Ashish.
Yeah.
Sir, after that you will tell.
Ashish.
Ashish. Yeah, tell.
So, in my view, actually, patient is the best teacher. Unless we get the patient, we cannot do. So, we must do the regulations so that we can protect the encroachments from the other fields. So, we must be careful. Actually, I always tell 2 things. We must be careful for the encroachment. 1. Number 2 is proper fees or fee structures like in BSQI or Ayushman Bharat, even in private practice, should be noted. Actually, we are seeing the hair transplant in Odisha, in Bhubaneswar, doing everybody. And in 20,000, 10,000 rupees, they are doing hair transplants. Actually, that is one thing. And most important is to protect the encroachments. Our national association should make laws, regulations, or rules to protect us. Thank you.
I'll answer that. I want to answer that.
Dr. Ashish, our association is not a regulatory body.
Ashish, listen to this. First of all,
we are not a regulatory body.
We are not a regulatory body.
Sir, we are a group of individuals.
Yes, sir.
So we cannot set out any laws.
We can create social awareness. We can create social awareness.
So not only social awareness, we have to force the law enforcing bodies like member of parliaments, the bodies who are member of standing council.
I think Rajat, Dr. Jain, can I close this now because we are running short of time? We'll continue the discussion at the end.
I will just answer with one thing. You said 10, 20,000. You know, the most expensive hair transplant surgeon is also from Bhubaneswar. Yes. You don't know this, okay?
Yes, I know.
So it depends upon individual also.
No, that time is, sir, actually when we ask these questions to our teachers, they always tell us, do the best and you will get the patient. Now, but the time has gone. So we have to protect ourselves.
Let us, sir, I am missing one important question.
Yeah.
Like in Ganga Hospital or Institute of Orthopedics, can we not have an Institute of Cosmetic Surgery or Aesthetic Surgery in India? I don't think any state having. The reason being I am talking that institute means a team of people who will be doing cosmetic surgery. Now in solo you will find every state you will have lot of people. But in team like South India, mostly I am not giving examples of places, you don't have a team.
Sir, it will
Everybody individually wants to get name, fame and everything. That is the biggest problem.
You are actually predicting it, you are not asking. It is going to come. Yeah. Next 5 years you will have big groups. Yeah. Thank you very much.
Thank you very much, everyone, for a gruesome session. And perhaps it might have woken up from sleep, everyone from sleep. And thank you very much, sirs. And the next session is abdominoplasty, marking to execution by Dr. Medha Bhave, ma'am.
Good afternoon and welcome to this post-lunch session. I hope you have cooled down after the heated debate. So abdominoplasty, marking to execution. I think my paper in Indian Journal of Plastic Surgery was about drainless abdominoplasty. And now I can say that drains can be definitely avoided in abdominoplasty. I am not going to go into the details of paper, but one thing I want to make clear that I am not using any progressive tension sutures, quilting sutures or glue. Then how do I do it? So only one important concept from my paper I would like to share with you, and it is applicable in almost all the surgeries. Basically, rolling out fluid after liposuction, they have used abdominal mops, they have gone to the kitchen and brought balloons and pizza rollers to drain the fluid. But I don't think it has been effective. Why not use the cannula instead? Our own liposuction cannula is kept inside. Then you continue to suck without much to and fro movement and roll up the envelope around the cannula, squeezing out the residue. This brings out serosanguinous fluid and the broken fat. Can you see the serosanguinous fluid coming out? And at the end of that, the broken fat. And this actually, it is like post-lunch cleanup. The entire milieu interior is cleaned up and then you don't need drains. There are many other small steps, but today's topic is different. So this is my drainless abdominoplasty patient, and I use this to tell everybody how abdominoplasty is a very, very important functional aesthetic surgery. Aesthetic surgeons are caught in the mindset that aesthetic surgery patients are very fussy, they want it for their vanity. The society feels it is a luxury, because that is the reason why Dr. Chaudhary shared the experience that BJ Medical College, they were not allowing a very good faculty there to do cosmetic surgery. But this is a standing example how abdominoplasty is a functional aesthetic surgery. This is a patient whose abdominoplasty progress you can see. Within a year of abdominoplasty, once the 6-month time period for not stressing the abdominal muscles was over, she built herself and she won a state level bodybuilding competition. So previously, because of the fat on her stomach, she couldn't show off her abdominal muscles, and every time she was frustrated that she couldn't win despite developing excellent leg muscles. So this is the happy patient, and this is how it is functional aesthetic surgery. Some of my abdominoplasties in older era before I used energy-based devices. All these patients are from common background. My celebrity practice is hardly 5 to 10%, and my practice started actually from common women. And I'm very happy to have touched lives of many of them. This is a 68-year-old hernia patient. She came to me for abdominoplasty. This was the hernia. That is also another misconception, that our younger generation who has seen more of laparoscopic hernia surgery feels that we cannot tackle hernia, but that is not true. We are basically general surgeons, and with abdominoplasty we can manage hernia. So marking of the abdominoplasty. This is my patient. She is 45-year-old. You can see her skin, which is very, very stretch marked. You must remember that the striae are above the umbilicus cannot be removed. Basically, abdominoplasty marking begins by marking all the bony points. Then, like gynecomastia, you tell the patient to throw her muscles in action, and you mark the areas which are going to be negative area. So you try to push the panniculus together and mark a tentative line, and that is a wish line. Remember, below that always mark a line 2 centimeter below, and that is going to be your line of closure. No abdominoplasty is complete without marking the back. You may feel that I have marked asymmetrically, but when patient lies down, you see how it is. And this green marking is for radio frequency. That is given only in the midline, in the areas which I want to depress more, that is pararectal negative areas, and the flanks. So this patient is on the table, and now you can see that the lower line is the one where the closure is going to be possible. Even at the back now, after lying down, both the side markings are looking symmetrical. So first is to infiltrate with power assisted liposuction, making tunnels. Then radio frequency at deeper level to contract the septae. Then Bbsr to liquefy the fat. And this, you have to give adequate time in between every step. And this is the back result I have put. Excellent back contouring you can see, and a very clean aspirate. Now the patient is turned supine. Always keep 20 to 40 cc fat away to correct the deformities. This is the liposuction of the midline. You can see a depression. Now here I want to emphasize one important point. You can see here that above the umbilicus, this portion I have not done any liposuction because this is going to be the future pubic symphysis, and that thickness has to match the pubic thickness. So the lower portion of your supraumbilical flap, you should not suck too much. You can adjust it later. So this is the suprapubic cut. Now here, how this marking is done, this is done with the patient lying down 6 centimeter above the vulval commissure after pushing up the vulva and stretching it so that there is a pubic lift there. The lower line is marked, and I make segments of 10 centimeters each on either side so that I can have a symmetric closure, because it is very easy for midline to go astray once you start closing, especially when the skin is so thin. Sorry. Yeah. So in the lower part of the incision, when you start, you have to dissect above the scarpa's fascia and leave the scarpa's fascia intact so that there is a good lymphatic drainage maintained. Also, I don't like to do a very planar dissection. It is explained in my paper that when you leave blobs of fat, you are damaging less lymphatics also, and fat also acts as a velcro to adhere the flaps to each other. So you should not bare the rectus sheath. Now here you can see I am doing suprascarpa dissection, and on the right side I have descended down to almost the rectus sheath level. And I am not touching the rectus sheath anywhere. It is just above, so that there are no burns to the loose areolar tissue above the rectus sheath. So now I am near the umbilicus, so I am going to be very careful and slow. All the blood vessels are properly coagulated. Now I am going almost to the rectus sheath, but still about a layer above it. Here I am cutting the umbilicus. When I am just 2 centimeters away from the umbilicus, I start cutting it. I leave most of the fat behind on the flap. I like to skeletonize the umbilicus, especially the supraumbilical fat has to be left behind because that is going to be the closure. This is how I dissect the umbilicus. This is a side dissection. Now I'm cutting the flaps so that I can go above the umbilicus and make a supra-umbilical. This is on the side. I have lifted one flap on side and I am dissecting almost to the sides. Now, because this patient is very non-elastic skin and lax skin, I have decided to cut because these flaps were too heavy. I couldn't have lifted and made a proper supra-umbilical tunnel. Now here I am marking the rectus sheath. After that, I have not taken video of this further because after I repaired the rectus sheath and opened the umbilicus, I realized that there was a huge gap in the umbilicus and I had to remove it. So I have removed, and on the right hand side you can see an H umbilicoplasty. Her umbilicus has been removed, and this is where you understand why you don't defat the umbilicus. If you defat this area, then it is very difficult to create the umbilical depression. So I had to take a vertical limb. Her skin was very bad. I also fat grafted her striae. This is another patient of a different type. Her skin is better. Dermis is much thicker. Just a little different type of marking you can see. Again, the costal margins are being marked. Patient contracts her muscle, but now note that she is not able to contract at all. Her muscles were so lax, there was a 10 centimeter rectus sheath divarication. So you have to be prepared for all these differences. I am marking the umbilicus. This is how I told you, I make 10 centimeters so that I remain symmetrical on either side. Now here I am planning to drop the umbilicus down and actually cut the panniculus at much higher level from the umbilicus. So I will have to leave much more fat behind to get the suprapubic thickness that is required. These are the posterior margins. These are the bra rolls. So unless the back is sucked, it is very difficult to recruit all that skin anteriorly and remove. Because the final shape will depend on whether this fat is removed or not. When you create a space in front, the fat of the back is going to come forward and spoil your result. This is how we paint the patient, and we put the patient on pre-draped table so that the entire circumferential body of the patient is available. Again, she is turned down, liposuction of the back, uniform infiltration. So please note that I am not doing any fan-shaped movements here. Fan-shaped movements means breaking of the septa and creating a seroma. So finish one tunnel and then enter the next tunnel. This is Bbsr for lipolysis. So you can see the result of the back here. Here I have harvested fat. In this patient I have not used radio frequency because I have done it at some other place. She wanted a fat grafting of the breast. That is why I have harvested the fat. Now I am doing Bbsr for the midline, and you can see that the part that I am holding in my left hand, I am not giving any Bbsr energy because that is going to be the suprapubic closure. When I have infiltrated the umbilicus, I am doing expansion, vibration, lipofilling of the breast, very low pressure, very slow speed, low vibration, and long strokes. So the upper poles of both the breasts are being filled up. This is fast video, but actually I have done it very, very slowly. This is close up. It has to be done very, very slowly in the subcutaneous plane. I have chosen not to fill pectoralis because I am doing abdominoplasty and I don't want to disturb anything. Now I have completed the liposuction of the flanks. So this is a different shape of incision because she has got a tough skin and doesn't have as much lax skin. So it is not going to give medially. So I have given her a shape of bicycle handlebar. It also depends on the type of crease the patient has got under the inguinal area. So again, above the superficial fascia. Now it is the place where her caesarean scar is. That is why it is going through the scar. Now I am at the rectus sheath level. You can see that one layer above the rectus sheath is well preserved. Again, umbilicus is being cut. So I am near the umbilicus now. My staff is showing me the site of umbilicus where I have to be careful. This is the lateral part, lateral to the umbilicus. I am cutting the flaps here again. So this gives you a good access to the supraumbilical area and you can do a good dissection there. So this is lateral to the umbilicus, almost up to the anterior superior iliac spine. The lower flap is completely dissected off and now this is the supraumbilical tunnel I have created. The muscles are so lax. So I am holding one muscle in atraumatic Alice and the other. So the separation is really, really huge. I don't like to go up to xiphoid process because if you put your first stitch at the xiphoid process, the patient's breathing is hampered. And secondly, the shape of the linea alba is broader above and narrower below. So it is not necessary to go really till just below the xiphoid. Now, a running suture is taken where every third knot is placed and that knot is buried. So this actually I started doing in general surgery when I was a resident. Since then I have been burying my knots. Otherwise they can be palpable by the patient, especially near the umbilicus. So one more knot I will show and then so too much tightening also should be avoided, otherwise it is difficult to give that midline depression and contour. But in this patient the separation was so much and the muscle had no tone at all. She had a twin pregnancy. So I decided to do a little tighter repair than I usually do. So this is how all the knots are buried. See, this is how the repair looks. I do a V umbilicoplasty, so umbilicus is already cut in the midline. I have put the flaps in the center at the pubic symphysis. I have decided the umbilical location and cut a V flap in the midline. This is how a repair is. Umbilicoplasty is done after cutting the flaps then, because they are already anchored in the midline. Here it is important to remember to leave superficial fascia more, and you can go deeper and cut extra deep fat. Here you can adjust the thickness to match the pubic thickness. I have already done a pubic liposuction, so I know what is going to be the thickness there. So the flaps are cut on either side. I am going a little above the fascia to cut more amount of deeper fat. And then when you suture, you have to take deeper bite for every layer, and this is how the result is. So do you want me to do this just now, or you want to take it in the difficult cases session? My results? Huh? You want me to finish it? No, because Sandeep said that there have to be some difficult cases. So should I keep it then? Yeah, okay. So that was the abdominoplasty marking and execution, and most of the cases that I have included to show here are going to be in the difficult cases section.
Ma'am,
yeah.
Which gadget do you use to record these videos?
Which?
Gadgets. It is a GoPro or something else. You are recording, the recording are very good.
Recording camera is iPhone 13 Pro Max.
Because while you are taking the sutures inside like tunnel, as if you are seeing this, it is a head mount like.
I will tell that to my assistant who I keep on firing all the time, poor fellow. Thank you, let me know your name. He will be grateful, yeah.
Thank you, ma'am.
Very nice video recording and presentation.
Thank you, sir.
Obviously, the credit is with the presenter, not the camera that much. But I have a simple question. What is your take against the drains? Why do you not want to give the drains?
So that is my entire paper actually. So everybody feels that they should put drains to be on safer side, but actually the drain negative pressure is minus 125, which is way beyond the venous pressure. So it actually probably pulls more blood out rather than just draining whatever is collected. And if you follow certain steps, it is not required. So drain itself can irritate the tissues, it can stimulate. And after my paper was published, I have interacted with many people and even international people. They say that our drain doesn't stop. It is very difficult to decide when to stop, remove the drains, because sometimes 100 ml keeps on draining for 25 days. So what to do? So good idea is to just take it out. So that was my experience in my sternal dehiscence cases. I used to keep the drain for 7 days and every day there would be 75 ml of serous fluid. Then I got frustrated and I just pulled it out and nothing happened. The things improved. So probably the drain itself was drawing serous fluid out of the tissues. Maximum 2 days. When the capillaries start regaining their tone, like again burns, it is like internal burns. So within 48 hours, even in burns wound, the capillaries start reversing. So around 48 hours, if you remove, that is not a problem. But soon, if you follow such techniques of toilet liposuction and good hemostasis, leaving good amount of areolar layer on the tissues, you will realize that that much is not required. That is how it was my process. No, if at all, now recently I put a drain, but I put a corrugated drain. The problem is with the negative suction, and I removed it in 48 hours. There are sometimes patients who are very leaky and oozy, and you are not sure that you have achieved a dry field. So in that case, corrugated drain for 48 hours is enough.
Now, in that continuation, I'll ask one question. You told not putting the drain. If something wrong happens, will it stand in court of law?
You can quote my paper.
No, that should be evidence-based.
No, actually yes, it is. I have published a series of 204 cases, drainless, and now even I presented in UK more about 40 cases done using energy-based devices using the same principles. So I will publish that also. That will be useful in court of law. All the court wants is evidence, that's all.
Okay. And other question is, while doing the application of the rectus sheath, how much pressure you exert so that there will be no breathing problem later on?
I actually like to just approximate the muscles normally. This patient, I have taken a little bite of muscle because her muscles were lying away from each other for many years. After she delivered when she was 30-year-old and she got operated when she was 45. So muscles had no action. If you see when I am marked, they were not even contracting, but otherwise they should be just together, that's all. Okay. If you tighten it too much, then you cannot create that midline depression that you can see in this patient. Such an obese patient, but there is a definition. So if you want to create that, you should not over tighten.
And last question is how you give good shape to the umbilicus?
Pardon me?
How you give good shape to umbilicus?
I like to usually do V umbilicoplasty, and if as I showed here, a V-shaped flap from the upper flap is inserted in V of the umbilicus. Umbilicus is cut in the center, and into that a flap from the upper flap is fed. So that I do, and otherwise neo-umbilicoplasty, H-umbilicoplasty that is described by Hoyos that I showed in the first patient.
Is it V cut or inverted V cut?
Both are V's actually. V goes into V.
Okay. Okay, thank you.
Another question, madam. One question, madam. Hello. Madam, one question. Madam, in which conditions you are doing lateral releasing incisions? When you feel there is a pressure and lateral releasing incision, have you placed in any part lateral releasing incision to prevent the intra-abdominal pressure in tightening? You are not doing anything.
And then you can pull it down easily.
Okay.
There are no lateral incisions. No. All I would like to say is many times, at least 75 to 80% of the times, I am not happy with the midline plication, but I also add a horizontal arm.
Okay.
In the midway between the umbilicus and the pubic symphysis. That I find it necessary many times.
Do you combinedly do mesh plasty with this one?
If the abdominoplasty is small, I have shown one patient like that at the end.
Okay, thank you.
Yeah.
Thank you much, ma'am, for your
Bit about history of liposuction for the people going for their exams. It was popularized by Illouz, who in 1982 did the wet technique. It had been tried by the dry technique earlier with disastrous results or not very promising consistent results. So when Illouz did the first wet liposuction, he presented it, it became caught people's eye. And then in 1986, Jeffrey Klein did a tumescent technique, which is basically overfilling the area with fluid. And in 1987, Jeffrey Klein published the same, his findings, and that made it a leap ahead. And in 1996, the innovation by Michel Zocchi from Italy, where he introduced ultrasonic liposuction, which is called UAL, and it's also there is a company which sells a machine by the name of Bbsr, and Bbsr is basically ultrasonic liposuction, but it is a much more advanced version, getting rid of a lot of the complications and variabilities of the earlier ultrasonic liposuction. So basically the popularity is much more because the technique has improved, patient safety has improved, and thus the surgical outcomes have also improved. So what is the mechanism of fat removal? With the large cannulas, it's basically avulsion of the fat, and with finer cannulas, it's emulsification, which is called the wet technique. So how do we address a patient for this technique? The patient selection is important, appropriate indications, and also assessing that the patient has realistic expectations of the outcome of this procedure. So what are the indications? The aesthetic and non-aesthetic indications. Aesthetic indications, the key is the ideal patient who is otherwise fit and healthy, has got limited issues with the body contour, and we address those limited issues with liposuction and get a good result. The second is a limited fatty deposit, which may be just be a hip dip or maybe the arms, and so you do a localized area and you do get a good result because the patient otherwise is stable. The third indication is obese patients. These may be of two categories. Obese patients but without skin laxity. I'll show you an example of that on the video, and or it may be with skin laxity. So both can be addressed. Both have their reasons why after counseling, which can be decided, and I'll talk more about that later. The other thing is as part of lipoabdominoplasty. So that is very common now. I think that's probably almost equally as common as a pure liposuction, where in case of lipoabdominoplasty, you may be doing liposuction of the pannus which you're going to be excising. Or it may be an adjunct procedure to that, which we call as the full lower body contouring. So, but there are certain riders in aesthetic indications that the patient should have a stable weight for the last 1 year, and the patient it should be made clear to the patient that this is not a weight loss procedure, it is a body shaping procedure, and all the weight loss that happens is incidental. So they should not be really looking up to us to say that, okay, after this procedure, you're going to lose 4, 5, or 6 kilos. So, and this is absolutely not a replacement or a substitute for diet control and exercise. In fact, this is what comes in after they haven't got the desired results in spite of diet and exercise. And also whatever we deliver after that in a healthy patient who maintains his or her weight, the results are maintained in the long term. The non-aesthetic indications are lipodystrophy, skin flap thinning. It may be myocutaneous flap, it may be fasciocutaneous flap. It's a big blob, and that can be thinned by liposuction. HIV-induced lipodystrophy and axillary hyperhidrosis, it has been reported with favorable results by some people using fine cannulas doing superficial liposuction. So what investigations do you do in a case of liposuction? Basically, you just do the routine blood tests, you add in the bleeding profile, and you may want to do imaging as required per the individual case, whether it is a sonography or whether it is a MRI to assess intra-abdominal versus extra-abdominal, or to identify a vein or artery in case of any aberrance, or if you're doing a liposuction of the leg, you might want to have that. So, so the first step you do once you decide to go ahead with the procedure is marking. The marking is done in a standing position. It is reinforced by sitting or lying down, depending upon the area to be done. It is done with a waterproof marking pen. So you mark the areas of liposuction in concentric areas. Some people prefer to mark the center first and then take a big round circle around it. I prefer to define the area to be marked and then make a concentric circle to define the peak. it's important to decide and know about the transition zone, because as you go to transition zone, the gradient of liposuction should be lesser, so that you have a smooth transition between non-suction areas and suction areas. Have a different color pen to mark the areas which you have to avoid. You've got to also mark the zones of adhesions which should not be broken, because then that sort of shifts out or rotates the abdominal pannus. Make a note about any pre-existing scars, because you might want to show it to the patient, and also you might want to do something to the scar, be it subcision or scar revision. Also note any asymmetry, if it's the thigh which is bigger or smaller, if it's the arm which is bigger or smaller, or if it's lopsided in the abdomen or the love handles. Another skill which we should all have is photography. Today with the good mobile phones, they are good enough, but then equally important is the lighting. So not only should you know the angles or views which should be taken with photography, there should be adequate number of photographs taken, but you should also have the lighting right, show it sort of either highlights the deformity or what you're trying to address, and also possibly and preferably the skin quality as well. Because quite often, once you have a complication, then you can go and look back that why a complication happened at that area. And so you've got to take a photograph before marking and then another set of photographs after marking. This after marking should be shown to the patient, and at that point you should again have a sort of a comprehensive discussion to go through the plan which is in mind and whether there's any change required in the light of the markings. So, and then if there's a modification, modifying the markings accordingly and retake the pictures if required. Also, videography has become very important, not only from a social media point of view, but from record keeping as well. So you should have a video before the marking and after the marking. These photographs should be kept handy in the operating room, because quite often during prepping, some marks might get wiped off. So if you have the photograph, you can again remark that area. Label and archive both for clinical record as well as for medical legal purposes. It's very important to take consent for the photography. There should always be a general consent for photography, that is for your records. And if you are going to be using those photographs either for patient education or for marketing or online, then specific consents should be taken for that, because increasingly there is conflicts between patients and doctors about the consents for photography. Personally, having a photograph is a very important thing. It holds very good in the court of law if required. Next is the anesthesia for liposuction. If it is a limited area, the best is to do it under local anesthesia. If it's a little more, and certain areas, then especially lower body, you'd want to do it under regional anesthesia, and if not, then under general anesthesia. Personally, if you are doing it under spinal, it is much better. It adds to the safety. Important thing about anesthesia is that you should keep the surgical time to a ballpark figure of 4 hours maximum. If it's going to be more than that, then you've got to decide whether you're going to stage the procedure so that you stick to the surgical time to 4 hours, or whether you're going to have multiple surgeons operate. As discussed earlier, I personally am against multiple surgeons, but then yes, if it's a team which is operating continuously and all the time, so that both of them deliver the similar results on both sides. Otherwise, whatever you say, even two good surgeons will always give differing results on two sides if done on the same patient. And also, the anesthesia, whatever we do, is always going to be supplemented by tumescence for the infiltration, so which prolongs the anesthetic effect and the duration. So, Illouz had given these principles, almost now it's around 40 years ago, and they still hold true. So he says, use blunt cannulas, create many tunnels. Dissecting hydrotomy is useful, meaning with fluid, infiltrating fluid. Operate deeply, meaning stay away from the surface, because that's where you cause irregularities in the surface, and use the retraction of the skin to your advantage. His 10 commandments were: create only tunnels, do not create cavities, be as gentle as possible. Yes, important, you can do more if you are very gentle. Use small blunt instruments, use the least possible number of passages, respect the superficial layer of fat, Very important, but that's where the vascularity lies. It's not so much of what is removed that's important, but what is left behind. Use, anticipate, and estimate skin retraction instead of fighting against it. Obviously, it says experience and planning is the key. Do not undertake an important resection that is locally and generally dangerous. Absolutely, because you don't want complications. Indications should be restrictive. Adipoaspiration is not a panacea, meaning you just don't promise a liposuction just because the patient wants it. You yourself should see a merit in delivering some outcome which is going to satisfy the patient. All fat resection is final, absolutely true, but since then the only advantage is that now we have the advantage of lipofilling or fat grafting. So if there's over resection, it can put back, but remember that fat grafting is not 1:1. There's always going to be some degree of fat loss, so it might require a few sessions to put things back. Results in the operating room approximate the final result. Absolutely right, because immediately after the liposuction, the shape you see, the volume reduction you see is what's going to be, because there's going to be rebound edema, which is going to cloud your result, and so it's going to show up later on. So be very hawk-eyed to see what result you're having on so this technique demands blind surgery. That's absolutely right. It's blind because you are doing with touch and feel. So literally, if you're a right-handed person, you use the right hand, then the left hand is your ultrasound, which you're putting your hand on, and you've got to guide your cannula from the surface as it works inside. So this is a schematic diagram of what you expect. So there's the fatty layer, the tunnels there, and once you suck out fat from a tunnel and they apply pressure, so it will collapse. So obviously multiple tunnels and multiple scores of suction, that's what's going to reduce the volume in the desired area. So again, basic principles, to take the relevant history for safety, to know what the reason the patient is wanting the procedure done, and also know that they're going to follow the post-op instructions, because post-op care and instructions are very important in the first 3 months to get a good result. So if the patient does not understand or doesn't seem cooperative, you may have to rethink whether you want it done or not. Thorough examination in terms of local examination as well as general fitness, counseling the patient as to the outcomes to be expected, and informed consent, detailing what all you have explained. No longer is it okay to take a general consent for every procedure. The procedure should be specific about liposuction and the complications which can happen in cases of liposuction. And then intraoperative, a bit of massage is important to prevent DVT. Infiltration should be done with smooth strokes. We always use a wet or tumescent technique, and after infiltration, we do wait for some time. So the cannula which you use has to be blunt tipped with optimal holes. I prefer the Mercedes cannula, which is like a triangle and has got holes on all 3 sides. And if you are doing superficial liposuction, which if required in a safe way can be performed, then the holes should be pointed away from the skin, in which case I would use a cannula which has holes only on one surface, not on all surfaces. And always use as small a diameter of cannula as possible. This obviously depends upon the volume and the area where we are doing. So, and a tunnel in a fan shape, so the fan can be this way or this way. So you either decide to go first in columns or you can go in layers. So, and always tunnel from deep to superficial, not from superficial to deep. And multiple access ports should be used so that you can crisscross, so no area is missed out. Because if you have only one port, you're going to be going in one direction only, so you'll miss out the rows in between. And always important to feather the margins of the area which you're going to do liposuction on. So I'll just show you a few things in a moment. Before I doing that, let me tell you a few more principles. So avoid end hits. Do you know what are end hits? So basically, when you put in the cannula, it should go under the skin. But if the skin is turned like this and it goes and hits here, that's called an end hit, because it's going to go and hit the deep dermis. And that's where the vascularity is, so that's not good. And obviously, if you're using a power device like a Bbsr, which is ultrasound or whatever, the energy is going to go into the subdermis and damage it. So end hits are bad. So, and then on a personal note, as we are talking about, if you're doing classic liposuction, you should be ambidextrous, because you're using force, you're putting in multiple strokes, probably sometimes like 1,000 to more than 1,000 strokes within a short period of time. So you should be fit and you should be ambidextrous, because then you can stand and either go this way or this way rather than have to turn and go in awkward position, which affects your back, affects the shoulder and your posture as well. So over a longer period of time, it becomes a health issue. So being fit and being ambidextrous to me is very useful to prolong your life as a plastic surgeon doing lots of liposuction, and also to be able to give good results. And you don't get that tired at the end of the procedure. So they use the non-dominant hand to guide and monitor the working of the depth of the cannula. So both hands are equally important. While one is resting, it's not just resting, but it's really guiding, while the other one is doing all the hard work. And then you can correct it and go the other way. So many surgeons I see, they keep switching places because they only can operate in one direction. So learning that early on, especially for the youngsters, is good. In large volume suctions, you leave the ports open so that, because a lot of tumescence has also been put in, all that can flow out. It can be a bit messy, but it's important. But make sure that your ports are in dependent areas so that there is benefit of the keeping open. Then I use a pressure garment. Unlike Dr. Mehta, I use a pressure garment on table, and that is sort of put while the patient is still under anesthesia. So when he or she wakes up, the struggle of putting it on is not there, because wearing the garment for the first 5 days is not a very pleasant experience. So the first experience need not be bad. And again, if I know if it is too tight, I would not wear it, put it on. So the question of it being too tight is decided by me or my staff. So the patient should be mobilized early. Early mobilization means the same evening or definitely the next day morning. So they go to the washroom, they can just walk a little bit, but not resting all the time. Antibiotics, anti-inflammatories, and I usually discharge patients even if I do multiple areas on the same day. So clinical examination, two things you see. First of all, you see which are the areas of concern where it is required to do the procedure, and the other thing is to see the skin elasticity. These two things are going to help us decide the following things. Number one is this the reason to do the problem, the area of concern, is that why it's going to be solved by doing a liposuction? If yes, then how many areas should be done? Whether they should all be done in one session or multiple or more than one session to be done. Have an idea about the volume of suction in a particular area. So just because I can make it flat, I would not want to, because if like for example the inner thigh, if I remove too much, that inner thigh skin is going to sag, and it's going to sag badly. So you want to leave some behind. You don't want to kind of remove as much as possible. So those decisions are made. And also patient's understanding about what she is going to undergo. We do multiple areas and that patient is not that mentally strong. So it would have been as if she has taken a beating rather than had a surgery, because she'll be bruised and pained all around, and that makes for a very unhappy patient, because they did not sign up for so much of pain. Right? They signed up for a good result, but did not sign up for the pain. So we've got to be sure that even though the patient says, yes, I'll tolerate it, we've got to make our own judgment that, yes, is she going to be really up to, going through such a big procedure. And the other very important is comorbidities. Any comorbidities immediately reduce the volume of surgery you do, because there is bound to be the comorbidities. The common ones we face is morbid obesity, controlled diabetics. Obviously, uncontrolled you don't do it. Controlled diabetics, controlled hypertensives, smokers. These people, and even in my experience, I've even had people who claim to be controlled hypothyroids. They also tend to have some problem or the other. So you've got to be really careful how much you do in such patients. Okay? And also you got to explain when you decide, like say for example you're doing a thigh liposuction. You know that beyond a point it's going to sag, and that patient will not be happy with the look of it. She'll be happy with the size of it, but not with the look of it. So you got to explain that you will require a thigh lift in the future. So that it's not that, doctor, you caused this. So now you solve this problem for me. I didn't want a thigh lift. So only if they agree that if they are unhappy, they will be going for a thigh lift, you would want to do an inner thigh liposuction. Right? So those things you got to understand. And also now I feel time has come to video record all informed consent especially with aesthetic surgery patients. So the youngsters should learn this, because we seniors still have a repo, some degree of sort of respect or a command on the patients. Youngsters don't have. So you people should now develop the art of video recording your consents. Right? How you store it, where you store it, those you guys know better. And so, then, okay, now going on to the technical part, the techniques are dry, which is you do it only for a very small area. The commonest is wet liposuction, which is where you infiltrate as much as you will pull out. So how do you decide that? You infiltrate the infiltration solution enough that it is stiff and turgid. So when that is stiff and turgid, that is the total volume required. And in that case, when you aspirate, invariably you will bring out the same volume that you had infiltrated. Then there is a super wet, where you the infiltration is 3 times more than what you're going to aspirate. So you're really going to put in more. And then there is a tumescent technique. This is basically, tumescent is either interchanged with wet, super wet, or tumescent is basically, it's a kind of anesthesia where you're putting a local anesthetic in that local part, so that that supplements the general anesthesia or the regional anesthesia that you're giving. So infiltration fluid, everybody has a different formula. There are many formulas. The one I've been using for years and I'm happy with is ringolactate with adrenaline, with soda bicarb and xylocaine. Now, techniques, after you've infiltrated, you will do a bit of pre-tunneling. Pre-tunneling means you do not switch on the liposuction machine, but just put in the cannula so it makes tunnels around, right? And then you can use a larger cannula in a deep level and finer cannulas as you come superficial. And also now we've got good malleable cannulas which can be used in contoured areas like the lower back or the upper back or the flanks. The positions where you do liposuction, yes, most cases if you're doing the frontal part, it's in supine, but whenever you're doing a 360 degrees or a high definition liposuction, you will have to turn the patient around 360 degrees, so he or she will be lying in all positions, both prone and supine. So, and then there is one thing I've also always find is that very often when you're doing a thigh liposuction, you'll be called upon to all those people many times, or at least half of them will also have medial knee pads which are very big. So if you do both of them together, you'll have to then have a garment which goes below knee, and then you end up with pedal edema in the post-op period. So I often find that in the more obese people, I would avoid doing the inner knee at the same session. I'll call them back for later, just so that my post-op period is not, is not stormy, because then the patient, if there's pedal edema, will not mobilize, and if they don't mobilize, all the other risk factors increase. So, and then a bit about large volume liposuction. So, again, patient selection, that's a very sort of scary proposition because the risks increase. But yes, if you have counseled the patient well, if you know your technique well, if you have a good post-op care session, and you know it's almost like an ICU kind of situation available in case of patients not doing well, then you may consider going ahead with large volume liposuction. There are issues with male versus female. There are certain differences which you should know. High definition liposuction, again, not for all patients, the motivated ones, and also not beyond a certain volume excess would be eligible for high definition liposuction. The UAL again, it speeds up the procedure. It is good for it speeds up the procedure. It is good for fibrotic areas as well. And well, it doesn't speed up. It actually, you have to do 2 passes. First, you put the ultrasound energy to emulsify the fat, and then you suck it out with a normal cannula. Power assisted is basically sucking out at a speed. So that does speed up a procedure. So if you use both of them in combination, that will speed up your procedure. And in fibrotic areas, many times in males, it does make a significant difference in outcome. Post-operative dressing, again, there is variations. Mainly it's the garment that you got to wear. Massage is very important. Garment is very important. And the results which you see are usually seen, the best results are seen after 6 months. So if you have to do a redo or any touch-ups, you have to wait for minimum of 6 months, maybe a little bit longer as well. So what are the sizes of cannulas? You use For deep, large volume, you use 4 to 6 millimeters. For superficial, you use, and small volume liposuction, you use 3 to 4 millimeters. And for the face and neck, you use 2 to 3 millimeter cannulas. So reducing in size as you go more superficial. Anything more than 6 millimeters would be really avulsion, which was used in the past. In the past, there used to be 8 and 10 millimeters as well, which is no longer used because that is very traumatic. The tubing is important. A silicone tube with an inner diameter of 10 millimeters and the wall thickness of 3 millimeters. It's important because if it's not, then it kinks very easily, and that sort of holds up the pressure. It should be autoclavable, but then you don't hold on it for too long because it starts getting softer as with every autoclave. And don't have it very long because then the delivery of suction from the machine to the cannula is lost in the distance. So again, just UL for fibrous areas, for redo SALs, when higher skin contraction is required because of a lot of skin laxity. For PAL, that's power assisted, yes, it improves 30 to 45% efficiency, and so more fat can be removed or a fast extraction done, and there's less surgeon fatigue. For a young surgeon who does not have to do 2 or 3 liposuctions in a day, it's okay not to have that. Complications, there's a list of complications we should be all aware of. That I'll deal with later in the complication part. But suffice to say that it is a relatively easy procedure. People think it's easy, but it's a nightmare when there is a complication. And these complications like surface irregularities, contour irregularities are very difficult to address, and it overall makes the patient unhappy. So however hard you must have worked, it doesn't make it worth it then. And many times if you go superficial, then there can be hyperpigmentation or depigmentation depending upon the damage created by the superficial patient. And then, as always, there is a dissatisfied patient. That's a patient who is unhappy. That does not result to the result you have given. It's just that that patient is not satisfied with your work. So, and that's where all the litigations come from. Sorry. This was supposed to be. So this is showing that I'm using the left hand. I'm a right-handed, so you can be ambidextrous and do that position. So this is showing, this was a lipomeningocele, so I removed the fatty part from there. This is showing doing from the abdomen. So you go by sort of gentle strokes with the ports in the inguinal region so that the scar is in that fold. So you got this big, almost like a lipodystrophy kind of bulge in the lateral thigh. So in summer, we don't have a hypothermia issue. So the other hand is monitoring, making sure that there are no end hits, and you go in, push in only as much as you need to address that target area. So, and then you can also inject, the fat which you have aspirated after sort of sedimenting it. So just to show some results, again, the medial and lateral thighs. So this is almost 7.5 liters taken off. So that's the pre and the post. And that's sort of, yeah, the same patient with different views. Again, you see the concentric marked areas is where the fat was aspirated from, and that leads to lax skin. The more you take out, the more laxity. So you got to have a judgment as to how much you want to remove. So you can see the change. There's another patient. Similar. As a young girl. So that was the only concern she had. And there is a dip there marked which was lipofilled. So that's her post-op. More results.
Thank you very much, sir.
One second, I've got something else to show. 1 minute. एक और बचा हुआ है वीडियो तो बचा है इसको उसमें डालना पड़ेगा इसको ये वीडियो को तो उसमें डालना पड़ेगा क्यों वीडियो वापस प्ले नहीं हुआ So this is a lady where, so as I said, we first take the photographs without any marking. So she requires, a full lower body recontouring. So now there she is marked. So she's marked up for an abdominoplasty, plus these concentric circles are where we are going to be doing the lipoaspiration. So that's the upper abdomen, that's the flanks, outer thighs, posterior thigh, medial thigh, and the lower and mid back. You will note that we try and avoid doing the anterior thigh. As a rule, we try to avoid that. So that's sort of so now that's the liposuction being done. So that was side, now that's the abdomen. So that's the silicon tube I was talking about, and that's the abdominal specimen which has been removed. That's sort of the amount of aspirate which is done, and this is the post-op. So that's the post-op. So all the areas addressed. Thank you. And yeah, so that's the last case. Again, she was a case of both breast as well as abdomen or the lower body contouring. So, so the first stage did the lower body. So those are sort of the markings. You can see that the red areas are the areas which required lipofilling, which were so that's sort of the posterior done, and that's the lipofilling done, that's the aspirate, and that's after the second procedure. So that's what the outcome is. That is at 2 weeks. 2 weeks after the breast surgery. So that is 2 months. Basically whole body contouring, that's sort of the pre and the 2 months post-op. Thank you.
Thank you very much, sir, for a wonderful presentation. And I am sure our residents must have got their long questions answered for them.
Yeah, I understand that everybody is dead tired and so am I. But I'll request all of you to please sit down, have your teacups and sit down. Because we'll be talking about technologies in liposuction, and I know since morning a lot of people have asked a lot of questions. And we'll talk about the art of liposculpturing and how do technologies help. So is fat reduction enough? Is just removal of fat enough? Or should we look at sculpturing the body? These are my disclosures. So what does liposuction do? It removes unwanted fat deposits. It also has the power to give our patients enhanced and smooth contours. Basically, we understand it's a cosmetic surgery to enhance the cosmetic appearance, but it's not a weight loss procedure, right? So are we really enhancing the cosmetic contours? Are we actually utilizing the power of liposculpturing in such a manner that we get really enhanced contours? So what are the technologies which we can use to achieve liposculpturing? First is ultrasound-assisted liposculpturing. A lot of my things were covered by Dr. Medha Bhave ma'am during her talks because she also used ultrasound and radio frequency. So I'll skip certain parts. But what is the advantage of ultrasound-assisted liposculpturing? It liquefies the fat and allows the surgeon to target specific fat layers. Understand, even within the fat layers, you can target some specific fat layers and to create a sculpted appearance and outline the musculature, underlying musculature. It gives you power to be precise and get enhanced results. It also preserves the connective tissue around. Of course, there is high degree of precision. Reduce pain, bruising and swelling because it reduces the effort of removing of fat. Much more speedy recovery. It also maintains the fat cell viability. So when it came, there was a lot of confusion whether the fat which you harvest after Bbsr, will it be viable for fat transfer? It is now dead and buried. Fat is viable. There is no two doubts about it. And of course, it reduces the surgeon's effort, which I said in the morning, it's the most important effect which these tools can give you. To understand how it preserves the viability of fat, understand the nature of fat cells. Fat cells, as in adipocytes, are arranged in globules. Multiple globules together form a fat pearl into a fat section. All these are bound loosely by connective tissues. What is the relevance? So fat cell structures are most affected by cavitation. When the tumescent fluid is infiltrated, there is microscopic gas bubbles also in the fluid.
understand that Bbsr can affect if you have infiltration of fluid. Then because of the cyclical compression, that is squeezing and rarefaction of ultrasound field at specific kilohertz, these bubbles burst. And then when these bubbles burst, the soft tissue matrix around the fat cells also break away, so that the fat cells become liquefied and it forms like a soft emulsion which can then be harvested. So the point here is, it does not damage the adipose site. It does not damage the fat cell. It just damages the connective tissue structure around these cells. So these loosened fat cells mixed with fluid and form emulsion can easily be sucked out. I'll just quickly show you a video. Now this is a redo surgery. I'm doing Bbsring, and as soon as I do that, I gently press and you can see how the liquid amount of fat comes out. That's the power of ultrasound assisted liposculpturing device. Since it breaks the air bubbles among the fat cells, it is also tissue selective. And because of tissue selectiveness, there is chances of less bleeding, less pain, and achieve smoother results. Another video, you can see this is a fat globule. Of course, I've infiltrated some fluid in it. And you can see, can I have volume please? So you can see the fat being melted. That is the effect of ultrasound. So now you can imagine, if you can achieve this, the fat being melted, you can easily take out this fat with suction later on. It also has the power to retract the skin. How? Because it has the ability to stretch and contract due to isoelastic fibers interspersed through the skin. When we remove the volume from the subdermal layer of ultrasonic energy, there's a space is created and the isoelastic fibers contract and there is skin shrinkage. So this was ultrasound assisted. What is the advantage of radio frequency assisted? All those people who are using both ultrasound and radio frequency, they will tell you that the radio frequency tool gives much more skin shrinkage than what an ultrasound alone can. We are talking about this tool called as Body Tide. There are several other tools, but this is one of the tools which is FDA approved, which Dr. Mehta has, I have. And what this tool gives us is a power to bridge the gap. Now we all have our patients in our practice who are not just good enough for liposuction only, but they are not as bad enough that they need a skin excision. So they are in between and you are confused. So this technology helps us contouring those patients and tightening the skin. At the same time, there are some sideline patients who are not fit for anesthesia or who are actually simply not willing to go for a skin removal at all. So such cases can be contoured using this technology. Plus then there are maintenance patients. Now what do you mean maintenance patients? They've had this surgery, they've lost weight, they've lost skin, but then they lose again. So you need to bring them into your practice and tighten the skin again. So these are different tools in the same device. You can tighten the skin for body, face, and around the eyes as well. There are different caliber cannulas as well as the devices which get attached to the same machine. Basically going depending upon the depth of the skin. I'll not go in details. So this is basically nothing but a bipolar RF. So there are two poles, one going in and one going out. There's also monopolar RF in it, which can deliver the energy through a single pole. How it works? Basically, it's unique technology so that there is a cannula tip which sends the energy. The outside tip is acting as a control so that the circuit is completed. And in between these two poles, the electric circuit is completed and the radio frequency is immersed, and in between tissues get treated. Basically, we are again tightening isoelastic fibers so that it contracts and the skin gets treated. So this is how the cannula goes in. There's a schematic video. We'll show you some surgical videos as well. And the isoelastic fibers isoelastic fibers are heated by temperature, which goes up to 70 degrees Celsius. The skin temperature has to be around less than 40, 42, so that there are no burns, and it contracts. That's what radio frequency does. There are also tools along with radio frequency which has cannula. So while you are doing this, you can also suck out the fat
but most of us don't prefer that because suctioning of fat is very, very slow. So basically, these are the fibrous septae which you are targeting with this technology. So tissue contraction happens. If you see, this is a video, and as we are heating, you can see how the tissue contraction is happening. That's what radiofrequency does. So there are ample research article which clearly says that it works, and it works beautifully in some patients. Of course, they should have good elastic fibers so that so if the patients who have lost a lot of weight, loose skin, a lot of stretch marks, they have lost a lot of isoelastic fibers, it will not work in that. But in other patients, it worked really nicely. So there are a lot of research articles, I'll not go in that. So it's a very simple procedure. Here I'm doing the neck. So there is an auditory stimuli which is created so that you can hear. You don't need to see the screen. As soon this tone goes from 2, that means you have treated that area. So you don't need to keep that screen. You just have to see the monitor once, set up the temperatures, outside and inside temperatures, and just keep going and treating that area. There are different amount of energy which you need to treat for a particular area. A portion of an upper abdomen, say around a 10 centimeter square area, you will need 10 joules. So you deliver the specific energy in that area so that the skin tightens. So what is high definition liposuction? Basically, we create contours depending upon your underlying muscle outline. So using these technologies to now create high definition results. So this is the area we need to contour. We need to imagine that area, what the muscles would be. So you ask the patient to tighten the muscles, feel the muscles, and mark them accordingly. So these are pre-operative markings. So what you can see, what is the dark thing, black thing is, these are negative spaces. The green thing, which is a marking, is I'll be adding some fat here. So these black dark things are negative spaces. Then there are areas where are light removal of fat, and then there are areas where you add some fat. So all these areas basically are creating the valleys and the mountains. As ma'am said, valleys will make the mountains look nice. So you need to create those areas where you will have shadow effect, back and front. So this is how the marking would look like. And then, as she has already said, I can't fast forward it, sorry. I'll have to repeat it. Okay, I'm sorry, you will have to see this again. I can't help it. Any questions meanwhile? If you have, I'm happy to take it. So anybody who wants to learn high definition liposculpturing, I highly recommend a book by Dr. Hoyos. There are areas, how your anatomy looks like, how your muscle anatomy looks like when you are standing and supine are different. So you need to understand that while you do the markings so that your result comes out nice. So unless you do 360 liposuction, you can't achieve a result, nice result. Why is that? Think of this as a 360 degloving injury. There's a cylinder of skin, cylinder of fat, and cylinder of muscle. Unless you deglove the skin completely, it does not shrink, uniformly and nicely. So you have to do 360. There's a concept of infiltration by power-assisted method, as she has already said in the morning. So there's a power-assisted cannula which keeps vibrating, and also tumescent infiltration is done, wet infiltration is done. So you keep moving and keep making spaces and infiltrating fluid. I'm infiltrating with basket cannula, and then we suck that fat out. So again, using power-assisted tool. And once you have taken the fat out, we are using radio frequency embrace to tighten the skin in the lower back. Now, many patients who you even be doing abdominoplasty, they will have reasonable fat in the lower back, and when you remove the fat, the skin tends to sag. You don't want that skin to sag, you want it to contract nicely, so you do radio frequency of the back as well, so that the skin shrinks nicely. Typically, The lower back will take something around 17 to 18 joules to complete the whole treatment. Some extra joules may be required if they have some brow rolls. So all this area, the skin is treated so that the skin tightens. So understand, in any energy-based devices, whether it's Bbsr or this, you need to keep moving. Anything static can cause burns. So then you turn the patient supine. After infiltration, what I'm doing now is Bbsring. So you do superficial Bbsring first and then do deep Bbsring. Why? Because you have infiltrated the fluid. You want to not cause burns. You need to remove the melt the superficial fat first. And then when you start doing suctioning, you do the deep suctioning first and then the superficial fat removal. So once you have done the deep fat removal, then in the areas where you have marked, you can do the superficial fat removal by angle cannulas so that the etching happens. This is called lab etching technique, so that you can see I'm maneuvering the angled cannulas to create those contours. You'll see this patient, initially it will look like that there's a skin which is not tightened, and I'll show you some post-op pictures and you will see how the skin tightening effect happens. So initially it looks like wobbly, but the skin actually tightens nicely over the next few months. I make some very tiny small hole for the upper horizontal axis. Understand, when you can create six-pack ab look, you don't make them perfectly symmetrical, make them perfectly asymmetrical so that they look natural. And then what I'm doing is, again, radio frequency skin tightening of the abdomen. So you tighten the skin more at certain areas where you want the valleys to be created so that the skin shrinks more, and less at areas where you don't want the skin to go inside. So this is what radio frequency is doing. So each technology actually helps you getting improved result. And once you have completed the chest liposuction, we can also create upper pole fullness by fat grafting, which we have harvested from fat. So this fat is then inserted into the upper pec muscles. So insert the fat in the upper pec muscles so that they bulge. So what you need is a bulge in the upper pec, and then it should go down, which gives you a nice masculine appearance. So this fat can be injected in the pectoralis major muscle, actually between the muscle and the fascia. Very difficult to finalize that, but you get that giveaway feeling as soon as you pierce the fascia, and you just don't go deep to that. So it gives you a nice pectoralis major muscle look. I'll move forward. So this patient, if you see, I'll show you his immediate post-op, and I'll show you his post-op after 6 months. Now, this is how he looked like after 1 month. So abs appearance is there, it looks fine, but the skin is not tightened, right? Can you appreciate it? It is not tightened skin. So he's happy, but I was thinking whether it's looking natural or not. What should I have done something different? But then where's the magic of energy-based devices come into play? And you see his result after 6 months, how the skin shrinkage happens. And that's the beauty of these tools. Now I know Dr. Sandeep always says that unless you do a couple of surgeries a month, you don't buy these tools. But you know what? When you buy these tools, your couple of surgeries becomes a dozen, and then they become a score, and then they become 50. So buy these tools, and your number of surgeries will increase because your results will increase. He's a film actor. He came to me, he says, I have a movie starting shoot in 1 month's time. I can't do an abdominoplasty. I was fighting with him that you need a tummy tuck. Can you see the amount of loose skin? And this skin can get tight. So much amount of skin tightening. Sometimes it tightens much more than you would even imagine. That's the power of energy-based devices. Other patient of six-pack abs. See, and as we have been doing, even we have improved in our results. Even our results keep improving and becoming much more natural. You can see the six-pack abs, how it sculpts as my previous surgical result I show you on table. We have started also contouring the external oblique insertion. You can see the external oblique just above the inguinal fold. That have been started contouring. It started looking much more natural. Another patient, you see, we did his chest pecs, we did his six-pack abs. Now, unless we would have used these energy-based devices, see the shape of the belly button. How the skin of the belly button has stretched, that this sad-looking belly button has become oval. I did not do any umbilicoplasty with him. It is just lipo and use of energy-based devices that amount of skin can get tightened. So you see this result, and this is what we have come for, so that the result looks very natural and tightening of skin. Female patient, of course, we did a breast reduction as well. You see the amount of skin tightening. Other patient, you see the skin tightening. So some women also want ab appearance and very athletic look, and that can also be created by ab etching in women as well. We can also create 6-pack ab, 8-pack abs in women. So that all can be done with these tools. Of course, skin tightening in gynecomastia is as a big advantage, as my previous speakers has already told. Another patient, you can see the amount of skin shrinkage. I thought he will end up needing a mini tuck, but that skin shrank really nicely. You can use this technology to use arm contouring as well. Showing you the marking of arm contouring. If you see, what I've marked is the deltoid groove, so that you get a nice sculpted appearance. Doing lasering. I'm doing this under sedation, so patient is awake. Now you see, the important is the movement of hands while you are doing laser and suctioning. It should not be rough, but it should be gentle but firm. We can also use it for buttock. We're running short. I'll quickly cover buttock in this talk only. So lower back fat can be removed. This fat can go into the buttock to augment the butt. So again, I'm using basket cannula for infiltrating. As I said, deep infiltration first and then superficial infiltration, because we'll be doing lasering superficial. So you want maximum fluid just beneath the skin when you are doing lasering. So first you do deep infiltration, then superficial space fluid infiltration. And then so make sure you always insert a port before you do ultrasound assisted. You don't want any skin burns. Then you do superficial ultrasound energy, more at the contouring part. If you can see that there is a thin stream of fluid being put over the skin to prevent any burns by my assistant. So all these things are important to prevent any complications. Then you do deep lasering. So, and then you start doing suctioning. So, at areas where you have to be very cautious, you take small cannulas which have multiple holes or Mercedes. At other areas, slowly we have moved to basket cannulas. All this fat which we will remove will collect in this jar. And this is the fat which is being harvested, and it will be collected in the jar. If you notice that we have kept some 100 ml of saline in the jar before the fat goes in, and this is why is that? Because when you want the fat to go in, you don't want the fat cells to get damaged when they fall on the glass. You want them to go in the water. They don't want to break the fat cells when they hit the glass, because they come from a height. So small things are important, so to prevent the viability of fat cells. And you keep collecting the fat which you are harvesting. So you see, when we have contoured one side and the other side bulge remains, I'm doing the superficial liposuction now, and then you contoured both sides. You can then wash the fat, let it sediment, and take out good fat from that. And then turn the patient from back. Repeat the same steps of contouring the lower back. So again, superficial laser first, then deep laser. And what I just showed in this is how to create sacral dimples as well. So do superficial liposuction there to create that depression. So if you see one side, fat is removed, the other side is still remaining, and then you complete the other side. As soon as you do the lower back, buttock already starts looking bigger, and then you can do buttock augmentation. So the technique which I use for buttock augmentation is
expansion, vibration, lipofilling, very similar to what Dr. Medha showed for the breast. You wash the fat, remove the fluid, and then you transfer the fat with the basket cannula while it's vibrating. So fat is released while you're creating the space in the buttock. You're creating the space between the skin and the muscle, making sure all the fat goes in the subcutaneous plane and not in the muscle. This is 4 mm angled basket cannula, releasing the fat cells while I'm keep moving your cannula. So understand the left hand acts as a guide so that I can feel the tip of my cannula always, making sure the fat remains in the right plane. We don't want fat to go into the muscles because that's where the problem is. You can see one side is augmented, and then we complete on the other side. Around 400 cc of fat was augmented on each side, and you can see the shape. So this is what a buttock augmentation can achieve. So you start from that and go there. I'll show you a lot of our results. So you can actually contour the bodies. You can create high definition result in abdomen, nice abs, lower back, augment the buttocks. Hip dips very commonly, issues in most of the women. So buttock augmentation in India is very common. Only thing is we need to counsel the patient accordingly. Not everybody wants like an African butt, but many women would want a nice hourglass shape. So once you remove the fat and put even around 200, 250 cc fat in the butts, they get an exaggerated nice hourglass shape which looks very nice. So it can be used to enhance your own results even with abdominoplasty. So we combine buttock augmentation even with abdominoplasty, result like that. So I'll skip abdominoplasty because Dr. Medha has already covered it. So you see, we have not just done abdominoplasty, we have also augmented that fat in the butts to give that nice lordotic spine look, which looks very nice. Using the concept of liposculpturing in abdominoplasty as well. So liposculpturing can be done with abdominoplasty. Gone are the days when it was said that liposuction cannot be done with abdominoplasty or should not be done. In fact, it's now the other way around. Liposuction should be done with abdominoplasty. If you don't do it, you are not giving the best result to the patient. In fact, you are compromising the vascularity of the flap because liposuction, mind you, frees the flap from the fat so that your flap can be mobilized more. So liposuction helps in flap survival if done properly. You can see how nice the result can be, how scaphoid abdomen you can make it look. Another patient you can see, we also use that fat to augment the butts, and this is what you can contour. So in abdominoplasty also you don't want flat abdomen, you want abdomen which goes in. There are some highs and lows, some peaks and valleys, which makes it look very aesthetic and nice. So I can show you a lot of our results. It's all about contouring and sculpturing, and these tools helps you in achieving that. You want that edges of muscles to be defined. Okay, so you can see even in a patient who has a lot of fat, you can achieve that, and that's what the beauty about liposculpturing is. So edges of muscles, the central muscle depression, which looks nice. And when you give such results to a patient, the patient from anywhere will come to you because there are very few surgeons who are doing such sculpturing, and that's what sets your practice apart. So another patient you can see. So from that, of course, she also had a hernia, which we could see, to this. So you're not only removing the fat, removing the skin, but you are sculpturing, and that's what the art of cosmetic surgery is. One point, this Bbsr really helps in redo cases. Since we do a lot of high definition tummy tuck, there are a lot of tummy tucks which we do as redos. Patient comes to us because they've had tummy tucks, but they don't get results of high definition. So you see this patient, and you see there's hardly very less fat, you would think, and everything is stuck. But with Bbsr, with 2-ring or 3-ring probes, you can actually go in and extract a reasonable amount of fat and give a nice sculpturing look. So
These technologies really help, and it enhances the shapes and contours what we can achieve. So you can see the fat which will come out even from a patient like this. Yeah. So advantages of using these tools: faster recovery, less pain, less blood loss, reduced need for retreatment, smooth predictable result, excellent skin retraction, enhanced precision and reduces physician technique. It's a viable fat cells, and of course they are good marketing tools. Thank you.
Thank you very much, sir, for your wonderful presentation. I wanted to have a question for you. A pattern kind of, or it was a kind of a straight?
No, it's never a straight line. It's never a straight line. In that video, it looks like a straight line, but actually that line goes like this, and then when it come out, I suction like this. It's never a straight line. I did mention it.
Yeah, okay. And one more question. When you said that sound, that monophasic sound will come and end with continuous monosyllable sound.
Yeah.
So, like, how will we know? Like, with repeated movements, or in one movement only we can know?
Keep moving. When you hear that sound of ta-ta-ta-ta, that means that area is treated, and then you move.
Okay.
So something like that. Sir. Longest follow-up for that case is, longest follow-up is around 6 years, and the reason is that I've been in practice for 6 years. So, yeah. I've showed you the results. Most of them are long-term follow-ups of tummy tucks, which I showed you 1 year, 2 years also I showed you, 3 years also I showed you. And once the result is there, it's there. Patient has to just maintain it. It's not that these results will disappear someday. Redo the operation. So, sir, once the result is there, it's there. Yeah, but one point of caution. I have done a lot of redo abdominoplasties now. These energy devices does, make the underlying dermis very, very thick when you open them again. So you have to use them judiciously.
Thank you.
Okay. I'd request Dr. Sanjay Giri sir and Dr. Jayandas sir to also to join.
Good afternoon, and I welcome all the panelists first. So we have our panelists from various backgrounds: senior, junior, medical college, private practice, everything. So it's a good mix. And I would like to start with Dr.
She's calling you junior. He's junior. In energy-based devices, he's junior.
So I would like to begin with Dr. Sanjay Giri. Which kind of liposuction devices are available at your institute, and would you put in application or indent for any of the energy-based devices after today's presentations?
Frankly, to start with, when we started our MCH course and when our director was there, they told that aesthetics should not be done first. Then after a lot of struggle, we got real fact. This is a real fact. Then we got something 25 or 50,000 for manual liposuction and all those things. So we have taken it from that Bombay that surgical that he has given some 25 to 50,000 some manual liposuction cannulas and all those things. And with us, then after that we told that we have not told about the aesthetic. We told that we have to do some to fat and all those things to be removed. After that, they have given like 10 to 15 lakhs for giving some ultrasound assisted liposuction.
Okay.
So,
So that is a really good advance, I would say.
we didn't get it because the cost was so much and we do not know about the budget. So what we got, power assisted something, but that is also like a combination.
Okay.
Not that like micro air, like that is not with us. So that power assisted liposuction, it is given by us Myotech. And they have combined something Indians and like motor and all those things, which also not able to do after 1 or 2 years of. Otherwise, we are doing almost in manual liposuction.
But do you want to buy now?
Definitely, we have given this.
Do you feel that there are some shortcomings of manual liposuction?
There is no shortcomings because we have residents and they are doing it. Sometimes we are also giving it, but lot of energy is going on. Sometimes that is the most important thing. Otherwise,
that is a very important point you have shared, that a lot of energy has to be spent when you are doing only manual liposuction.
So initially we are doing it. Then after that, when residents learned it, they are doing it.
Okay.
Almost many times we are doing marking and all those things they are doing. Now they are also doing automatic. That is the basic thing.
Yeah. Dr. Dash, how about you?
Madam, I started liposuction with suction assisted liposuction, but for last 10 years I am using micro air power assisted liposuction. Last 10 years. And since last 2 years I am thinking I should give more result to the patient. So I think my next target would be ultrasound assisted liposuction.
Now I want to ask you, you have used micro air for 10 years.
10 years.
I also used it almost for 15 years before the EBDs came. So what were the shortcomings of micro air?
Yes, so micro air is excellent. It is less tiring, it gives good result. But I think if we will add some other devices like ultrasound or...
Good result in what way?
Good result in it reduces the fat, it gives a good contour also. But I think any energy-based devices like ultrasound or radio frequency, it will definitely give an advantage for a better contouring, and so initially I would like to have that ultrasound assisted. I will add first ultrasound assisted, then after 2 years or I will add radio frequency.
So let me share my experience. After using micro air for almost 15 years, I realized that I was giving very good skin contraction to the patients, but I was unable to produce wonderful contours. So that is why I added energy-based devices. Now Sandeep has stuck to his, I am admiring him in fact, that's really good. So how is it that you have been able to give results with a simple suction-assisted liposuction?
Yeah, well, I think I'm a slow learner, so it's taken me long to get good at this. But now that I've done so many, I really know kya struggle hoega, where it's tough and where it's not. So it's probably, I put it down to experience, that I know how much I can deliver, what I can deliver, number one. Number two, I don't have that high volume that I need to do 2 or 3 cases in a day.
So this is also one important point, that cost of the devices is so high that it should be sustainable in one's practice.
Because I was calculating that it will cost me around 20 liposuction I have to do free to be able to afford that.
Understand.
Yeah,
yes.
so that you have to have that many volume ke utna sab main free karunga before I start getting that. That's number 2. Number 3 was the satisfaction factor of my patients. I get patients who want good results. I don't get patients who demand कि आप ये use करो, वो use करो, कैसे कर रहे हो, क्या कर रहे हो. Many I find almost 20%, 30%, they finish the consultation before I start showing them my before after.
Correct, correct.
They don't want to see
Many of them, yeah, even I have the same
20-30%,
experience.
I don't not all, but 20-30% will say, "No, sir, ठीक है."
Yeah,
They feel embarrassed.
We trust you.
Okay,
Yeah.
we trust you.
Correct.
And many of them come, and the few who come, many don't come with their husband. The few who come with their husband don't want to see,
Correct. They don't want to see the ladies' photographs.
photographs ऐसा करके, so they are okay with it. So that is the scenario which I have at the moment. Yes, on the flip side, yes, I've got people inquiring, आपके Bbsr है? तो मैंने कहा नहीं है पर तो phone काट दिया. So that kind of, so there are Bbsr shoppers, or there are, whatever, they believe that that is going to work. Unlike, it's like people who come, मेरे को liposuction कराना है. But क्या कराना है वो कर देंगे आपको, पर let's first talk about it. So if they don't hear the answer liposuction, they don't want anything to do. So I get, probably I'm missing out on those. So I feel the budget,
Right.
why unnecessary add burden, why adds more stress, and I'm getting good results, and I'm able to point out where I struggle. So I work harder at that point. And the third point is, which I've seen, which initially put me off, was I saw certain complications. And I think that complication is like, okay, we all have to admit most plastic surgeons are multitasking.
Correct.
They're on the phone while they're operating, they're doing this while they're doing that, giving instruction, all that. So with manual liposuction, if you do, if there's a result, the minute you stop, it will go. That you can hold it and it will just empty out that area. So I have seen that happening. And many end hits have also happened, many burns have also happened because of this. So it is because of the casualness of the surgeon, not because of the lack of ability or the dedication or the skill of the surgeon. So those complications are also going to be avoided. So that was sort of in balance why I haven't. And to be honest, if there would be a suction machine available on rent, right, I would incorporate in my practice, because that will give me the option of choosing both.
Correct.
Because I find that whenever you have a new device, you want to find an indication for that all the time. So I feel people who have it are using it because they have it, not because they have the option. It's like if you have a car, you'll never take out your scooter or your cycle, even if it is only half a kilometer away. So that is my sort of simple explanation to what you think.
So Rajat, Dr. Sandeep has said that person who has the device uses it. Is it true?
Of course. If your car does not know how to go gearless, automatic car you don't have, you will not use it, right?
Correct.
So since I have the device in my office and I don't have it available on rent. Now understand, if the device is available on rent and I get it on rent for a particular surgery, I have this in mind, I have spent 40,000, 25,000 more. I will try to charge my patient more.
Correct.
Now since I have it in my operation theatre, if I think that this device addition will improve the result even by 0.5%, I will use it. Because my concept is it's not patient's result, it is my result. I will like to use that tool even if that patient will not pay me extra, nothing mind. So any device you use, actually you do not increase your charges. It does not happen that way.
Correct.
Sometimes you just add the tool to improve your results.
But then do you put it in their own perspective, or do you use it on everyone?
We don't use it on
Supposing a 20-year-old comes to you with very little fat, like how Western doctors show their contouring patients for contouring, would you use?
So I would use Bbsr and power assisted for that. I would not use body tight for that, because I think that the skin is shrinking. I would not use body tight left, right, center for type grade 2 gynecomastia, where the skin is tightening enough. So you use it judiciously.
Correct.
But you also use it for patients who need it. And sometimes you think, if I ask patient about the cost, he will not pay it, but I'll do it because it will improve his
You
result.
feel you are giving a better result. So you said you use the machines very judiciously, but that comes only when you have had some experience. And experience is always when something bad happens, you learn from that. So you learn more from your mistakes than from your success. So how about the learning curve in using these energy-based devices?
There is a learning curve. You can reduce the learning curve by visiting centers where they use these surgeries. Be slow, be cautious. But I've had my share of Bbsr burns as well. I've had to treat those patients. I'm still treating one patient since last few years because she's unhappy, I'm unhappy, but this is what it is. Once a burn, it's a burn, right? You will have to revise it. So you have had such cases. But with anything in life, there will be some good things and bad things. Life, wife, anything, right? So there will be some bad, good things. So you have
wife is always good, remember. I am the moderator, so wife is always good.
So, yeah, but you move over them, improve, and then make sure that you get only the good things and less of bad things.
Correct. So basically, anyone who wants to incorporate energy-based device in their practice, you have to consider the cost, you have to consider the learning curve, and the various ways in which you can employ it. Dr. Giri, supposing you had to buy one energy-based device with unlimited budget, so would you go for ultrasound-based or radio frequency-based after seeing today's sessions?
I would go gradually because we are usually conversant with manual, so we'll first go for ultrasound assisted liposuction. Then after that radio frequency. I would go gradually. I think that is the best way of learning. And if required something like that, because we, according to the patients, we have to. Otherwise, what will happen? These types of patients we are not getting in government setups. We are mostly getting this gynecomastia. And abdominoplasty is also very less patients coming. So mostly we get gynecomastia patients. So I think we will go for ultrasound assisted.
Dr. Dash, there are many patients nowadays who don't want scar. Quite at least 15 to 20% of the patients, they say even if the result is compromised, we don't care, but we don't want scar. So in such situation, if you don't have energy-based device, what would you do? Would you let those patients go, or would you invest in an energy-based device, use it?
So it's very difficult to give a very good contouring if there is a protuberant abdomen, loose skin, unless until you do the abdominoplasty or do energy-based devices. So it's very difficult to give a very good contour. And the patient does not want scar. Then obviously I would like to use some energy-based device. And I will give her the option. Suppose if she is in a hurry, then that's okay. Otherwise, then I will definitely invest in one energy-based device because I want to give the good result.
Correct. So it depends on the number of inquiries, type of patients you are getting, and the types of demands that are being created by the patients. So coming to Dr. Sandeep, in radio frequency also there are multiple different tools. So supposing you have to incorporate anything in your practice, how would you decide? Supposing you have to buy an energy-based device, what will be your strategy of thinking apart from patient demands?
You mean non-surgical and surgical? I mean, meaning,
How
invasive
will you
and
go about, supposing I have to buy a device, I did something.
Right.
So what is it that you will do? What research you will do before buying an energy-based device?
He will call us.
Let him say that.
Yeah, see, basically, there are what I would be looking at is obviously skin contraction and the ease of delivering the result. That's what people are looking at.
Actually, this is a question for very junior people.
Yeah. Correct.
So that
how
to think about it.
No, true. So, no, I'm also still thinking. So, so right person. Yeah. So basically, I'd be looking at both things in terms of skin contraction, because skin contraction takes some time and it can be unpredictable. So I'll be looking at which machine is going to be more predictable with skin contraction. So that is the only way to kind of be sure that I will get something better than what we are getting as a routine. So again, so it basically means...
So maybe you will go through various papers.
That's right. Correct. So various papers, and also I also realized that just because somebody gives a name to a technology, every company is not the same.
Correct.
So the quality of delivery of the energy also becomes very important.
So it should
The
be
stability,
approved
yeah, the
machine.
stability of the current, consistency, all those things matter. So that is a second thing, once I have decided which one do I want, that I would do. Second, I would want the same thing should be applicable to more than one area.
Correct.
So, whether I can use it on the face and the body or not, rather than just the
Yes.
body. Because that has, I can use it multiple places, and, how many things do you put in the OT, even if you have got money? Managing and maintaining things are also. Third, I would see is then what is the after-sales service or availability of parts.
Absolutely. That is
Because,
extremely important.
Because, because no point in having a Ferrari and I can't get a spare tire for it.
Correct.
So,
correct.
so that
Garage should be there to service the Ferrari and maintain it. So Schumacher can't do anything if there is no service center.
Exactly. So that is the other important thing which I would want to have. And apart from that, where else I can use it? As Rajat was saying, if you have it yourself, I mean, Rajat worded it differently. I would, even if I needed it, tomorrow if I were to hire, I would not jack up my charges.
Correct.
Because it will be split across my last 5 cases. So, but what he means actually is, because he has it, he is able to expand its potential uses.
Correct.
So he's able to do things and maybe find out something new which others may not be able to do it. So that is how it's going to help him more by owning it as opposed to that. So so what are its other potential uses that gives us, so whether there's creativity allowed with that technology or not, that sort of...
Maybe for junior people who have not yet started, they can pool resources, make a single center where 3-4 people are working together, sharing the investment, sharing the maintenance and providing a good service.
I'll tell you why. One of the reasons why I've been very wary about new technology often is that, there were few instances where I was, privy to how things went. Like when CO2 laser first came out, Coherent was the company. They, in the West, they sold it like nobody's business.
Yes.
If you don't have laser, why are you a plastic surgeon?
Correct.
Itna karke. So everybody bought it, and they realized very soon that its uses are limited only. But they had to be seen to be doing it. Fortunately, there was no Instagram, so they would be recorded forever.
Correct.
But they showed off that they did for everything, and I know they did not use it.
Correct.
Because they were scared, because side effects you only have to look after. So once finally somebody started telling, but it was 5 years later, okay, there are so many complications, that when people sort of use it only for limited.
Absolutely.
So that's what worries you. That's why I'm not very keen to be unless you are the inventor, you don't want to rush in.
Correct. Yes. So we should also remember that most of these gadgets, they are tested on Western skin and Western patients, and then they are brought to India. So how they interact with our skin? One simple example I always give, that our type of patients from southern India, they interact very badly with American sunscreens like Neutrogena, Lotus, and they come with pigmentation problem. So similarly, some of the energy-based devices, their energies have to be used at different parameters when we are using on our patients. So Rajat, now I want to ask you whether you have seen any different and new type of complications in your practice when you added the EBDs in the early phase. Maybe now once you start using it judiciously, you finally reduce the rate of complications. But did you see any new complications or some exaggerated complications?
Two. One is some patients had severe neuralgic pain.
Yes.
So especially with Bbsr.
Radio.
Okay. So you said radio frequency with Bbsr also.
Both I would say.
So because, as I said, it is liposelective. So there is a theory that there are fat cells covering the myelin sheath as well. So if you injure that, patients have severe neuralgia. I've had patients who had to take pregabalin for weeks together because they had severe neuralgia. So that's one unique complication I saw. And I'll tell you how I've reduced that rate also. And the second complications, which I didn't see that much, but a lot of people complain, is more seroma after using of energy-based devices. So when you use one energy-based device, you tend to use it a lot. Means it is, to give you a perspective, it is said, do Bbsr for 1 minute for every 100 ml of saline put. If you're using that, then their chances of complications, I think, is slightly more. So since I have multiple technologies, instead of using it for 1 minute, I on an average use it for something around 20 to 30 seconds only.
Correct.
So we don't rely on one thing only and overdo it. Similarly with radio frequency. And I also know that I have power assisted to suction out. I'm not doing a manual suctioning. So the amount of energy which I'm using with these tools is slightly less.
Correct.
If I would have been using them as a standalone, since I'm combining them. And hence the incidence of these complications are now very less.
Correct. So you have to change your surgical protocols when you have incorporated energy-based devices in the practice. My personal experience with energy-based devices, because I am doing toilet liposuction, not too many seromas, but there is a capillary dilatation leading to third space loss and hemoglobin drops on the 4th day. So I started doing CBC on 4th day, and if required, give IV iron or iron supplements. So we have to, whenever we have to add, we have to do research on every front. We have to expect a learning curve, and we should be ready to observe what is happening. We should not just blindly use the device. And as Rajat said, they are definitely good marketing tools, but the same tools will turn towards you if you start giving bad results with injudicious use of these technologies. I think that should be. Thank you. Yes, sir.
Madam, it is a very nice panel discussion. In my experience of 30 years, I have seen 20 years back, most of the government hospital I was working in SC Medical College, we didn't have a microscope, nothing of the kind. Now, all institutions, all over the country, I find microscope is there, with the micro instruments and everything. How it comes our way, that it depends on the department, the HOD, and how he pursues the government. I think it is a training where every training should be given, especially for aesthetic surgery. All the government setups, let it be a center of excellence like Ames or medical colleges, should have these devices.
Correct.
Otherwise, where you get...
Totally agree with you.
I am telling you one thing happens, the students are not trained within 3 years.
Yeah, yes.
So what happens suddenly when they go for any individual solo practice, they are sudden after a complication that not like Dr. Rajat Gupta or like Dr. Sharma. So it takes time. The learning curves is very stiff for those people.
Absolutely.
But if you commit a complication in the hospital or in a government setup, the complication is taken over by the senior. Because he is under the...
So backup available.
Backup available.
Correct.
So he will not get it when you go to the practice. So I think...
But same backup Iaaps is trying to provide. We have this complication cell. So if you have any complication, you can talk to them, get
It is a very nice
opinion
forum
from the expert.
And secondly, one of our medical colleges, who is a new one, started with MCH, Berhampur. They got a laser. So what I mean to say, government do not have any restriction or constraint of money.
Correct.
It is up to you to convince the government and get the money.
Yes.
Even Dr. Giri is there. He is my
Yeah,
student.
we should be after
So he
Dr.
should,
Giri
after,
to buy the devices.
Now I tell you, all these free flash microscopes, when I told the government, no, these are not required. Then I told it is required for free flash for burn patients.
Correct.
Then told is okay, no problem. So you have to highlight the government how to get.
Correct.
And I think all the devices what you have shown,
Yes.
by the 3 years completion of MCH, all students should be conversant. They may not have the opportunity of independently doing it, but on supervision and with their experience, I think that will be a big boost to them when they go pass out. Because I remember in one of the meeting in Bangalore, one person told in that meeting that in Bombay I passed MCH, I have never done a clay palette. In front of the teachers, I think you may be there.
Yes.
So if somebody get a MCH and passing out without knowing about the liposuction, we have a manual liposuction for 5 years.
Correct. Yeah.
But I think all these devices are not very costly, which cannot afford.
Yeah.
No, no, sir,
Sure,
they're
sir.
very costly.
You want to ask?
Government can afford it. There is no problem in government, I tell you.
Dr. Sanjay.
Yeah.
The health budget has gone from 2% to now it is to 5%.
Correct.
And state budgets have also increased. Now it will depend. You don't get in one time everything. But try like Dr. Giri has told.
Yes.
One step by step you get things. And this is possible and special needed for the trainees.
Correct. Correct.
Unless they
sir.
are exposed, I tell you, when they pass out, after 5 years you find
Yes, sir, I totally agree
these
with you.
equipments will be advanced much more.
Yeah. I think I would like to thank you, sir. Thank my panelists. Thank you very much.
Thank you, ma'am. Thank you, sirs, for the wonderful panel discussion. Now we would begin the felicitation ceremony. We have our national faculty who traveled more than 1,500 kilometers and leaving their practices aside. And thank you, sir and ma'ams, for so wonderful discussion and a wonderful time being spent with us. So good evening. We have our felicitation ceremony. I would like to invite Dr. Arun Chaudhary, sir, to felicitate Dr. Sandeep Sarma, sir. Felicitate करेंगे, sir. Thank you, sir. Next, I would like to request Dr. Akshay Raut, sir, to come over here and felicitate Dr. Medha, ma'am. Now I'd request all our plastic surgeons to come over here and join our guests for a group photo. Everyone, please come over here.
First of all, I am thankful to our faculties, Sandeep Sarma sir and Medha Bhabe madam and Rajat Gupta, who has come from such a long distance. I think it was a brainchild of our Jayan Das. He has already planned it from A Search that we are going to do this one, because last year we have done in the month of July, and that was also very successful one. And from that, he has kept in his mind that we will do this one in the next July, from that day last year. And and also thank you Iaaps for electing Dr. Jayant as EC member. On behalf of Apraso, we are giving a lot of input to that, so that he can convey to the Iaaps executives. And next, I am thankful to our president, Lakshmi sir, who has given a lot of inputs how to do it and when to do, what to do, at what time. Then I'm also thankful to all the esteemed members of Apraso, and especially thanks to Arun sir, who is there from being a senior member and being always guided to us what should be done and what should not be done like this. He always gives us at what time we should do. So, and totally I think we have gained a lot of things, because aesthetics in this part is a little bit of less, and hope this knowledge will help us and also to the many of our residents who are present from SCB, AIMS and MKCG. MKCG we have started new MCH course, so they have also there. And from SOM Hospital, they have also the new MCH course started. These are the medical colleges where new MCH course has been started. So they have always there here. I think this knowledge will help them to boost for their future. And also to all the members who will definitely be geared up by this one. And thank you again from our core of hearts to all these 3 members who has come from long distance. Thank you. And I will invite all of you for the dinner. I forgot. Audio visual, of course, audio visual and hotel, they are all part of we have done here 3 to 4 times all our conferences. Although there are some glitches in the audio visual. Yeah. Trade people. And thanks to the trade people, they have given in a short span, they have helped us, without which this event is not possible. And also to management of hotel is a part of our because we are doing it regularly. So management of hotel, they never wants. They want that you do always. So thank you. No one is there from, I think, that is Padmaja Hotel is always associated with us. Whatever we have financial, they help us in different way. So that makes us also a little bit of easy to do all those things. So thank you everyone, and you can all join for the dinner.